enlightening talk for the next 15 to 20 minutes. Over to you.
So Dr. Purvi left.
I'm sorry for the technical glitch. I think, can you somebody call her and figure out? Probably she has got a connection issue.
Yes, sir. We are figuring it out, sir. There is a small connectivity issue. Dr. Purvi will join soon. Please wait.
Different computers, so I just need 1 minute to get the slides. for this technical hitch. I don't know what happened and what went wrong, but we've switched to another computer.
Yeah, please, Purvi, carry on. I have already did the introduction.
Yes, thank you, sir, for that. Okay, so injectables with low risk of hypoglycemia, and I will not dwell upon too much of perspective on hypoglycemia, but I think something needs to be said as to why we are looking at injectable therapies in diabetes care with low risk of hypoglycemia. So when we consider our clinical considerations besides glycemic lowering, importantly considers hypoglycemia as one of as an important factor in deciding the treatment for our type 2 diabetic patients. And we know hypoglycemia is nothing but abnormally low blood glucose levels, level 1 less than 70, level 2 less than 54 milligrams per DL, and level 3 roughly is cognitive impairment that requires a third person to rescue. So consequences of hypoglycemia, complex, varied, include cognitive dysfunction, even coma and seizures, falls, accidents, cardiac implications, as well as inflammation, to name the least. And the outcomes of social outcomes may include that complete fear of hypoglycemia in our patients because of the extremely poor quality of care with repeated episodes. So this again, an SMB, a CGM graph showing us that the more the glycemic variability, the more experience of hypoglycemia. Again, looking at the fasting glycemic variability itself, that increases the risk of hypoglycemia, MACE, and all-cause mortality, as indicated by the dark blue rods, which are severe or the highest fasting glycemic variability. With that, I want to highlight that hypoglycemia in the first 3 months is an important predictor after you start basal insulin therapy, is an important predictor of long-term hypoglycemic risk as well. And overall, the all-cause death following a severe hypoglycemic effect or event has also been seen to be much higher with repeated episodes. So overall, if we want to transition to injectable therapy or maintain patient adherence, one of the most important factors to consider is alleviating the fear of hypoglycemia in the physician as well as the patient, because that's an important barrier. With that, I want to just bring to your notice that an injectable, effective and safe with low hypoglycemic risk will definitely support initiation and titration and enable us to reach and maintain glycemic targets with favorable long-term outcomes. So with that, I introduce the injectable therapies in diabetes that we have today, right from basal insulin to prandial insulins to premix to formulations, co-formulations, and then GLP-1 receptor agonists and even amylin analogs. And right from and this, if you see, is the evolving profile of basal insulins, right from the older NPH with a relatively shorter duration of action with a tall peak, to the later basal insulin analogs that were discovered and developed, glargine U100 and tetamine. And as you can see that with progressive development on the basal insulin analog front, we have more longer lasting profiles and flatter acting profiles. So that eliminates or reduces the risk of hypoglycemia. It does not eliminate, but definitely reduces our risk of hypoglycemia with these newer agents, particularly glargine U300 and degludec. Looking at the premix as compared to basal insulin, of course, we got better control with premix insulins, whether the biphasic human insulin or the biphasic analogs, and then include the co-formulations, insulin, degludec and aspart. Initially, we had a lot of hypoglycemia, particularly due to the rapid acting insulin component in the premixes, but that got slightly better with the premixes, the analogs, and then even improved with the co-formulation. And that has definitely improved the uptake of injectable therapy in patients. Now we shift from the insulins and look at the non-insulin injectable landscape, and that has the GLP-1 receptor agonist or the glucagon-like peptide 1 receptor agonist that vary in molecular structure and size is given here. They are important agents today as they have changed the paradigm of diabetes treatment from our simple focus to glycemic lowering to many more pleiotropic benefits, and I'll show you in the next slide. So these are either human GLP-1 based therapies or the exending based therapies, and these are part of the incretin therapies that we have today. Predominantly, we are using either the once daily liraglutide or the once weekly dulaglutide, and yet to be introduced semaglutide in India, the oral as well as the injectable forms. If you see, GLP-1 receptor agonists are important, and like I mentioned, they changed the paradigm of treating type 2 diabetes as they had a multi-pronged approach to attack diabetes. Whether it was impaired insulin secretion that they corrected, or even enhanced glucagon secretion, or decrease the hepatic glucose production. But importantly, they had the central effects on appetite regulation also and caused a modest amount of weight loss with that. So among the other key factors, like I mentioned, HbA1c lowering and put benefits in weight loss. The important and striking feature with GLP-1 receptor agonist is hypoglycemia and the low potential of hypoglycemia with the same. Even though there are some adverse GI effects, I think by and large the low potential for hypoglycemia make them a very attractive choice for therapy. We also have the combinations of GLP-1 receptor agonists and insulin fixed ratio combinations in the form of ideglira and iglar-lixi. These are considered by some physicians as the most optimal or the most advantageous injectable therapies today. They have the component of basal insulin plus improve the postprandial control also with the GLP-1 in it. Now we focus on the injectables with low risk of hypoglycemia and the evidence with it. So if we review the evidence with basal insulin, I just want to quote one trial here which was switch 2, which compared Degludec given once daily with glargine U100, and halfway down the trial, the patients were switched to the opposing therapy. So those on Degludec got glargine U100, and those on glargine got Degludec. When the entire trial was analyzed, and we saw the rates of overall symptomatic hypoglycemia or the nocturnal symptomatic hypoglycemia or even severe hypoglycemia, all these clearly favored the use of Degludec as compared to glargine U100. So that did reduce the overall incidence of hypoglycemia. Now we look at a slightly different design, the DEVOTE study, where Degludec again was compared with glargine U100 in patients with high CV risk as part of the cardiovascular outcome trial. And what did that show us? First of all, it confirmed the CV safety of Degludec and glargine, and clearly the rates of nocturnal severe hypoglycemia and severe hypoglycemia, as you can see in the boxes with blue, with the dark blue lines, clearly the rate of these two types of hypoglycemia is much lower with insulin Degludec as compared to glargine U100. So this was the outcome of the DEVOTE trial with focus on hypoglycemia. So again, some favoring the newer insulin. When we look at glargine 300, and that was compared with glargine U100, look at what we got in terms of the hypoglycemic rates. So the addition trial, that was a phase 3 program of glargine 300, where they compared it effectively with glargine 100, and whether it was hypoglycemia throughout the day or in particular nocturnal hypoglycemia, you can see that the rate is much lower with U300 as compared to glargine 100. And whether it was the initial titration phase, the first 8 weeks of the trial, or the latter maintenance phase also, we can see that clearly glargine 300 glargine 300 had much lower rate of hypoglycemia as compared to U100. Now, what's the evidence with new generation co-formulation insulins? I call them the designer insulins. And this is in particular an interesting study, the Boost Japan study in insulin naive patients, where IDAGASP was initiated as compared to glargine U100, and they found that 27% reduction with low overall confirmed hypoglycemia was seen with IDAGAS, and 25% reduction in the nocturnal confirmed hypoglycemia in these patients as compared to with IDAGAS as compared to glargine U100. The lower blue lines are the IDAGAS arms. With the similar comparison, but in patients with type 2 diabetes, where IDAGAS was given once daily, and compared with glargine U100 with an aspart, and initially in the treatment initiation phase, and then later on progressing to intensification with IDAGAS given twice daily, and compared to increasing addition of the aspart to the glargine U100 and aspart OD regimen, to basal bolus regimen, complete basal bolus regimen, and let's see what we found there. So here we found that even at 26 weeks, there was a 45% lower rate of nocturnal confirmed hypoglycemia with IDAGAS as compared to glargine U100 and the aspartame. And then at the end of 38 weeks also, there was a significant reduction. That reduction in nocturnal hypoglycemia was well maintained. Now we focus on the evidence with GLP-1, and I'll quickly review that as well. When a meta-analysis was conducted with comparing GLP-1s with insulins, whether it was basal, pre-mixed, or bolus, we found that the risk over and above the metformin and sulfonyl urea agents used in both arms effectively, the rate of hypoglycemia was the lowest with GLP-1 receptor agonists. That increased progressively with basal insulin pre-mixed and was the highest with bolus insulin, as we know clinically. So this analysis just confirmed what we saw clinically.
Excuse me, ma'am, your session will end in 2 minutes.
Yeah, give me just 5 minutes, I'll complete this.
2 minutes, ma'am, 2 minutes.
Okay, so similarly, a meta-analysis by comparing the short and long-acting GLP-1s with basal insulin also favored GLP-1, and especially the long-acting ones with respect to lowered hypoglycemia. Liraglutide once daily, this was the entire lead program summary. Total and severe hypoglycemic rates were much lower than the other arms. Dulaglutide once daily was also compared in so many regimens with so many different drugs, and we found that the incidence and rate of hypoglycemia was similar with dulaglutide and other non-secretagogue active comparators, while the concomitant use of glimepiride, glargine, or aspart or lispro did increase the rate of hypoglycemia in the dulaglutide. Semaglutide is yet to be introduced in India, but again, you can see the rates of total and severe hypoglycemia much lower. And similarly, we saw a similar trend with idaglida as well. So overall, the reductions in body weight and less hypoglycemia are associated with improved adherence to anti-diabetic medications, and this has been studied over and over again. And what do our guidelines say? Again, they focus on hypoglycemia as an important consideration in our choice of anti-diabetic agents for our patients, and GLP-1 receptor agonists definitely are highlighted there in compelling need to minimize hypoglycemia.
Thank you, doctor. Thank you very much. And
with that, I thank you for this patient hearing. Sorry for the technical lag, and I just want to conclude that thus we have a whole range of injectable agents, and I described the ones with the lowest range of lowest rate of hypoglycemia that we can offer to our patients.
Thank you
so much.
Very much, Dr. Purvi. We would sincerely apologize for the technical delay in the beginning, and I am afraid that we don't have time for the question. So I think
Thank you, sir. Thank you, sir. For the next session, I'm inviting the chair, Dr. Arun Shankar, sir. He is a medical director and senior consultant diabetologist at JYOTHYDEV Diabetic Center, Tirunelveli. Dr. Arun, sir.
Good morning. Am I audible?
Yes, sir. Yes, sir.
Yeah. So this is our second day of Jpef 2020, and I'm so delighted that I have got the chance to introduce one of our dear friends from Egypt.
Excuse me, Dr. Beena Chandran, madam. Purvi Chalo, madam, please stop the presentation.
I have already done that.
Yeah. So so it's with great pleasure I'm introducing our next speaker, who is from Egypt, my dear friend, Dr. Hossam Rafa Ghazi. He is the lecturer of internal medicine, Faculty of Medicine at Mansoura University, Egypt. He had completed MD degree in 2017. He is the consultant of diabetes and endocrinology in Mansoura University of Hospitals. He is a member of scientific committee of the International Pan-Arab Diabetes Conference and Arab Diabetes Forum. He is the reviewer for the International Journal of Diabetes for Developing Countries. He is the speaker in almost national diabetes conferences in Egypt, and he has already publications in international and local journals in the field of diabetes and thyroid diseases. Also, he had presented posters in ADA and IDF annual conferences. So we were fortunate to share few moments at our JYOTHYDEV'S Diabetes Center. When he visited us, we worked together at our center. And he's again with us in the second Jpef. Very sad that he couldn't travel and attend the conference here.
Thank you.
With that introduction, I would like to invite.
Good morning, everybody, and thank you, dear friend and my brother Arun, for this great introduction. Today, I will talk about the use of seahorse technology in diabetes. First of all, I would like to thank the organizing committee and Sir Dr. JYOTHYDEV for inviting me for the second time to participate in this conference. And although last year it was a long trip from Egypt to Trivandrum, but I was interested very much, and I wish next year it will be, inshallah, in Trivandrum. This is Egypt, and I live here in Mansoura, which is about 80 kilometers from the north of the Cairo. And this is my Faculty of Medicine, in which I'm acting as a lecturer. And this is my hospital. I'm acting here as a consultant of diabetes. Before I start, I have no conflict of interest, and this is my disclosure. In 2006, there is a company which is invented this apparatus, and this apparatus is called the seahorse apparatus, and it have a technology to study the bioenergetics of the mitochondria. So the story will start in the mitochondria. All of us know that the mitochondria are the core energy metabolism of the cells of the body. It utilizes the fat, sugar, and protein with oxygen, whereby aerobic oxidation, it will release the ATP, which is the main source of energy to the body. In the mitochondria, there are two important processes: utilizing or consumption of the oxygen. The oxygen will enter here to the mitochondria, and it will be utilized as a source of energy. Then it will release the ATP, and on the other side, it will release the proton. So the mitochondrial dysfunction, it is not a new disease. It is established in many years ago. And first, who described this dysfunction in the mitochondria, our colleagues in the neuropsychiatry. It is described in the muscular diseases like myotonia and muscular weakness and chronic fatigue syndrome. It is also described in Huntington's chorea and Alzheimer's disease and Parkinson, cancer, obesity, and recently in type 2 diabetes. And there is already published literature about the dysfunction of the mitochondria from type 2 diabetes and the diabetic nephropathy and neuropathy and some of the neuropsychiatric manifestations. The publication started usually in 2010 and 2011. This is the seahorse apparatus in which we put the cells, This apparatus can utilize and can estimate the oxygen consumption rate, in which how many oxygen molecules that mitochondria of these cells are using. Then it can consume and can estimate the extracellular acidification rate, which is called the ECAR. So we have two important ratios. This apparatus can prescribe it in a real time. In every second, in a real time curves, it can describe how much this mitochondria in this cell take and consume oxygen and how much of protein can release. So when we compare it by the normal, we can know and we can estimate what is the abnormality in these patients and these cells. Usually the cells, we are taking a blood sample. Usually it is the polymorph or the T cell lymphocytes, but it may be the beta cell, maybe the muscle cells, maybe the liver cells in animal studies. We put it here in this cartridge and put it in the seahorse, and it releases the results, and it can give us a real time about the oxygen consumption rate and the extracellular acidification rate, and we can know where is the abnormality. It uses, this is the cells will be here, and it uses fluorescent sensors to estimate the OCAR and the ECAR, as I told you. And after we know the abnormality in these patients and these cells, and we can know, we can also put a drug which intervene by these mitochondrial cycles. When we know where is the abnormality in the mitochondrial dysfunction, we can put a drug and we can estimate and we can correct and see the effect of this drug on the mitochondrial metabolism and mitochondrial bioenergetics. And actually, last year, I have the chance to attend a scientist training course in Copenhagen, which is sponsored by the ASD for the junior scientists. And it was in Steno Diabetes Center, and I have some handouts about this seahorse technology. It is a very, very, very complicated. This is just superficial information about it. Okay, what's the clinical implication? As most of us are clinicians, what are the clinical implications of this seahorse? This seahorse technology are introducing for us in the next few months or maybe 1 or 2 years, the new classes of anti-diabetic medication, which is the glimins. The first one of them are the imiglimin, which I'm talking in the next few minutes. But when we remember 30 years ago, when Ralph DeFronzo described that type 2 diabetes is having the problem in these three things, which is the impaired insulin secretion, which will lead to increased hepatic glucose production and insulin resistance on the muscle, so it will lead to decreased muscular uptake of the glucose. And at that time, there was two questions. The first question is mitochondria is a cause or results from insulin resistance? At that time, we do not know. And also, is mitochondria is linked and responsible for the lipotoxicity or no? Imiglimin, which is the first drug in this family, will lead to correction of this abnormality. Imiglimin decrease the hepatic gluconeogenesis, increase the muscle uptake of the glucose by improving the insulin sensitivity, and also increase the insulin secretion. When we remember from the biochemistry, from the basic science, this is the mitochondrial respiratory chain. It have 5 complexes, complex 1, 2, 3, 4, 5. By the seahorse technology, we know that patient with type 2 diabetes, even before the starting of the diabetes, even in the pre-diabetes, even in their relatives without development of diabetes, they have this problem. They have overactivation of complex 1, this complex 1, and underactivation of complex 2. This will lead to insufficient insulin secretion, insulin resistance on the muscle and the liver. This will impair and accumulate of the reactive oxygen species inside the mitochondria, so it will lead to beta cell dysfunction and death in the pancreas, and outside the pancreas it may lead to endothelial dysfunction and vasculitis, and all of us know that the diabetes is a cardiovascular disease. By the imiglimin, we can correct this problem in the mitochondria. We can inhibit the complex 1 activity, which is overactivated, and we can restore the complex 2 activity, which is underactivated. This will correct the abnormality in a patient with type 2 diabetes. This will lead to decrease the reactive oxygen species, so protecting the mitochondria and the extra pancreatic cardiovascular endothelial dysfunction from the oxidative stress. And also, this will lead to improvement of the insulin secretion in a glucose-dependent manner. So imiglamin, from one of its action, is increasing the glucose as a response to hyperglycemia, but in a glucose-dependent manner, like the incretin-based therapy, DPP-4 and GLP-1 agonist. And also, it improves the insulin sensitivity in the muscle and the liver, which is sharing the action of the pioglitazone and some action of the metformin. And also, it improves endothelial dysfunction and diastolic dysfunction. And it increased the molecule, which is called BGC1 alpha, which is increasing the number of the mitochondria. So it will increase the ATP production inside the pancreas of the diabetic patient. This drug started phase 1 in 2015. It is a Japanese drug. It is performed by Poxel company. This drug seems to be very good and giving promising results. It is an oral drug, twice daily. It have a 3 concentration, 500 milligram, 1000 milligram, 1500 milligram. It's taken twice daily. Very low hepatic metabolism, excreted by the kidney and modified with the GFR. No drug-to-drug interaction with the metformin and sitagliptin. No QT interval. And the PK not difference from the Japanese to other Caucasian, and it is not related to food. And after phase 2 was completed, it seems the drug is a very safe, up to 6,000 to 8,000 milligram per day, with a minor or minimal GIT side effect like the metformin, nausea and diarrhea and abdominal discomfort. And it seems weight neutral, not increasing the weight like the DPP-4, and it have no effect on the lipid profile or the blood pressure. And the good things, it is an effective drug. It have a lowering from the baseline by the dose 500 milligram up to from 0.5 to 1,000 milligram, 1,000 gram reduction in the A1C. And the good thing that there is the severe hypoglycemia was nearly to be 0. We are waiting for this drug in the next next year or maybe the year after it, and it seems to be promising drug. Mr. Chairman, dear colleague Arun, and dear audience, I want to end my presentation by this take-home message. Seahorse technology is a novel technology to assess the bioenergetics of the mitochondria. Imiglamin is the first class and the first drug in this family, which is acting by reversing the abnormality in the mitochondria of the type 2 diabetes. It enhances the flux by improving complex 2 and decreasing complex 1 activity. So it will augment the ATP inside the mitochondria and increase the mitochondrial number. Clinically, it has the action of 3 major drugs. It increased the insulin secretion in a glucose-dependent manner, sharing with the DPP-4, improve the insulin resistance in the muscle and liver, sharing with pioglitazone and metformin, and decreasing the hepatic glucose production. Imiglamin seems to be safe and tolerable for most of the patients with a minor GIT side effect on the highest dose. It is neutral in weight, neutral in blood pressure, neutral in lipid profile. And finally, it is an effective drug with a reduction of the A1C from baseline 8 up to 0.5 to 1 gram percent. Thank you, dear Arun, and thank you for audience. And I thank you for the organizing committee. And I wish you visit Egypt, and next year, inshallah, I will seeing you in Trivandrum. Thank you.
Thank you very much, sir. Moving on to the next session, I would like to introduce the chair, Dr. Rajalakshmi S., diabetologist and podiatrist at Waynard Hospital, Nirmangat. Welcome, doctor.
Yes, can you hear me? Hello.
Yes, ma'am. Yes, ma'am.
Yeah.
Continue.
Yeah. Good morning, everybody. At the outset, I thank Dr. JyOTHYDEV and his team for giving me an opportunity to share this section. And also, I congratulate this team for conducting a wonderful conference, and we all are enjoying it. Okay, so people with diabetes face a lot of problems while managing day-to-day life activity, and also in traveling, whether they travel in station, outstation, or by whatever their mode of travel they take, either from time zone to different time zone, they have to face a lot of problems. So today we have Dr. Ravindran to talk on management of diabetics in travelers. So I introduce Dr. Ravindran. He is an alumnus of Government Medical College, Kozhikode, and KIMS Humuli. He has worked as Assistant Professor of Medicine in Kozhikode Medical College, Kottayam Medical College, and Manjeri. Currently, he is working as a specialist in internal medicine at Sama, Barka, Sultanate of Oman. To his credit, he has 25 articles in various journals, and both national and international journals, and more than 100 health educational magazines he has in his credit. And I invite Dr. Ravindran. Over to you, sir. Is not that? Hello?
Am I audible?
Yes, sir.
Yeah.
Thank you very much, madam, for your nice words of introduction. First of all, I would like to thank JYOTHYDEV sir and his team for giving me an opportunity to present the topic. Going to the topic proper. Management of diabetes in travelers. I hope the slides are seen.
Yes, sir. Continue. Yes, sir.
Okay, thank you. So I'll be dealing under the following headings: introduction, factors influencing travel, preparations, driving and diabetes, and conclusion. As you all know, traveling is accompanied by various experiences and disturbance of routine lifestyles, especially long distance travel. An individual with diabetes may particularly vulnerable to emotional and physical stress associated with traveling. So diabetes is largely a self-managed disease with unfamiliar circumstances. Patients with diabetes may face unique challenge in caring for their diabetes. So patients with either type 1 or type 2 diabetes can travel safely if appropriate self-management skills are and adequate preparation is there. So what are the factors we should consider in people with diabetes while traveling? We have to consider the factors related to travel and the disease status, that is diabetes status. So what are the factors related to travel? Like duration. Short duration travel is safer compared to long duration, and the type of travel, like walking, by road, by train, air, or by sea. And driving is also an important factor. And about the diabetes, we have to assess the risk of hypoglycemia and severe hyperglycemia leading to various complications, the medication the patient is already using, and if there is any complication or not. So the management of diabetes in travelers, we can divide into 3 stages, that is preparation before travel, during travel, and after reaching the destination. So coming to the preparation before travel, so they should schedule an appointment with the healthcare provider 4 to 6 weeks prior to their trip. It's helpful to assess their glycemic status for the evaluation and review of the risk of travel, discussion of the measures the patient can take to minimize the risk, and to review their diabetes self-management competencies, and meeting a diabetes educator and nutritionist also will help to reinforce the diabetes self-management skills. And they should always carry a letter from the treating physician, and the letter should be in English and in the native language of the country to be visited. It contains the name and other details of the individual, diagnosis, any history of allergy, and prescription regarding the on medicines. Preferably generic names also has to be included. Enough medication has to be there, and emergency glucose supplies and blood testing supplies should be there, and patients medical necessity to carry needles and lancets has to be mentioned in the letter, and in case of emergency the contact number and details also has to be provided. And notify the security agent about the diabetic status of the individual, so that they will allow them to carry special tools for taking insulin, such as syringe and vial, during travel. and they should carry adequate medicines, blood testing supplies, the supplies to treat hypoglycemia like glucose tablets, health insurance card, comfortable shoes, and other protective clothing. And they should pack at least twice the medication that they anticipate, and they should carry it in 2 different places. And they are advised to plan for any delays and advised to check blood sugar frequently to avoid hypoglycemia. And they should carry a comfortable shoe, and all new shoes should be purchased and broken in 2 to 3 weeks before the trip. And they should obtain a medical identification bracelet which states the diagnosis, use of insulin, and any allergies. American Diabetes Association created a diabetic alert card for the patient to carry while traveling, which contain all the details regarding the diagnosis and the treatment, and what has to be done during emergency hypoglycemia or severe hyperglycemia. And those who are using insulin pump should encourage to call the manufacturing company to inquire about loaning a backup pump for international travel. And they should record all the pump settings like basal rates, insulin sensitivity, etc. And they should arrange an alternative insulin method like pen or vials. And they have to carry that along with them in case the pump fails. And they should call their medical insurance company and review their medical coverage policies during travel. And they should confirm their immunization status, which they can, and they should do the necessary vaccination for the region of travel, which they can find out from the CDC sites. This is the website showing information for the travelers and for the clinician. Coming to the management of diabetes during travel, first in the airport security checking, the diabetes travelers should check their pump or continuous glucose monitoring equipment companies regarding the recommendation of exposure to radiation. Most of the pumps and CGM company allow the passage of their equipment through metal detector, but not through an X-ray machine or body scanner which use X-ray machines. And insulin also should not be exposed to X-ray. And whenever traveling by plane, leave the insulin in the not to leave the insulin in the loading part and carry with the passenger, because it will help in the easier accessibility while traveling, avoid medication and supplies getting lost in unrecoverable stage, and in the cabin there will not be any extremes of temperature, but which can be there in luggage compartments. The next issue during travel is, as we are flying at a height, we are exposed to hypobaric condition, and the cabin pressure is 0.75 atmospheric pressure, which is about 75% of the pressure measured at sea level. And at every 100 feet, elevation results in 1 to 2% underestimation of blood glucose with the glucometer. So the glucometer will be showing falsely low value during travel. It's not only during travel. Some cities are at high altitude like Mexico, where if you are visiting to such city, there also the same issue can occur. The glucometer may be showing falsely low blood sugar value. And about the diet, food option for diabetic travelers may be limited during travel, especially during air travel, and they have to plan accordingly. And when they are traveling long distance, they will be crossing more time zones. And as a general rule of thumb, a change of 15 degrees of longitude should result in a difference of 1 hour. And the time zone you can find out from this website, timeanddate.com, where you can see the time zone of different areas in the world map. And if you are traveling towards north or south, you can see that there is no change in the time zone, so there is no change in the duration of the day. But when you are traveling to west, there will be change in the time zone and the days will become longer. Whereas if you are traveling to east, the days will become shorter, and you have to modify the insulin dose accordingly. And from the same website, you can see the daylight duration also. So when you are traveling to east, the day is shortened and you have to reduce the insulin dose. And when you are traveling to west, you will be having a longer day and you may require extra doses of insulin. If the time zone change is only for 1 or 2 hours, there is no need to make much changes. But when you are traveling to west direction, the duration increases. You have to take extra amount of insulin and sometimes extra lunch also because of the long day duration. But when you are traveling to east, the duration will be reduced. So you have to reduce the insulin dose by 10%, or you can use the formula travel dose is equal to usual dose into 0.9 minus number of time zones you are crossing divided by 24. And on arrival, they should adhere to the new time of the local area and follow insulin dose accordingly. Those who are on oral medication, the time changes are less crucial and they can most of the time follow their own medication. But those who are taking sulfonylurea, if they are expecting a missing of meal, they should avoid taking sulfonylurea in order to avoid hypoglycemic events. But other drugs like metformin, thiophanidinones, and other drugs are comparatively safe. When you are taking insulin during flight travel, now because of the change in cabin pressure, insulin will not be delivered in the correct amount, and this can also occur for those who are on insulin pump. And it is also important to prevent venous thromboembolism. In order to prevent thromboembolism, you have to walk or move the legs frequently and drink enough water in order to avoid dehydration. Coming to the management of diabetes after reaching the destination, in some countries, the insulin will be available in different strengths, 40, 100 unit per vial, per ml. So you have to use the appropriate correct pre-labeled syringe to use such insulin. Since if you are using wrong syringe, you may deliver more or less insulin than the desired amount. So you should be careful while using the syringes from destination country. Similarly, there can be mismatch in the vial also. Another issue is the blood sugar value is expressed in milligram per deciliter in some countries, whereas in millimole per deciliter in some countries. So when you are communicating the glucose level to healthcare professional, you should be very clear. And to know that before starting traveling, you should know the details, the climate change, everything regarding the destination, so that you can see if it's a hot climate area or cold area, and accordingly you can plan the availability of refrigeration equipments to keep insulin and other medications. Colder environment can potentially damage the diabetic medication, and insulin will be absorbed slowly in colder environment. Coming to the storage of insulin, usually it is stored between 4 to 30 degrees Celsius, but usually the insulin what we are using, we can keep in a cold area, no need to refrigerate always. And you have to identify decayed insulin. The clear insulin, if it turns turbid, or milky insulin, that is NPH insulin, if it turns to granular, it indicates that the insulin is damaged. And before going to the destination place, you have to find out the food available there and plan accordingly. And after traveling to the time zone area, after traveling to the destination place, you can use the local time for adjusting your insulin doses. And you should always use a comfortable footwear and check blood sugar regularly in order to avoid hypoglycemia or severe hyperglycemia. And in very cold climate, the uptake of insulin is lower. In hot climate, it is faster. So that itself can affect your blood sugar value. And if you are sick, you should follow the sick day rule and check the blood sugar frequently, and if you are preferably ketones in the urine also. Coming to driving and diabetes, it's a highly complex task, and those who are exposed to hypoglycemia, it can cause to lead to hypoglycemia related neuroglycopenia that results in increased neurocognitive dysfunction, which can result in impairment in the ability to correct hypoglycemia, leading to severe hypoglycemia. And it can also impair in the visuospatial skills, which are important for driving. What are the potential causes of driving impairment? Acute hypoglycemia, hypoglycemia unawareness, retinopathy, neuropathy, ischemic heart disease, cerebrovascular disease, sleep disorders, use of pain-related...
Excuse me, sir, you have 2 minutes left.
Okay, ma'am. Cognitive dysfunction, unstable coronary heart disease, alcohol and substance abuse, all these can impair with driving. So the medical evaluation should assess the risk of development of hypoglycemia and the complications like retinopathy, neuropathy. And these are the questions usually asked the patients who are driving, like episodes of severe hypoglycemia. Is there any increased risk of hypoglycemia, ability to recognize hypoglycemia, ability to correct any complications like neuropathy, retinopathy, etc., and understanding of the diabetes and its management and measure to avoid hypoglycemia while driving. And they should take food in time, always carry food in car while driving. Whenever the blood sugar value is low, stop driving and take some food, and avoid alcohol before or during drive. And those who are having severe hypoglycemia or risk of hypoglycemia or neuropathy or nephropathy are not allowed to drive. And any mismatch between carbohydrate intake and intake of medication can cause severe hypoglycemia. So metformin, alpha-glucosidase inhibitors, and other oral medications are comparatively safe during sulfonylurea, and insulin can precipitate hypoglycemic events. And those who are on these two should be very careful. And in some countries, there are laws regulating the driving, and they have to get a fitness certificate regarding driving in some countries. So the take-home message is people with diabetes can also travel as a normal person. Proper planning and preparation in people with diabetes help to avoid difficulties during travel. Thank you for the patient listening.
Thank you, Dr. Ravindran. I know it is a vast subject, but we have to stick on to the time. And you have covered almost all aspects in a short period. Thank you, sir.
Okay, thank you, madam.
I think questions we'll take up at the short, because of the shortage of time. Okay. We'll take up in the discussion.
Okay, okay, thank you.
Thank you very much, everybody. We will now move on to the next session. For introducing the speaker, I am inviting the chair, Dr. Mohan Varghese, sir. He is consultant physician diabetologist, Believers Church Medical College, Tiruvalla.
Thank you. Good morning. I think I'm not going in detail regarding this painful neuropathy and restless legs syndrome. The speaker is very well known to all of us, and he is Professor Ashok Kumar Das. Is an internationally acclaimed clinician with 3 decades of experience, and currently is a consultant endocrinologist at PIMS Puducherry, and formerly is the head of the endocrinology at the Jpef Pondicherry. He is author of more than 80 publications in the area of diabetic research in leading international diabetics and medical journals, held a position as a national president of APA and RSSD, and currently is an executive position at the RSSD, national convener for Indian National Consensus Group for the development of insulin guidelines in India. So welcome Ashok Kumar Das sir for the talk regarding painful neuropathy and restless leg syndrome. Thank you.
Ashok Kumar, sir, are you there?
Hello.
Sir, continue, sir. Speak, sir. Your slides are
Yeah.
being shared.
Actually, probably there is some problem with that. So I will actually discuss a little bit regarding this diabetic neuropathy. Everyone knows that is a very from basic symptomatic neuropathy to complicated neuropathies with a very difficult to manage sensory distal sensory neuropathy, as well as radiculopathy, mononeuropathy, compressive neuropathies, and cranial neuropathies. And these are all entities of different and individual identification and treatment targeting to the need of the individual patient. That is more important, because some neuropathies recover naturally, like cranial neuropathies, truncal neuropathies, and other. But painful distal sensory neuropathy is a tough area where the many drugs are there, which is going to be discussed. I am not entering into that particular field. The thing is what is the dose to be given? What is the combination of the medication to be given? It is all depend on the patient need. That's more important. The patient needs, because the therapeutic response of individual vary in different class of drugs, and particularly that particular patient, when they feel satisfied with your treatment plan, that's a target dosaging, and dosage can be stepped up depending on the severity of the pain. And another thing is that restless leg syndrome. This is also commonly seen with the diabetics, and this is a irreversible urge to move the leg. That is very commonly in our setup. I think it's one of the diabetic and iron deficiency, and pregnancy is one of the common issues which we encounter in daily practice. But they say there is a genetic background behind the issue, and when our childhood, the grandparents used to tell the massage leg and all. Probably this may be the reason for the restless leg syndrome. They used to say that massage it and use oil, these things, that things. So this was a time old one. It's described by the French physician, and in the 17th century, as then Thomas Willis, that 10% of the adult population. So the gravity of this issue is a very high. And
Sir,
yeah.
Sir, Ashok Kumar Das is available now. Sir,
Yeah.
you there, Ashok Kumar, sir?
Welcome, sir. Ashok, sir. Welcome. Hello. Ekeda, sir, welcome. Hello, welcome, sir. Hello, hello. So this we will continue a little bit till Ekeda sir comes into the scenario. So this disorder has got very particularly affecting the legs. There is a criteria to diagnose it. Upper limb also can get involved. There is medications. So I am not going into the depth into the discussion. But remember that this is a very commonly seen in we are under diagnosing, and treatment is should be directed properly. And the SAR will be discussing very meticulously regarding it, because these issues are actually challenging to the practicing clinicians, diabetologists, and neurologists across the globe.
Can I put my slides now, Mohan? Can I put my slides now?
Definitely, sir.
Yeah. Let us start. I'll take only 10 minutes, 12 minutes that is left. Can I put my slides?
Yes, sir. Go ahead.
Restless leg syndrome, this second. Yeah, fine. Can you put the slides on, please? Dear friends, we are discussing as Dr. Mohan Varghese said just now. It was described by the French physician, followed by in Africa by the Ecobam. Can I have the slides, please? Going to present today is something on the a very important topic, the restless leg syndrome, as introduced beautifully by Dr. Mohan. Is a great topic, and I'll start. Is my slide visible?
Just a minute, sir.
Visible? Is my slide visible?
There.
Am I audible? Mohan, am I audible?
Yes, I am audible, sir.
Yeah.
Audible. Very
So
well.
it was called Willis-Ekbom syndrome by the Thomas.
See the slides now?
Yeah, I'm showing my slides. Don't worry.
So can you see the slides now?
Yeah, I'm seeing my slides. Don't worry. I'm showing my slides. Am I audible? No, audible.
Yes, yes, yes.
Yeah, yeah. So it is about it's about a prevalence of about 7 to 10% of the adult population, and about 20 to 40% of these have significant suffering. Is my slides visible, Dr. Mohan?
Yes, yes, yes. Yes,
And
sir.
I'm audible?
Audible, visible.
Okay.
Go ahead.
So restless syndrome, what it is? It's an urge to move the legs and associated unpleasant sensation, typically at night, and moving the leg provides some relief. It's a very great urge to move your leg due to uncomfortable situation that occur primarily in the legs. It's a motor restlessness expressed as activity, and one is the leg activity that relieves the pain. It worsens by relaxing. It is better by activity. It occurs day and night, but mostly in the night. Mostly in the night. It is sometimes associated with the periodic limb movement that occurs in sleep. It has also sleep disturbance like insomnia, difficulty in sleep initiation. There is sometimes positive family history, genetic factor, which Dr. Mohan just now spoke about it. And we have to potentially to exclude the other causes. Now, what is the causes that cause it? Low brain iron, low serum iron, peripheral sensory neuropathy, cortical and spinal excitability, and hypoxic pathway activation, and genetic factors. But what we can definitely take care of is low brain iron, low serum iron, and peripheral sensory neuropathy, which is very important. Now, it has to be differentiated from myalgia, venous stasis, leg edema, but that is the primary RLS, restless leg syndrome. But what is important to discuss today is the secondary RLS. The most important amongst them is diabetes. It can also occur in the kidney failure. It can occur in the hypothyroidism, but most important is the diabetic RLS, restless leg syndrome. Now, what test we do as a management? We may do anemia workup, the iron workup for the serum ferritin, complete blood count, and total iron binding capacity, iron saturation. We can do diabetes workup because good blood glucose control is very important. We look at the renal diseases, and we have to do the test like electromyogram, nerve conduction studies, and the Doppler studies, and that is very important to do because that gives a great answer. And we also do polysomnography for the immobilization test. Now, there are two types of restless leg syndrome. Am I audible now, Dr. Mohan?
Yes, audible, sir.
And visible. My slides are visible.
Yes, visible.
So we have two varieties of restless leg syndrome. The chronic persistent type, the symptom when not treated would occur on average at least twice we also exclude the chronic pain syndromes, and we have to exclude peripheral neuropathy, radiculopathy, arthritic pain, and positional discomfort, and the vascular claudications. Now, The nocturnal leg cramps are more with neuroleptic induced akathisia, drug induced. Peripheral neuropathy is a chronic pain syndrome and movement does not bring in relief. Radiculopathy is a hypotensive akathisia and arthritic pain, varicose pain occurs because of other regions. What are the associations of type 2 diabetes restless syndrome? Number one is the quality of sleep, which gets compromised, which gets very much compromised. We have one of the earliest study reported that 27% of the patients of type 2 diabetes get diagnosed with restless leg syndrome. Some studies have shown it can be up to 51%. And patients with type 2 diabetes and restless leg syndrome have poor sleep quality, take longer time to fall asleep, and asleep for a less time, and they use more and more sedatives. Very important. Poor sleep quality, longer time to fall asleep, and were asleep for less time, and they use more sedatives. Now, there's a study about the quality of sleep component that's called sleep dimension by the PS polysomnography quality index study, and it has shown that the diabetes have very significant impairment of sleep when compared to same diabetic subjects who do not have RLS. So it impairs the sleep. Now what are the implications? Now, I think the most important part is played by the drugs and the educators. Now, there's a study at the Philadelphia, United States. Now, 45% of type 2 diabetes there had RLS. And the quality of life was affected as a result of the depression and the anxiety caused by the restless leg syndrome. Most important, they have to give assurance that it has no bearing on the longevity of the life. It's a nuisance, no doubt about it, but it is modifiable, it is curable, no significant effect on the length of life. Now, if you look to this quality of life and the psychological status, it has been shown that it is related to the glycohemoglobin. Therefore, poorly controlled type 2 diabetes can have more of the restless leg syndrome. You have to differentiate it from very important condition. Number one is the neuropathic pain syndromes. There is no relief with movement in the diabetic peripheral neuropathy. The distribution is globes and stocking type. Here the distribution in the whole leg. Radiculopathy, there is the radicular pain. Sleep-related leg cramps, there is palpable tightening of the muscle, alleviated by the stretching, which does not occur, and it does not occur in which occurs in this leg cramps, not in the RLS. Positional discomfort, with shift in position it relieves, but not here. Venous stasis can produce leg edema and skin alteration, which does not occur in the restless leg syndrome. Now, there are a few things one can exclude very easily, like the arthritis, like the anxiety, like the habitual foot tapping, but there is no urge to move. People just tap their foot as a habit. You must have seen many people shaking their legs, tapping the foot. And there is some less common mimics like the myelopathy, but it produces muscle atrophy, produces weakness, produces hypostasia, which are not present here. One can easily exclude also the myopathy, the vascular neurogenic claudications, the painful leg syndrome, and the other things. Now, in the pediatric age group, there is one disease called the growing pain, which has to be excluded, and the attention deficit disorders also can be excluded. One has to exclude it from the diabetic painful neuropathy, and here the main symptom also to move. Painful neuropathy main symptom is the pain, and I think it is very easily distinguishable. There is one variety of restless leg syndrome which is known as the refractory restless leg syndrome, and some causes that we have to address here is low systemic iron and concomitant use of other drugs like antihistamines, antidepressants, dopamine antagonists, and comorbid indications like sleep apnea. Last 2-3 slides. What are the strategies for the treatment? Choice depends on many factors. Two main classes of drugs that provide relief are the dopaminergic drugs like ropenolol. The alpha-2 delta ligands like the gabapentin, pregabalin that we use extensively also provides relief. I'll repeat it again. The first is the education, psychological support. The second is two main classes of drugs, the dopaminergic agonist, the ropenolol, the alpha-2 delta ligands like the gabapentin and pregabalin. Sometimes it will be very severe. The opioids such as the methadone can also use in the refractory case, and in the overall secondary cases, it has to be the iron deficiency has to be corrected, and the symptomatology is depends upon the treatment. The last slide, the associated insomnia, restless leg has to be addressed, and the drugs which have been used extensively are the gabapentin, pregabalin, and the various dose of propranolol. Dear friends, I have given you a very brief outline of how do we diagnose, differentiate, and treat the RLS. The bottom line is to diagnose it as RLS, not peripheral neuropathy. The second is psychological support, the support by the education. Third, two groups of drugs, the dopaminergic drug, propranolol, and the gabapentin, pregabalin, the alpha-1 ligand drugs, and also taking care, if it is refractory, the replenishing the iron load. Thank you very much for a patient hearing.
Thank you, sir, for the nice and excellent presentation. And I think because of the time scheduling, we will discuss these things at the end of the this rest of the topic. Okay. Thank you, sir.
Thank you very much, sir. Thank you. For the next session, I am inviting the chair, Dr. J. Krishnan B. He is a professor, Department of Medicine, Educare Institute of Dental Science, Malappuram. Welcome, sir. Jay Krishnan, sir, are you there?
Are you able to hear me? Hello.
Yes, sir. Yes, sir. Continue.
Hello.
Yes, sir.
Am I
We're
audible?
able to hear you. Yeah, continue.
Yes,
sir.
sir. Good afternoon, everyone, and welcome, Dr. Matthew John, sir. He is very well known to us as the Organization Secretary of ESICON 2017. He is a known endocrinologist at the Providence Endocrine and Diabetes Specialty Center, Trivandrum. He has done his DM endocrinology from KEM Mumbai, and is having over 40 publications in Indus journals and 30 conference presentations. He's an investigator in three clinical trials of molecules in diabetes, osteoporosis, and growth hormones. And welcome you, sir.
Yeah.
Please start, sir.
Yeah, I'm starting. Can you see my screen?
Yes, sir.
Okay.
Continue, sir.
Give me this opportunity to give me this opportunity for presenting here. And my topic today is storage and transport of insulin. So this is looks like quite a dry topic, but let me see whether I can do justice to this. So what I'll be discussing is the following points. What is the path of manufactured insulin? How should insulin be stored in pharmacies? How should insulin be transported? How should insulin be stored in patients' homes? How long can you use a cartridge? And how can you look at the potency of insulin stored at room temperature? And are insulin in pump reservoirs stable at tropical climates? This is the path of manufactured insulin. As you would know that insulin which is manufactured by the manufacturer comes to the distributor, then into the pharmacy, and then to the hands of people with diabetes. What we have in India is that we have certain agents in between called the carrying and forwarding agents, which may handle insulin ahead of the distributor. And cold chain management is required to be like the distributor and the manufacturer are beyond our regulations. So let us look at from the pharmacy perspective. This is a study which has been done in India, and I'll just form this as a basis to why this topic is very important in our clinical perspective. So this is a study which was done in Pondicherry, and what they did is that they looked at 3 brands of insulin, the Novo Nordisk, Lilly, and Biocon insulin, and they studied the insulin storage at various temperatures and how the biological effect, that means in terms of blood sugar reduction, blood glucose reduction, behave. And what you can see in this particular picture is that at 32 degrees Celsius and 37 degrees Celsius, insulin was not stable, and it had around a significant reduction in the potency of insulin, around 20%, 15 to 20% reduction in the potency of insulin when insulin is stored like that. So this makes it very important that we store insulin properly in our clinical practice. So what are the concerns regarding the exposure? Exposure to cold will cause protein aggregation and irregular action profile and agitation of insulin, like when you're carrying it in a pump, insulin reservoir in a pump, or when you're carrying it insulin in your pocket or in your bag and it gets thrown around and all those things. It can lead to agitation, which can lead on to fibril formation and filament formation, and that can be dangerous for people with diabetes. So how should you store insulin in pharmacies? So basically all insulin should be stored between 2 to 8 degrees in a refrigerator. And this temperature, when you say, it is not the average temperature of storing insulin, that should be the continuous temperature of storing insulin 24 hours in a day. And nothing else should be stored in these refrigerators. You should not be storing any other things like food or ice creams, or the cakes which come after the birthdays in the department should not be stored in the same fridge. The fridge should have an electricity backup in case of power outages. And you should limit the repeated opening of the refrigerator. And always follow the first in, first out rule. That means whichever insulin came in first should be stored ahead and supplied ahead of the insulin which comes in last. And it is always good to have a medical grade refrigerator in pharmacies. You should realize that most of the pharmacies don't have a medical grade refrigerator. So what are the features of medical grade refrigerator? There are a lot of features, but some things I would like to point out is the temperature recording which should be there. You can use, if a committed refrigerator is there, you can use the refrigerator itself as a temperature recording system is there. It should not be temperature setting, it should be the temperature recording, and that should be calibrated every 6 months to 1 year. There should be a temperature log which should be preferably electronically or manually recorded by the pharmacist, and some alarm should be there if it is electronically recorded to show that you are crossing the temperature. It is preferable that these refrigerators have a transparent thing so that you know where exactly the medicine is stored, so that the pharmacists can easily acquire it. And there should be adequate space between the medicines, because there should be a good airflow so that the temperature should be uniformly maintained within the fridge. So once you supply it from the pharmacy, how should you transport the insulin to the patient's home? So it should be transported using a cold chain management. Do not put any ice or ice gel pack in close contact with the insulin. So you can use bags like the ones which are shown in this thing. There are aluminum foils which come in between the insulin storing area and in between the gel pack that we are using. And keep a towel. If you don't have such a facility, you can keep a towel in between the ice and the insulin which is getting stored. So there should not be any direct contact with the insulin and the ice. So these are the wrong ways and the right ways of transferring insulin. The first picture you can see, this is from another article which I have taken. You can see that insulin is in direct contact with the ice cubes, and ice water also, insulin is kept in direct contact. It's a wrong way of transporting insulin. And what you can see on the right is a bag which is used for transporting insulin. I put up this particular picture to show you that the ice pack should be kept in a separate container or a separate area, and it should not be in contact with the ice when you are transporting it. So how should people with diabetes store insulin at their houses? They should be stored in refrigerators, again between 2 to 8 degrees Celsius, and they should not freeze the insulin. This is the general instructions which is given by the companies which produce insulins. But we should also realize that these refrigerators are optimized for temperature household refrigerators, where you keep your meat and fish along with your vegetables and insulin is actually not optimized for insulin storage. The optimized temperature that for the fridge household refrigerator is between 0 to 4 degrees, and for insulin is between 2 to 8 degrees. Mostly in these refrigerators, air is not circulated and temperatures may occasionally drop below the freezing point. And even in refrigerator temperatures, various compartments of the refrigerator may have a different temperature. So this is one of those studies to show that even though most of the time we keep the insulin on the butter compartment, that is the place on the side of the door, but you can see the highest fluctuations of temperature actually happens in the door area and not in the other areas. So the best area to keep an insulin in the fridge is in fact one of the middle components of the main refrigerator and not on the side doors where the temperature fluctuations can be larger. And these are again studies from patients, temperatures in patients' fridges or in the fridges of people with diabetes, people like all of us who have refrigerators at home, that the refrigerators don't keep a uniform temperature at home, especially when you keep opening and closing it, and there can be power outages which come. There are certain mini bars or hotel fridges, refrigerators which can be used, but these are actually not at all good for storing insulin. And if you're using a refrigerator which does not have a defrost, auto defrost facility, you should defrost the insulin. And if preferable, you can use a thermometer also. So this is one example of a wrong way. This is a hospital refrigerator you can see, and you can see the blood components being stored, the insulin being stored, various medicine being stored. But look at what is happening. The freezer compartment does not have a door. So the door has gone off and no one has bothered to repair the door. So what happens? The fridge is totally in a sort of freezing state and insulin is likely to get destroyed if you keep it in this fridge. So how do you transport in day-to-day life? Once the patient has bought the insulin, how does he transport in day-to-day life? People do have short travels and overnight stays are also there. It is recommended you store it below 25 to 30 degrees. Different companies have got different regulations, and do not freeze. And there have been reports of insulin getting destroyed in insulin pumps or in the syringes or vials of patients with type 1 diabetes leading on to diabetic ketoacidosis. So these are various methods of transporting insulin that you can see. Pouches are there, certain branded items like Medicool and Frio wallets are there. You could use any of these things to transport insulin for 2 or 3 days. And when do you throw off insulin? How long can you use an insulin? It is confusing according to label guidelines, and it can vary between different brands of the same insulin, like insulin NPH from one brand may have a different storage from insulin from another brand. Follow the local expiry guidelines. It can vary, for the same insulin, it can vary from vial to cartridge or pump reservoir. General rule is 4 weeks, but you can see from this picture which I have given that it could be up to 6 weeks or even 8 weeks with Degludac, 6 weeks with U300 glargine. So different areas are having different sort of storage capacities, storage expiry dates. So the next question is, can pens be refrigerated? Open vial should be stored in refrigerator 2 to 8 degrees after using. That is a very common recommendation. Cartridges, disposable pens which are unopened, again can be stored in the refrigerator 2 to 8 degrees. But they say that the used pen should not be stored in refrigerator. No one knows why it should not be stored. There are concerns generally regarding air bubbles and cold insulin, which can be settled by the patients with diabetes if they are well aware of having that. But newer insulin pens have actually changed this trend. So what I've shown you here is the data of the Tresiba Flex Touch pen and also the new Fias pen. It in fact can be refrigerated at 2 to 8 degrees even after you start using the pen. So will pens get damaged at higher temperatures? The insulin inside the pens, it can possibly get damaged. You can store insulin at room temperature. The pens can be stored at room temperature if the room temperature is less than 25 to 30. Generally recommended not to refrigerate these pens, but studies have shown that there are loss of insulin potency at higher temperatures. The first study I showed you at 37 degrees Celsius, and limited data with stability of insulin pens in tropical climates are there. There is at least one study to show that it can be stable at 37 degrees, but not many studies to support that from our country, our part of the world. There are certain traditional methods of insulin storage that we recommend for people with diabetes. This includes things like storing in clay pots, and clay pots are actually found to have 7 degrees less temperature than ambient temperatures which are there in the surroundings. But we take care that not all things which all those clay pots which were studied in this particular study had this advantage. Only if you have a bigger mouth of the clay pot and if you have an evaporating system, this sort of temperature reduction will come. And now finally to the insulin stability in pump reservoirs. Pump reservoirs are in constant proximity to the body. They are supposed, when people walk around or play with the pump, they are supposed to have heat and agitation, and they can have precipitation of insulin inside the pump. It is recommended that pump and infusion sets and reservoirs be changed in 2 to 3 days intervals, but a lot of people do use it for more than 3 days. And there is some data to show, this is data for patients where temperatures have been recorded from the reservoirs kept on the patient's body inside the pump. to show that temperatures can cross up to 34 degrees Celsius. These are temperatures in the US, where temperatures are generally colder than India. Definitely in India, it may go to different temperatures, higher temperatures. But as of now, we don't have much of data to say that it gets spoiled in insulin pumps. Now, this sort of temperature storage has been taken very seriously by companies, and now you have certain things like insulin clock, which is a novel insulin delivery device, which actually records the temperature along with the dose of insulin that the patients are taking. So thank you very much for patient listening, and I'll be happy to take questions. Thank you very much.
Thank you very much, sir. Moving on to the next session. I'm introducing the chair for the next session, Dr. Madhu N. He's a consultant surgeon and managing director of Chaitanya Hospital, North Parabur. Welcome, sir.
Good afternoon, everyone. With a lot of thanks to JPF team, let me introduce the new topic. When the whole world is fighting against the COVID pandemic, we are facing another twin pandemic in clinical practice, that is diabetes and thyroid disorders. They are the two most common endocrine disorders of which mutually influence each other. The association of obesity with the hypothyroidism, abnormalities of the two largest endocrine glands of the body, along with the diabetes, actually makes it a triple pandemic. And prevalence of both these endocrine disorders are more common in Kerala also. To enlighten us on this, we have got Dr. Sambit Das of Odisha, working at Apollo Hospitals, Bhubaneswar and Endeavour Clinic. He has an illustrious career, getting numerous awards like Chief Minister's Merit Award, Gold Medal in Microbiology, and many others. Inviting Dr. Sambit Das for this presentation, Thyroid and Diabetes Crosstalk.
Thank you, sir, for the kind introduction. So hopefully my slides are visible.
Yes.
Yeah. So at the outset, I must thank Dr. JYOTHYDEV for giving me this opportunity in this wonderful conference. And the topic is quite important because as the chairperson has already introduced, thyroid and diabetes are two important endocrinopathies, and there is a significant crosstalk among them. So thyroid disorders and diabetes are the two most common endocrinopathies, and they frequently coexist. One comes with the other, and the overall prevalence that has been studied is around 13.4% of thyroid disease in patients with diabetes, and the maximum prevalence occurs in type 1 diabetic females, and the lowest occur in type 2 diabetic males. So that's the range of the prevalence from 6.9 to 31.4%. And there is a significant crosstalk between these two important endocrinopathies. Now, in this presentation, I'll be discussing on what is the physiology of crosstalk, how thyroid is related to type 1 diabetes, and how thyroid is related to type 2 diabetes. What are the implications in pregnancy? How OADs or oral antidiabetic drugs which we use, or any antidiabetic drugs which we use, can influence the thyroid, and what is the current guidelines. So coming to the physiology of crosstalk, now I have presented it in this single slide, that is thyroid and glucose metabolism. Thyroid is basically a catabolic hormone, and it has got effect in liver and also in the peripheral tissue. And if you can see that thyroid can actually lead to increase in the gluconeogenesis, increase glucose output from the liver, and lipogenesis. And in the peripheral tissue, what it does is that it increases the transport of glucose into the tissues by GLUT1 and GLUT4. It induces lipolysis, it increases glycolysis, and it increases the mitochondrial function. So grossly, it's a catabolic hormone, and the thyroid hormone can actually lead to more amount of glucose output from the liver, and also the lipolysis and the glycolysis in the periphery. So the overall, the blood glucose can be high with this hormone. So coming to thyroid and type 1 diabetes, the most common association that we find between these two endocrinopathies. Now, if you see this particular study, you can find that female patients with type 1 diabetes is almost 30.9% chances of hypothyroidism, and the male patient have prevalence of 10% of hypothyroidism. And type 1 diabetes and thyroid disorders, it's the most common autoimmune pathologies associated with type 1 diabetes. So type 1 diabetes is an autoimmune disease, and there are so many other endocrinopathies or autoimmune disorders which are associated with that. And the most frequent autoimmune disorder which is associated with type 1 is thyroid disorders. There are n number of studies at different types and different years about the prevalence of hypothyroidism in type 1 diabetes. And if we grossly find out the conclusion from this study, the thyroid autoimmunity is present in 2.5 to 32% of patients. Overt hypothyroidism, we can get up to 15%. Subclinical hypothyroid, we can get up to 11.5%. And the total AITD or autoimmune thyroid disease present in thyroid disorders is around 24%. Now, this association is bidirectional, and that's very important thing to see actually, because the anti-TPO antibody, anti-TG antibody, which are the markers of autoimmune thyroid disease, is significantly increased in type 1 diabetes. We have already discussed it's around 7 to 32%. But what is more important to find is that the autoimmune markers of type 1 diabetes like islet cell antibody, GAD65, insulin antibodies are also significantly higher in autoimmune thyroid disease or in Graves disorder, and that may be up to 4% to 19% is the prevalence of finding these antibodies in thyroid disorder. So there is significant bidirectional association between these two conditions. Now, there is no clear-cut guidelines, but this is a recent guideline of Italian Association of Clinical Endocrinologists and also the Canadian Association of Diabetes, how they actually see or they actually recommend how we should monitor a type 1 diabetes for thyroid disorders. So they tell that screen type 1 diabetic patients for thyroid disorders with TSH and anti-TPO antibody in the first visit itself. TSH and antibody, if they are normal, it has to be repeated every yearly, the TSH especially. And if antibody is positive and TSH is normal, then you have to check it every 6 monthly for rise in TSH, and you can institute the therapy at the earliest. So that's how the recommendation goes. Now that was about type 1 diabetes. Now let us see what is the relation of thyroid with the most common garden variety of diabetes, that is type 2 diabetes. There are data that shows that prevalence of hypothyroidism in diabetes can be between 2.5 to 32%. And we have a good data from Manipur, the northeastern states, where Dr. Shalam Ranbir et al. Have found that the prevalence of hypothyroidism in type 2 diabetes is around 28%. There is a small but important or interesting study for me, which I could find out by Dr. Vikram et al., who have found that in a clinical setup, in a tertiary care setup, when they have tried to measure the T3, T4, TSH in both type 2 diabetes and the age-matched non-diabetic population, there is a significant lowering of T3, T4 level in diabetic patient compared to non-diabetic patient, and the TSH level was higher in diabetic compared to the non-diabetic population. Type 2 diabetes prevalence in subclinical hypothyroid is 5 to 8.6%, and we know that if subclinical hypothyroidism is present in type 2 diabetes, there is greater chances of diabetic nephropathy. So hypothyroidism or subclinical hypothyroidism is itself a risk factor for prevalence of diabetic nephropathy. The risk of cardiovascular event was significantly increased in type 2 diabetes and subclinical hypothyroidism, and that is significant. Coming to hyperthyroidism in type 2 diabetes, now in any patient who is hyperthyroid or in Graves' disease produce diagnostic confusion with a typical type 1 diabetes or a type 2 diabetes with osmotic symptom, because this patient will be really cachectic, they will be jittery, they will not be stable, and they may resemble a high blood glucose in a type 1 diabetic patient. Hyperthyroidism precipitated diabetic ketoacidosis in patients with diabetes, so that's also very important. And there is one condition known as the thyroid eye disease or the TD, and the incidence of dysthyroid optic neuropathy is significantly higher in patients who have diabetes than who have no diabetes. So the prevalence varies from 33% to 3.9% versus. So visual recovery is not good as a new glycemic patient. So if someone has dysthyroid optic neuropathy, the recovery is also not good with the optimal therapy. And caution about pioglitazone administration in diabetic patient with active Graves ophthalmopathy is there. I think we should not be using this class of drug with thyroid eye diseases. Now the next, so we've discussed about thyroid and type 1 crosstalk, thyroid and type 2 crosstalk. Now let us see what happens in pregnancy. about GDM. GDM and thyroid are also closely related. So if you see, there is 3 times increased risk of thyroid disorders in GDM. So if a person is diagnosed with, or a lady is diagnosed with GDM, then don't forget to check the TSH also. 25% of women with type 1 diabetes may develop a postpartum thyroiditis, and they may subsequently lead to hypothyroidism. So that is also to be taken care of. And combined GDM and hypothyroidism, we know that GDM is also a indicator of bad prognosis for a lady with pregnancy, and same also hypothyroidism. So it increases the cesarean section, preterm deliveries, and hypertensive disorders of pregnancy. Both the combination is there. So translating into clinical practice in pregnancy, so we must do a TSH and anti-TPO antibody in type 1 diabetes planning for pregnancy or at the beginning of pregnancy, and that is the recommendation. Screen for GDM if TSH is higher than normal trimester specific values in the first part of pregnancy. So that is the recommendation. So another interesting aspect how these two disorders can crosstalk is about OADs and thyroid, and I'll show some very interesting article. Like metformin may lead to actually reduction of the TSH level in patients who are hypothyroid, whether treated or not treated, and there is no effect on euthyroid patients. And the TSH lowering effect of metformin can be found after 3 to 6 months after the treatment initiation. And the mechanism is not clearly known, but probably it is related to peripheral AMP kinase activator and central inhibition of metformin. And there is a very nice article which was published in Diabetes Care, that is TSH lowering effect of metformin in type 2 diabetic patients. And what they've shown was that after 1 year of metformin therapy, there is a significant TSH decrease, and the p-value was significant in diabetic patients with hypothyroidism who are either treated or not treated. Even if you treat or not treat the metformin therapy with 1 year, the TSH level will go down. And but there is no significant change in free T4 was observed in either group. Plus, there is also a finding that there is a 30% shrinkage of the initial nodule size when metformin is given alone, and up to 55% reduction in the nodule size if both metformin and thyroxine have been given. So that's an interesting data. And so we could actually postulate that these therapies can complement each other. So there are sufficient evidence to tell that thyroxine therapy reduces the HbA1c in patients with type 2 diabetes with coexisting subclinical hypothyroidism, and the reverse is also true. Treatment with metformin reduces the TSH level in patients with type 2 diabetes. So if you are giving metformin in a hypothyroid patient, then the TSH level can also go down. Apart from metformin, the interesting data about metformin, there are, we all know that preclinical animal studies have shown an association of GLP-1 receptor agonist with thyroid C-cell abnormalities, and caution with GLP-1 receptor agonist in diabetic patients with a personal or family history of medullary thyroid carcinoma or type 2 men. So we should not be using in this group of patients the GLP-1 RA agonist. So coming to the last 1 or 2 slides, that is what do the guidelines tell and how we should go about it. So we have sufficient data that there is a crosstalk, but how we should go about it in translating into the clinical practice. So ATA 2017 and also the recent ATA have clearly shown that patients with diabetes and type 1 diabetes and thyroid, the screening is very streamlined, but for type 2 diabetes, they have not mentioned anything. For ADA also, even the 2018 I have mentioned, but even in 2020, at type 1 diabetes diagnosis, we must do a anti-TPO antibody, anti-TG and TSH, and every yearly. But for type 2 diabetes, it has not been clearly mentioned. So this is suggested algorithm by Kadiala et al. In all patients with diabetes, baseline evaluation, we should do a TSH and anti-TPO antibody, both for type 1 and type 2. If there is thyroid dysfunction, and if it is overt, we must treat and monitor. If it is subclinical hypothyroidism, we go about the guidelines of subclinical hypothyroidism, like if the patient is having symptoms, anti-TPO positivity, or the TSH more than 10, we can treat them. For euthyroid patient, if the TSH is normal, for type 1 diabetic, we must do an annual TSH survey. But for type 2 diabetes, if the TSH is more than 2 or the TPO antibody is positive, we can do an annual survey. But if the TSH is less than 2 or the TPO is negative, we can do 3 to 5 yearly TSH assay. So that's a very comprehensive algorithm how we can go about it. So coming to the last slide, that is what is the key messages which I wanted to give about this crosstalk. High frequency of thyroid disorders in diabetes and vice versa can have major impact on glycemic control. I have already discussed about that. Combined endocrinopathy can have major impact on pregnancy, and metformin's TSH lowering effect need to be better delineated, and it requires long-term studies. Current screening recommendations should be reviewed and modified. So how we should go about that. So with that, I'll end my presentation. Thank you for the patient hearing.
Thank you very much, sir. Now I request the chairs to take up the questions.
There's no question in the chat box. Anybody want to have any questions? Because in this short time, Dr. Sambit has gone through all the details of thyroid and diabetes. Thank you, Dr. Sambit.
Thank you.
I think no more questions are there. We have cleared everything. Thank you.
I request the last three chairs to please ask questions. If any questions, they can ask to the speakers.
I can ask question to Matthew John. Matthew, can I ask you? You referred to that study in that was done in Jpef by the former department. Are you listening, Matthew? Matthew, are you listening? Matthew, are you listening, Matthew?
Matthew is there.
Are you listening, Matthew? Okay. Yeah, I think we have lost. I have a very important question to ask Sambit.
Yes.
Sambit, I mean, you described beautifully about the crosstalk between the thyroid and the diabetes mellitus, and you also outlined. But you know, today the metformin is used as a corollary to the anti-thyroid drugs. I mean, along with other anti-thyroid drugs being used. What's your take on that? Should it be promoted or not promoted?
Yes, sir. So I think it should not be promoted, but definitely there is evidences, as you have suggested, that with the use of metformin in a hypothyroid diabetic patient, the TSH level can go down. So the clinicians should know the implications of that, and while giving metformin and this thing, and there is a positive association of giving metformin with lowering or getting the smaller size of
nodule. You said that. You said about thyroid nodule smaller size, and also improving HbA1c.
Yes.
That you also anti-thyroid drugs.
Right.
That's a wonderful presentation. And you know that hyperglycemia that occurs in the thyrotoxicosis. I mean, sometimes have thyrotoxicosis. What is your take on that?
Yes, sir. Thyroid hormone as such is a catabolic hormone, so it can actually produce more amount of hepatic glucose output and also insulin resistance at the periphery and lipolysis and all. The thing is that it can actually increase the blood glucose in a type 2 diabetic, and in rare cases in type 1 diabetic, it may precipitate a incidence of diabetic ketoacidosis.
Thank you. Thank you. Thank you. Thank you. Mohan, you want to ask any question that we?
Regarding the restless leg syndrome.
Yeah.
Actually, this is an underdiagnosed by the clinicians all over India.
Exactly.
So, what is your message to?
I think my message is that when patients come with the complaints of the leg pain, not pain, the urge to move the leg and not able to have proper sleep, a type of insomnia, we should not dismiss it. In the Tamil, there is a syndrome called Kai Kal Korchil. We call it KKK. Majority of the diabetics, you know, it's about 30% diabetics have this symptom, type 2. So people dispose it of as KKK, Kai Kal Korchil. It is not Kai Kal Korchil. It is a restless leg syndrome which has no bearing on the life expectancy, but it is a nuisance. And we exist as doctors to take away the unpleasant feeling. And we have drugs, wonderful drugs available. The first drugs to be used is the same drugs that we use for the nephropathy, the neuropathy, like the gabapentin and the pregabalin. And in the severe cases, and those which occur with nephropathy, since we cannot use diabetic nephropathy, since you cannot use this gabapentin, pregabalin, we use the anti-dopaminergic drug, propranolol. So the message is loud and clear that if the patient is complaining of no pain, but the leg is not able to keep static, there's a there is an urge to move the leg, and whenever he's keeping the leg static, there is severe urge to move it this way, that way. He tussles in the bed, doesn't get sleep. One must take it carefully, differentiate. There is no pain, no stalking lobe anesthesia, no pain of neuropathy, and then give these drugs which are inexpensive and can produce a change. Of course, one needs education, one needs diabetes control, and one also needs assurance to the patient.
Sir, this group of people are comparatively depressed also.
Yeah, they're depressed. Absolutely. But we are saying the correct thing. They are depressed because of the constant urge to move. They're depressed. And sometimes, the antidepressants also can make this situation much worse. You know that. So we give usually anti-anxiety drugs.
That's
Is Matthew John here?
Yeah.
Matthew, Matthew, where are you? Matthew, I can't see you. Matthew, you just quoted that paper from Jpef,
Yes,
which
sir.
is about the storing of the
Insulin.
drugs,
That is
storing of the insulin. That paper has made a mark, and also today the storing of insulin has gone a sea change. And we found that all insulins had drawbacks, and all insulins also had the good points, as you rightly highlighted. So storing of insulin is of paramount importance, and people must be spoken about it. I'm very happy you spoke on this subject, and very important. Once you take it out on this syringe, insulin syringe, Matthew, how long we can keep it, and in what temperature?
You are saying about the vial, insulin vial, and then you
vial, the poor man's insulin.
Yeah,
not the pen.
Insulin vial. Actually, what I just like mentioned is that if you look at different manufacturers, there are different regulations which have been proposed. I think the minimum you can store an insulin vial is 14 days. That is the minimum you can do. That is the least.
Yeah.
But some companies have said up to 28 days you are able to store the vial which you are using. So minimum is 14 days you can store. I think that is one of the GP's recommendation is 14 days, but up to 28 days. So if you are storing it properly at 2 to 8 degrees in the refrigerator, I think that most insulins can be stored up to 28 days. That should be
up to 1 month.
Average.
Yeah. Is there any guideline that when people store it very hot climate like Rajasthan, and they store it in the as you rightly showed, those matkas, those earthen vessels, all that, how long it stays with the potency?
So those actually I had searched and I could not find any specific studies on that. But what this particular study is a very good study which has been done in 2 countries. They have 2 areas they have done, and they have tried different types of mud pots and different things like Frio Valet and all those things. And they found that on an average, most of these things might have a -5 degree from the ambient temperature, -5 to -7. Yeah. So suppose your temperature is 40 degrees. This can actually bring it down to 35
I think
degrees.
that's a great message. And finally, I'm talking too much. Finally, that I think Matthew, you and your colleagues should do a study regarding the KAP knowledge, attitude, and practice of the storing of insulin, because that is very important, and that is need of our country. With this comment, thank you. Wonderful talk. Thank you, Sambit. Wonderful talk.
Thank you, sir. Thank you.
Sir, we still have 5 more minutes. If any more questions, you can still talk about it for 5 more minutes. At 1 o'clock, we'll be starting the next session. Until that, we can have a little discussion.
Yeah, Dr. Madhu is talking.
Yeah.
Yes.
Yeah.
Dr.
Sir, there is a question. Is there any role for L-carnitine and uridic acid for this?
What you said? Uridoxycholic acid?
L-carnitine and
L-carnitine as a coenzyme.
Yeah.
A coenzyme. And the other one you said?
Uridic acid. Uridic acid.
Is that a bile acid?
Uridic acid.
Is it, Dr. Madhu, a bile acid? I will be honest with you. Is it a bile acid?
It's used for muscle cramps and all these things.
Okay. I have not come across any studies. I think I have not used it. L-carnitine coenzyme that can contribute to allay the symptoms of breast cancer. That is well known, and people use it. Now, L-carnitine is available also today's world in plenty, and people take L-carnitine and a coenzyme which can definitely help.
Thank you, sir.
And people also have used drugs which are simple pain painkillers, but I must confide that the painkillers have no role in the restless leg syndrome. It's a neurologist domain, Madhu, and it's a leg movement. It's a movement disorder.
Yeah.
So movement disorder, like Parkinsonism, somebody may perhaps say if movement disorder not Parkinsonism, it is restless leg syndrome. Because they are the two most common. Of course, we have narcolepsy, we have but so the drug to be used is possibly the drugs we use for the Parkinsonism, most important propranolol, but that we use in severe cases when there is nephropathy. Otherwise, we use simple drugs like gabapentin and pregabalin. Yes, Dr. Mohan.
Yes, sir. Sir, it is some studies showing there is a relation between sleep and this restless leg.
Yeah. There is a great relationship. You know, the diabetics have two types of sleep disorder. Usually they sleep more. Whether the hyperglycemia, they sleep more. But the people who have restless leg syndrome, the polysomnographic study, there is a study called PSQI, Polysomnographic Quality Index. It has shown that sleep is fragmented, and early morning the sleep is very much fragmented, and they cannot sleep well. So it occurs in the early evening, middle of the night, and more also in the early morning. So sleep is definitely affected. That is why the quality of life also is affected.
Thank you, sir.
Thank you. So my purpose of giving this topic was to highlight that all that glitters not gold, all that is symptom in the leg is not peripheral neuropathy.
Yes,
there is no point giving tons of vitamins. One can give iron. It has been shown that if the ferritin is less than 20, transferrin is less than 20, and the iron is less than 50 to 75, then there is a definite role for iron replenishment. Because low iron, both in the serum and in the brain, is a cause of restless leg syndrome. So we have two criteria. If the serum iron less than 50 to 75 microgram, or the transferrin less than 20, there is a role of replenishing iron, but there is no role for any other vitamin.
Yes. Sir, hemoglobin estimation in a yearly basis.
It is very important. Hemoglobin, so that's why I showed that anemia slide. So one has to correct the anemia, because that becomes a very important cause for RRLs. So anemia has to be, especially Dr. Mohan, very happy you took the question. I showed that in the slide, but it is very important that anemia workup must be done in every case of diabetic, and more so with RLS.
Okay, sir, we just have 1 minute.
Including serum iron and transferrin.
Yes. Sir, how far it is a genetic background, the percentage of genetic background?
Yeah, there is a genetic background. It has been worked out, but we say we cannot do anything about it because we cannot choose our parents. Neither we can choose our in-laws anymore. So it is only modifiable factors which can modify. But genetics definitely has a role. And they are not linked to the genetics of type 2 diabetes.
Excuse me, sir.
Yeah.
We have only 1 minute left.
I think
there is one question for me. I'm not able to read the question. Sir, any beneficial effect of salbutamine in restless leg syndrome? I have not come across, doctor, but there may be something, because no, I have not used salbutamine for this drug, and I think he has asked thrice for the salbutamine. I think there may be some effect. I'm not very sure. I'll check up, because I must not give a wrong answer. Thank you for the question. That was in my question answer box.
Thank you. Thank you all the speakers and the chairpersons for the session.
Thank you.
Thank you very much.
Thank you.
Thank you, sir.
Enjoy.
Thank you, sir.
Thank you. Thank you very much.
JYOTHYDEV'S Professional Education Forum is organizing the Shaukat M. Sadikod oration for the first time in memory of a great physician whose life is dedicated to the treatment, education, and research of diabetes mellitus. Many of you would recall his vibrant presence in Jpef conventions. A true icon of the diabetes world, Dr. Sadikod was actively involved with the cause of diabetes and associated metabolic disorders in India, regionally and internationally for over 30 years. He started his career as a consultant in endocrinology at Jaslug Hospital and Research Center, Mumbai, and served as President of Diabetes India for many years. Dr. Sadikot was instrumental in conducting the first nationwide survey on the prevalence of diabetes in India. In his capacity as founder president of Diabetes India, he took the initiative for the enhancement of healthcare professional education in the field of diabetes. He served Diabetes India as its president for over 19 years. Dr. Sadikot was closely associated with the activities of International Diabetes as president of the Federation for the period 2016-17. He was an active member in several professional associations, editor of several journals, authored 4 books on diabetes, published over 130 research articles and papers in national and international peer-reviewed journals. Dr. Shaukat Sadikot was summoned to his heavenly abode on October 1st, 2019. Let us observe 30-second silence in memory of Dr. Shaukat M. Sadikot. For chairing the session, may I invite Dr. JYOTHYDEV, Chairman and Managing Director, JYOTHYDEV'S Diabetes Research Center, Trivandrum. Please, sir.
Thank you. Thank you very much, Veena. So welcome to my dear, so don't mute me again. So welcome to my dear friend, Dr. Benchi Sabu. So this is a very prestigious oration from our part. And this is the first time we are organizing. So welcome to my dear. Don't mute me again. So welcome to my dear friend, Dr. Benchi Sabu. So this is a very prestigious oration from our part. And this is the first time we are organizing. I think our Benchi is in the other hall, right? You are in summer hall. Okay, right. So this is the first time we are organizing this event.
So JYOTHYDEV, am I in the right hall or should I change the hall?
Very dear to us, and he is the founder of Diabetes India. And this Jpef we started partnering with Diabetes India. And Dr. Benchi Sabu is very dear, very close. He is a family friend of both Dr. Saukat and also of us. And it's a rare honor for us to invite Dr. Benchi for this prestigious oration. And this is a plenary session of our Jpef convention. And he's going to lecture on a very exciting topic, which has been discussed in almost every forum nowadays, and that is on reversal of diabetes, whether it is a myth or a reality. So welcome, my dear brother, Dr. Benchi Sabu.
Thank you. First of all, thanks, Dr. JYOTHYDEV, for inviting me for a very prestigious oration. And we are missing Dr. in month of October. He was past president of International Diabetic Federation. He was founder of Diabetes India, and he's already been introduced. But it's my great pleasure and privilege to have the first oration of JPEF of Dr. Shaukat Sadikot on the name of Dr. Shaukat Sadikot, of Dr. JYOTHYDEV for a fantastic program. Thanks to Dr. Sunita and complete team of Dr. JYOTHYDEV. Can I start? Should I share my screen?
Yeah, please.
So it's a new concept in management of diabetes, a reversal of type 2 diabetes. Is it a myth or is it a fact? I don't have any conflict of interest for this particular talk. And the reversal of diabetes, after this paper, which was direct paper, which was published in Lancet 2018, suddenly a hype is been there all across the world that diabetes can be cured or it can be reversed. But the first paper before that, he had in Diabetes Care in 2016 by Roy Taylor. And at that time, he had talked that very low calorie diet and 6 months of weight stability in type 2 diabetes can change the patients with diabetes and they can reverse with the sugar problem. But before this paper, even in 2017, in an endocrine society journal, which is a journal of clinical endocrinology and metabolism, they had also published a similar type of paper. And if you see the conclusion of that paper, a short course of an intensive lifestyle and a drug therapy achieves on treatment normoglycemia, it promotes sustained weight loss, and it may also achieve prolonged drug-free diabetes remission. So, I mean, not before this paper, even before that also, there was a paper which was talking about drug-free diabetes remission and which strongly supports ongoing studies of novel medical regime targeting remission. Even there was also a paper, a Indian data, a small proof of concept study, which was published from Pune. Anjali and Unni was the author for that. And they had also talked that a very low calorie diet, the total energy they had changed from 2200 to 1000 kilocalorie. And primarily if carbohydrate content of that energy, if it is 50% or less than 50%, they had shown in their paper, the HbA1c of 9 had come down to 6.2 with a small number of diabetic patients, and the number of patients were only 12, but they had shown there is a direct data from India also as far as reversal is concerned. Now, what exactly happens in a type 2 diabetes? We know that the first pathophysiological defect in type 2 diabetes is a first phase of insulin secretion goes away. That happens in type 2 diabetes. So when we call a reversal, it means a first phase of insulin secretion has to come back. And this is then and then you can say that, yes, somebody is reversed from the diabetes. I mean, this is a primary first pathophysiological defect which occurs. Now, if you know the Ralph Diffranjo, he had talked that even somebody becomes a pre-diabetes, the first thing goes away is the first phase of insulin secretion. While Roy Taylor had shown in his paper that after getting a reversal or remission in a direct paper, he had shown that those patients who could achieve the HbA1c of less than 6.5 without any drug therapy, who were on the 1200 kilocalorie, 1000 to 1200 kilocalorie on a long-term basis, and in first 3 months they were on less than 800 kilocalorie with a significant weight loss, they could get this first phase of insulin secretion back. So that is the reason he called that it's a reversal of type 2 diabetes. Here's one more paper which was published long back in 2011, and at that time he had have a hypothesis that type 2 diabetes can be reversed. And how it can be reversed? By decreasing pancreas and liver triacylglycerol, and that is what his first paper at that time, he had put a twin cycle hypothesis for type 2 diabetes. Why somebody develops diabetes? It is at a two different cycle. So positive calorie balance, which increases the liver fat, which increases insulin resistance. And this increase in liver fat, increase in VLDL triglyceride, which increase islet cell triglyceride, which decreases insulin response to ingested glucose. So one cycle at liver because of positive calorie balance, which increases the islet cell triglyceride and which decreases insulin response to ingested glucose, and that cycle is at pancreas level, and which increases the postprandial glucose level, increased plasma level, plasma glucose level, further increase in basal insulin secretion, and further increase in insulin resistance at the level of liver. So these two cycles which are responsible for increasing diabetes. But if primary driver of this diabetes is a chronic excess calorie intake, and if we remove that, the direction of cycle could be reversed, and that was his primary hypothesis, that type 2 diabetes can be reversed back, because if the primary driver for this diabetes is chronic excess calorie, so if we decrease this excess calorie, or we decrease it to the low calorie diet, and we can decrease the islet cell triglyceride level, probably we can reverse the type 2 diabetes also. That was his primary hypothesis, which he published in 2011, and then again one more paper in 2013 in Diabetes Care at American Diabetic Association. So the major current question, whether remission can be durable. So what he had told, that yes, remission is possible, reversal is possible, but whether it is durable, that is very important. The second important part of this, can it be delivered at a scale to reach the large number of patients? I mean, in a lab or in some of the patients, if you think that yes, it can be reversed, but the primary problem is, can it reach to a large number of patients, and that too at a primary care. So a primary care physician, can they do reversal of the diabetes? That was the primary question. And how much vascular complication of diabetes can be delayed or avoided? This was the major question. And for that, DIRECT was designed. It was designed to test an integrated weight management program, which was delivered in a primary care with an initial period of effective weight loss. So what they have done, in the first 3 months, they had tried to reduce the weight, then stepped food reintroduction with emphasis on an energy balance, and then a structured support for a weight loss maintenance with a provision for relapse management also. So this was the primarily designed DIRECT, and that was giving the question of what I had asked, that whether it can be used in a primary care physician's level or also. To our knowledge, DIRECT is the first study which was designed to test whether or for how long a dietary weight loss can generate remission of type 2 diabetes. DIRECT study was designed as an open label cluster randomized controlled trial at 49 primary care practice. So primarily it was designed for a primary care practitioner, whether they can use in their clinical practice or not. Weight management program was the intervention arm, while the best practice care, so the other arm was also given the best practice care guideline, was the control arm. The patients were between 20 to 65 years of the age, a type 2 diabetic patient with a less than 6 years of duration of diabetes. They have a BMI of 27 to 45. They were not on insulin, and the recruitment period was from July 25, 2014 to August 5, 2016. I mean, at the time of intervention, the withdrawal of anti-diabetic and anti-hypertensive drug, total diet replacement. Now, this is very important. All these patients were put complete diet replacement by a formula diet for first 3 to 5 months. And that formula diet was having the roughly kilocalorie of 825 to 853. Then afterward, they were stepped to food reintroduction. So after 3 to 5 months, there was food was reintroduced. That was between 2 to 8 weeks. And that food was 50% of that should be carbohydrate. So the carbohydrate content of that calorie content, what they were taking, it should not have more than 50% from the carbs, 35% from fat, and 15% from protein. And then this structured support program was maintained for next 2 years as a weight loss maintenance program. See the results after 1 year. After 1 year, you will find the weight loss of 15 kg or more in 36 participants. It means 1/4 of the number of participants in intervention group. Diabetes remission, it means they were less than 6.5 without any drug. After 1 year, 46% of participants in the intervention arm. But surprisingly, even 6 participants, that is 4%, even in the control arm, was also there in that group, because of they also started taking care of themselves and started taking low calorie diet. But the results after 2 years, that is 1 year data, and after 2 years, you will see 11% in intervention arm and a 2% in a control arm, a weight loss of 15 kg. It means there were good number of almost 11% of them, they could maintain this weight loss of 15 kg. 36% in intervention arm had remission of diabetes. It means 1/3 of person who were having diabetes of less than 6 years, they can manage their diabetes without any drugs, and they were keeping their HbA1c less than 6.5. So 1/3 of them were in remission. out of 129 participants with a data on medication, 42% were in remission. So even the number of persons who were with the less than 6.5 without the medicine was 36%, but another 6% were in remission and they were not on any anti-diabetic medication also. 36% in the intervention group, they maintain even 10 kg weight loss. So I mean, the 15 kg weight loss was only in 11%, but other 24% of them could manage their weight loss, or they can have a sustained weight loss of 10 kg even after 2 years. So the interpretation, the direct program had shown a sustained remission at 24 months for more than 1/3 of people with type 2 diabetes, and sustained remission was linked to be the extent of sustained weight loss. So the conclusion of direct trial, the type 2 diabetes of less than 6 years with a obese person who are not on insulin and those who are willing and motivated to follow the low calorie diet for first 12 weeks or first 5 months, the remission can be a practical target for them. This is very important message from a direct trial. Those who are obese with a diabetes of less than 6 years, they are not on insulin and they are ready to take low calorie diet and they are highly motivated, they can probably, a remission can be a target for them. This study, because it was extended up to 2 years, it had shown that evidence of remission is durability of up to 2 years. Even a early dietary measures in practice for routine management of type 2 diabetes should be considered. So each and every patient of type 2 diabetes, a dietary measure is very important, even if they are not going for a remission program or not going for a diet formula or a replacement diet formula program, but still the dietary measure is very, very important. Intensive weight management has potential to reduce or delay the complication of diabetes, and it improve the clinical outcome. It also says that yes, diabetes can be cured, or we can say at least it can be reversed, or there is a remission which is possible in a highly motivated patients or with their clinician who is equally motivated. This trial had shown that low calorie diet is a bright future for people with type 2 diabetes patients. If they can reduce and they can maintain their weight loss program for next 1 or 2 years, probably they can have remission or they can have very good control. But there are many advantages of remission. We all know that it's a sustained, substantial, intentional dietary weight loss, which is not feasible because it is not possible for each and every patient. Even there are multiple such publications which I had shown. But if you see one of the paper, which was Carter and colleagues, they found remission is only in 0.14% out of 120,000 United States patients. They were followed for 7 years. So I mean, if you give this choice to many of your patients who are even motivated at the time of randomization or at the time of first consulting, but long term, if you see, hardly 0.14% are ready to continue this type of program. Even in the Scotland, where the this program was there, the direct trial was done in Scottish Care Information Diabetes Database, which includes every patient in Scotland, show that less than 0.1% of those who are type 2 diabetic patients were coded as a being in remission. So I mean, out of 2,54,208 patients, only 245 patients were motivated that yes, they will able to do a remission program. So reversal, is it a fact or a fiction? So it's a fact because we have data, we have multiple papers which had supported, and we have a randomized controlled trial where it had shown that even after 2 years, the 1/3 of the persons with diabetes have remission. So it is a fact. There is no doubt about it because we have a evidence for that. But it is fiction. Why I should call it a fiction? Because in real world, if you see less than 0.1%, and this 0.1% means not 1,000 to 1, it is 10,000 to 1% is really getting benefited, and that too after so much education. If we educate the doctor, physician, highly motivated, equally motivated the patient, and both of them, if they continue, probability of getting remission may be 0.1%. So how many diabetes remission cases have we actually seen in our practice? I am practicing since last 20 years. We have for 25,000 patients, but only couple of patients, or the patients to whom I can count on my fingers, only they are there who I can think, yeah, they have diabetes remission. Now, possibility of reversal of diabetes, particularly a country where high carbohydrate diet, our diet is more than 65 to 70%. And what in this particular clinical trial or in a direct trial, they had talked that in first 3 to 5 months, they should be on a replacement on a formula diet, which is very, very difficult, particularly for India. And then the food was reintroduced to them, but they were supposed to take less than 50% from the carbohydrate, while our country, we are eating more than 70 to 75% of our diet contains carbohydrate only. So to change the diet pattern from 75% to 50%, and first 3 to 4 months, they should be at a very low calorie diet, and that should be also a formula diet. It is really very difficult for our Indian patients. Since it is difficult to achieve complete remission in a real world setting, this is what my experience. There is a lot of hype and excitement which is created by this paper in diabetes community, but actually in a real world setting, is it so useful? That's real doubtful. I am of the opinion that we can have reversal in stages, and that is what we do in our clinical practice. Each and every patient, we try to educate the patient for reversal, which would further help in motivating the patient as well as healthcare professionals. So if I tell the patient that yes, you were at this particular stage, now you had come back to this, you had reversed so much, it motivates the patient. It also motivates healthcare professional that each and every patient of mine, at least I must talk about the reversal of the diabetes. Although reversal is used synonymously for remission, but that's not the exact meaning of the reversal and remission are two different things. Remission means you are achieving a target or a HbA1c of less than 6.5 when he cannot be diagnosed with the diabetes and without any medication, that is remission. While reversal means at any stage of the diabetes, if somebody goes back, it is called reversal. And even a patient with a clinical diabetes, if he goes to the pre-diabetic stage, is reversal. In a clinical diabetes patient who is on a multiple oral anti-diabetic agents, suppose from the multiple oral anti-diabetic agent to the insulin, if he goes to only on 1 or 2 oral anti-diabetic agents, can we call it reversal? That we don't have any paper for it, but if we call it reversal, it will definitely motivate our patients as well as our healthcare professionals. So I had just proposed a journey of diabetes reversal. Can we call it? If somebody is controlled diabetes on whatever the drug, we can call it control, but reversal can be put in a different stages from 1 to 4. The remission is what he had defined, Dr. Roy Taylor, less than 6.5. And when you have a prolonged remission or when you have a HbA1c of less than 5.8, then you can call even a cure for diabetes. So again, the cure and remission and reversal, I think three are different terminology and that we should understand. We have 5 classes of drugs which are available to us. At present, we have insulin provider, which is insulin, sulfonylurea or glinides. We have insulin enhancer, which is all GLP based therapy or DPP-4 inhibitor. These are the two primarily the drugs which increases the insulin level by acting on beta cells. So beta cells are used while other 3 drugs are beta cell independent. And glucose excretor and glucose restrictor, which is SGLT2 inhibitor and alpha glucosidase inhibitor, they are primarily not acting through beta cells. They are glucose excretor or glucose restrictor, which is alpha glucosidase inhibitor, and SGLT2 inhibitor. They are nothing to do with their beta cell function. The insulin sensitizer is a metformin and glitazone, whatever the amount of insulin which is made in the body, that used in more proper way are the insulin sensitizer, which is metformin and glitazone, and which decreases insulin resistance in a type 2 diabetic patient. So clinically, if we define a patient in a different reversal stage, a patient who is in a controlled diabetic with less than 7 as per ADA, any medication is fine, then we can call it a control. Now, reversal stage 1, 2, 3, 4, you can change it whatever the stage which you want, or we can have a final paper, or we are trying to write a paper on this. But reversal stage 1, I feel those patients who are not on insulin enhancer. This is what, again, I'm talking of insulin enhancer, means the GLP-1 is gone. So once the IE has gone, we can call it, instead of reversal stage 2, at least reversal 1. So your patient is now only on insulin sensitizer. The second stage is the when patient is only on insulin sensitizer, and the stage where you can call somebody is a remission. Either the patient is with less than 6.5 but no medication, and the cure when the HbA1c goes less than 5.7 and patient is on a prolonged remission when it means more than 2 years and no medication is required, we can call that patient is with cure. So in real world scenario, a patient is committed and following a low calorie diet are really very low. But people who are able to stop diabetic medications are really very, very low. So I had seen more than 125 patients to whom we have motivated. We had talked about the reversal of the diabetes. But if you see the number of patients who could stop their medication, because most of my patients who are on a reversal phase or on a remission, we still continue them on a metformin, even their HbA1c is less than 6.5. So very, very few patients who are completely stopped the medication and their HbA1c is less than 5.8. There is always a chance of relapse if you stop the medicine. And that also we had seen in many of our patients when we completely stop the medicine after 1 year or 2 years or 6 months, they come back with the high sugar level also. Remission should not be the target of diabetes management. Rather, our target should be the reversal, or our target should be achieving a target HbA1c of less than 6.5. And if we can achieve HbA1c of less than 5.7 without medication, it's great. But that should not be our target only. Defining clinical staging of patient diabetes reversal journey very much clinically acceptable, because more and more patient will feel it is acceptable, it is achievable, it is doable, and also very motivating to the patient to define and achieve next level target. Suppose some patient who is at present we had decreased all the molecule which can increase the insulin level. Now he is only on SGLT2 and metformin, and now we are saying that we had stopped your GLP-1, we stopped your insulin or sulfonylurea. Now you are only on these two drugs and still you are achieving your target of less than 6.5. If you continue to control your diet and calorie intake, probably next time we may stop your SGLT2 inhibitor. This itself motivates the patient and he wants to achieve that next level target. This practical definition also increases more chances for achieving the remission or reversal for our patient. For advantage of these stages of reversal for patient, it provides a target and reward for the sustained hard work, which is usually necessary to achieve the target of remission. What in a direct trial, what they have done at the time of randomization, they stopped all the medication. So there was no further reward for them. While here in our day-to-day clinical practice in a real world, every time when patients come, you are stopping or reducing the agents for their diabetes and still they are keeping their HbA1c less than 6.5. It itself like a reward for the patients what he is doing a sustained hard work. For epidemiological worker and health system, it identifies a valuable indicator of success in healthcare through a national disease register monitoring, and it improves resource requirement forecasting also. Since it is difficult to achieve complete remission in real world setting, I am of the opinion that these stages would further help in motivating the patient as well as healthcare professional. Further studies would be required for understanding the benefits each of the stages of reversal would bring to the patient as well as to the health system. And that is what we are looking for further study from India, whether we can define multiple stages of reversal in our country or not. To conclude my talk, type 2 diabetes is a condition that develops in people who consume more calorie than they require over a long period of time. More fat in body can lead to excess liver and pancreatic fat and subsequent loss of plasma glucose control. The traditional concept of type 2 diabetes being a irreversible and progressive disease has been challenged. And this is very important. We were understanding when we were studying that type 2 diabetes is a irreversible or a progressive disease. That is no more. Evidence exists that type 2 diabetes reversal is achievable using bariatric surgery, low calorie diet, or by carbohydrate restriction. As physicians, we must grasp this paradigm shift in our understanding of type 2 diabetes for the benefit of our patient. This is very important. Each and every physician must understand that there is a paradigm shift in our understanding of type 2 diabetes. There is a possibility of reversal in our type 2 diabetic patients. We can think of using stages of reversal rather than complete remission in our day-to-day clinical practice in our real world. With this, I thank once again Dr. Jyoti for giving me this prestigious oration. And I believe that diabetes can be reversed, and this mission is possible if we understand the different stages of reversal and then complete remission in few of our patients. Thank you. Thank you very much.
The digital ovation. So I echo the same feelings. I can see comments pouring in the chat box. Very, very nice presentation by Dr. Benchisabu. So I echo the same feeling. So I wish Sadikot is listening to you from the heaven.
Thank you.
And yeah, because I remember how close both of you are. And I remember both of you having a resolution and a movement on India diabetes free by 2040 or so. I don't remember the exact date. So what is your vision on that?
So the vision for the 2030 diabetes free India, the meaning is, Jyoti, that the person who is born after 2030, in his lifetime, he or she should not all those environmental risk factors which are responsible for someone to become diabetes. So try to understand diabetes free India means those children who will be born after 2030, in their lifetime, they should not see all those environmental risk factors. Now, what are the environmental risk factors? The reduce exercise, less physical activity, more calorie intake in the diet, increasing the weight, and the environment is such that the obesogenic environment is there already. There is no place where one can walk, one can do exercise. Schools are not teaching or educating the people about the health and increasing importance of the weight reduction, all those things. So we want to create an environment after 2030, and for that we have to work now. In next 10 years, we have to create a system like that. The healthcare, those who are managing healthcare from the government side, and all those healthcare professionals, if we can understand and can we create an environment in such a way that the people who are born after 2030, even mean our grandchildren who will be born after 2030, they should not see such environmental factors which are responsible for someone to become diabetes in their lifetime. That's the idea of this diabetes free India, that concept which I had made, and it was acknowledged by Dr. Pranab Mukherjee, President of India. We have done some multiple programs. Also, Dr. AK Das was also there when I have done with the government of Gujarat in our Rajyapal Bhavan at our Governor House only. So just to motivate the healthcare professional as well as the government authorities who are responsible and improving the healthcare system. So by which you can decrease these environmental factors.
In an oration, conventionally, we don't ask any questions, but I will request you to answer to one question, and that is on any data on the role of intermittent fasting in the reversal of diabetes.
So the intermittent fasting definitely increases the ketone body, and that will, appetite will be suppressed by that. And it helps in decreasing the weight. So primarily the intermittent fasting is done for the reducing the weight. In obesity, we are using it. In a type 2 diabetic patients who is on sulfonylurea, who is on insulin, who is on diabetes, we are using intermittent fasting. And that helps in decreasing the weight. So primarily the intermittent fasting is done for the reducing the weight. Hypoglycemia, we can put the patients on an intermittent fasting, and that can help the weight reduction of this. But in my clinical practice, what I had seen, the low calorie diet and a low carb intake is very important for our diabetic patient, which helps for our patient to not only achieve a tight control, but it also helps for the reversal of diabetes too, and weight reduction.
So more and more positive comments are pouring in, appreciating the oration, fantastic presentation, new insight and new thought on reversal of diabetes by Dr. Surajit Kumar Batra. Another one, patients very commonly ask questions on cure of diabetes. As physician, what should be our answer on the first sitting? Whether cure is possible
say
or
that
not.
cure is possible, but we can always say that there is a possibility of remission. We have the trial which had shown, but reversal of diabetes is possible. So I mean, what I mean to say, that reversal means today you are on a 4 drug or 3 drug. There is a possibility that I can get your diabetes control even on a 1 or 2 drug if you are intensively controlling your sugar and simultaneously controlling the diet, also. So the lifestyle modification is very, very important for the reversal of the diabetes, and we can achieve in some of the patients remission. But I never tell there is a cure for diabetes, because these are the patients who are in remission or a reversal. We say that they are post-diabetes. They may get the sugar anytime. So you should not say the cure. It is like the same way what we say in the cancer patient. It is always a remission. We don't say that it's a cure for that particular malignancy unless somebody is having a data of more than 5 years. So at present, we have data of 2 years of remission, but maybe after patients, even post-bariatric surgery, the data is showing up to 5 years. Post 5 years, there are few patients who have relapse of sugar also. So I don't think we should say the cure for diabetes, but remission and reversal definitely we can tell to our patient.
Well said. So we are waiting for realistic evidence on diabetes remission.
Yes.
So that is the conclusion. So your oration was full of rich content and very energetic and enthusiastic. And congratulations,
Thank
Dr.
you.
Venshis once.
Thank you, Jyothydev.
Thank you so
for
much.
giving me this
Thank you
opportunity.
so much.
Thank you.
Thank you very much. Over to
After lunch,
Bina.
maybe again.
Bina Yasin. Yeah. After the virtual lunch break.
Thank you for the wonderful presentation. Sir, we will start at sharply at 2:30 for the next session. Thank you, everyone.
Dr. Harish, welcome. So, we are having the lunch break. You are muted. You are muted. Please unmute.
Sir, we are having the lunch break now.
At 2:30 we'll start like
Yeah,
next
yeah,
session.
you start sharp at 2:30.
Okay. First, I have to just start the topic and I can introduce the speaker. That the details were given.
Yes.
Okay.
Yes, yes.
Okay.
Going well?
Yeah,
Nice
going well.
meeting you.
Yeah,
Nice
because
meeting
even though our hospital, our senior doctor has recently only he passed away, so we have a little more pressure. So I was having to OP, so I just came from there.
Oh, okay. Okay.
51 years he was in our hospital. He's a physician from 1968. He just recently he died last week.
Anyway, thank you so much. There are thousands listening to you.
Oh, okay.
It's a live one. Yeah, thank you. Yeah.
Almost twice failed to show any benefit can appreciate. The fourth drug which was also tried in diabetic kidney disease was a non-selective endothelin receptor antagonist called evocentan, and this trial was called Ascent trial, with a feeling that the endothelin is the most potent vasoconstrictor. If you use antagonist, if you dilate the renal artery, you might protect kidney. But unfortunately, this trial was prematurely stopped because of increase in heart failure with this particular molecule evocentan. So you can see for the last 5 years, from 2005 with 4D up to 2010, we couldn't do anything good to protect diabetes kidney. Whatever agent was tried shown basically harm or either no benefit. The fifth drug which was again tried was a TGF beta inhibitor. So this is different from PKC beta inhibitor. This molecule was called pirfenidone. It was tried in patients with kidney disease, but there was no benefit whatsoever. There are several other drugs which were also tried. This is one agent called sulodexide. This is a natural glycosamine polysaccharide. The trial was called Sun Macro, tried to protect kidney but failed to show benefit. The Altitude was a landmark trial. Remember, the eliscarine was promoted by Novartis in past, which was stopped actually after this trial. People thought that if you use a direct renin blocker, it might work better than an AC or ARB. So this drug was tried in trial called Altitude. Unfortunately, this trial was prematurely stopped because of significant increase in side effects like hyperkalemia and hypotension. And since then, after the Altitude trial, actually eliscarine was withdrawn from every part of the world. So we don't have eliscarine which we used in past because of this increased signal of harm in the Altitude trial. Warfarin D was the first study which was tried to combine AC inhibitor with ARB. People had a feeling that one drug is not enough. So if you combine ACE and ARB together, you might protect kidney. But unfortunately, this was the first trial which suggested adding ACE inhibitor to ARB is detrimental. And since then, we have been recommended not to use AC with ARB together because of this particular trial, which was tried for a diabetic kidney disease, had to stop prematurely again because of similar side effect which we saw in the Altitude trial in form of hyperkalemia and acute kidney injury. The last in the syllabus was a new molecule called bardoxolone methyl. This is nuclear receptor factor 2 activator. Is in this trial called Beacon. This molecule was tried with a great appreciation that this drug could be beneficial, but unfortunately again this trial was stopped because there was significant increase in hospitalization due to heart failure and death, as you can see, twice compared to the placebo, and we didn't do anything good. So what I'm trying to suggest that since 2005 we tried many drugs, but we failed to show any benefit to protect kidney. However, everything is not as depressing as the current time of COVID-19. We did have something in our hand to offer, but this is way back in 2001. You can see the IRMA 2 was the first ARB trial done with irbesartan, which shown a significant decrease in progression from micro to macro. But remember, this is not a hard kidney protection endpoint. Reducing albuminuria doesn't mean that you protect kidney always. There is an instance where you can reduce albuminuria, but you harm, you actually do not protect kidney, you can harm kidney. So reduction in albuminuria is just a soft surrogate, it's not a hard endpoint. However, this was the first trial at least suggesting that ARB could be useful in preventing micro to macro albuminuria progression. In the same time, in 2001, two other trial was published. You can see again, IDNT was a hard endpoint trial where renal composite was used as a primary objective. You can see doubling of creatinine, development of ESRD or death due to any cause was the primary outcome. And for the first time, the ARB versus calcium channel blocker amlodipine 10 milligram as a second active comparator arm versus placebo, you can clearly see that the ARB was superior to not only to the placebo, but with the calcium channel blocker as well. And this was the first evidence to suggest that ARB can protect you from progressive kidney disease in terms of renal transplantation and death due to kidney cause. The third study was renal trial with losartan, again showing a significant decrease in the hard endpoint. That was again the composite of renal endpoint. So remember, everything happened in 2001, and this is the only evidence till 2019. So we had to wait for actually 18 years to find out whether there is any other agent to protect you from diabetic kidney disease. So recently we started showing newer data. The SONAR was one trial. It was done with, again, endothelin receptor antagonist. Remember the earlier trial I shown you called SN was done with ebocentan. Now this is a selective endothelin antagonist called etrasentan. And you know, this trial was presented same day when the credence trial was presented in the same hall 20 minutes back. For the first time, some evidence generated with this particular agent, which significantly shown a reduction in the composite of primary renal endpoint. But you know, unfortunately, this trial has to be stopped because of significant increase in hospitalization due to heart failure. Remember, even in the SN trial with ebocentan, there was a signal of increase in heart failure, and that trial was stopped. Although in SONAR, there was a significant reduction in the renal endpoint, but because of this increase in heart failure, this trial has to be stopped because of this side effect. Remember, at the same time, this SGLT2 inhibitor first renal outcome trial came with canagliflozin called Credence. You can see both results from both the SONAR and Credence in front of you. Both reduced the composite of renal endpoint significantly. However, in one hand, SONAR shown increase in hospitalization due to heart failure. The canagliflozin shown a significant reduction by 39% reduction in hospitalization due to heart failure. The previous trial, SONAR, was stopped because of increase in heart failure. The Credence was stopped prematurely because of excess benefit. So that's a difference between two molecules. Both are reducing kidney outcome, but one is increasing heart failure and is stopped because of increase in heart failure. The second trial not only reduced the kidney outcome, but also the heart failure, and was stopped because of excess benefit, because this is not ethically permitted to allow a trial when the one drug is doing wonder and you continue with the placebo in other arm. That's why this trial was stopped prematurely because of excess benefit. And we learned after 18 years from 2001 from IDNT and renal to now Credence trial, we had to wait for 18 years. 9 molecule was tried, everything failed. SGLT2 came with a flying color. And remember, during the lockdown time, we heard the top line result from DEPA-CKD, which has also been stopped, similar in line with Credence because of excessive benefit. We don't have the full results of this particular trial, DEPA-CKD, but I expect this trial would show us a similar benefit in line of Credence. So this is a second SGLT2 inhibitor trial, which was stopped because of excessive benefit, like the Credence trial. And finally, we do have a newer agent, and you can see the top line result came 2 days back on 9th July. And this is a third generation mineralocorticoid receptor antagonist. Remember, we know spironolactone is the first generation, iplerenone is the second generation. This is a finerenone. This is the elder brother of iplerenone called finerenone. This trial was undergoing since last 2 years, and this is called Fidelio diabetic kidney disease trial, and it has shown a significant reduction in the renal composite like the Credence trial. The entire result is not yet out. It will be presented at the World Renal Congress very soon. But for the first time, now we got a mineralocorticoid receptor antagonist showing benefit in the renal endpoint. 2 more trials is currently undergoing with this particular molecule, finerenone. Is called Figaro diabetic kidney disease, and the primary outcome is the 3-point mesh, like our CB outcome trial. And another trial is undergoing called Fine Arts Heart Failure with finerenone, and we all are waiting for the CB and heart failure outcome trial. But for the first time, mineralocorticoid receptor antagonist has shown a significant reduction in the renal endpoint. So with this background knowledge, let's look into what we have learned in last 18 years. So this cartoon tells you the story, what happened in past 20 years with different drugs tried for kidney protection. And as I alluded to, since 2001, we had to wait for the credence trial after 18 years, which shown a significant reduction in the renal and cardiac endpoint. And now we have got the DEPA CKD as well as Fidelio DKD trial with a newer agent. So what we are getting is a newer drugs are doing wonder as far as kidney protection is concerned. So let's quickly look into what happened in the credence trial, and I will not dwell much into that. We have already heard hundreds of times. So while you are comparing the 3 SGLT2, which is undergoing the a dedicated kidney outcome trial, the color coded in front of you, you can see these are the basic difference between 3 trials. All are looking into the primary objective of kidney endpoint. The difference being is, first in credence, everyone has to be on ACE and ARB. That's not a mandatory rule in DEPA CKD and the IMPA kidney. Second is difference is the credence trial, everyone had diabetes, but in DEPA CKD and IMPA kidney disease outcome trial, not necessarily it's a patients with diabetes. Even a non-diabetic kidney disease, the DEPA CKD and IMPA is going on. The third difference is that in credence, the EGFR cutoff was between 30 to 90. For the DEPA CKD, it is 25 to 75. For IMPA, it has further went down to EGFR up to 20. So that's the basic difference, but they have almost similar kind of endpoint. You can see a little bit different in the renal endpoint, but primarily they are into the same direction of looking into the different composite of renal endpoint. So we have got DEPA CKD stopped prematurely on March 30 this year, and we have got the full result of the credence trial, and we are waiting for the IMPA kit. So what was the credence trial? The credence trial was a dedicated SGLT2 trial done with canagliflozin compared to placebo in a patients with diabetes and CKD. Everyone has to have an EGFR of less than 90, and everyone has to have a microalbumin creatinine ratio in the macroalbuminuria range. Means everyone has to have more than 300 microgram per milligram or 300 milligram per gram of urine albumin creatinine ratio. The primary endpoint was the renal endpoint, and the secondary endpoint was the cardiovascular endpoint. And here is the result. And you have seen up to number of times there was significant 30% reduction, a highly persuasive p-value in the composite of renal composite, showing you there is a 30% relative risk reduction in the Cana arm compared to placebo. And this is in nutshell result on different cardio CKD endpoint, whether it's doubling of creatinine or ESKD or renal death or CV death. You can see the first 4 outcome was significantly positive on the kidney endpoint. They also had a secondary, the interesting point to note that you can see this benefit happen irrespective of the EGFR. As you can see, the p-value of interaction is not significant, thereby suggesting that even in a patient with a stage 4 DKD, even up to EGFR 40-30, you can have, that is stage 3B, you can have a similar benefit as in the stage 2. So this trial for the first time suggested that irrespective of the EGFR status, the SGLT2 inhibitor is doing a trick in protecting the kidney. This is as opposed to the glucose control. If you have got a less EGFR, there is no apparent reduction in blood glucose. But as far as the body weight reduction, BP reduction, and the renal heart protection goes, it doesn't matter what is your EGFR. So this was for the first time suggested that even with a lower EGFR in the range of 30 to 45, you can protect kidney with this particular molecule. What is interesting to note that there was no serious side effects seen in patients, those who are sicker with CKD. You can see even the adverse event are coming left to the unity, thereby suggesting that canagliflozin was as good as placebo with regards to the side effect. The common side effect, as we all know, was the genital mycotic infections and increase in DKA in the SGLT2 arm, in canagliflozin 100 milligram arm, but other side effects was pretty similar compared to placebo. Also, this trial was good to see that there was no increase in fracture, which we anticipated. We saw in the Canvas program, there was a signal of increase in fracture. We expected increase in fracture in a patient with kidney disease even higher compared to the Canvas, but there was no such signal with regards to the fracture in patients with CKD. So suggesting that whatever signal we saw in the Canvas program looks to be very questionable. Even with regards to the amputation, There was no signal in increase in amputation. You anticipate even more amputation in patients with diabetic kidney disease, but that wasn't seen in contrast to the CANVAS trial. So again, this suggests that the increase in amputation could be a statistical or by play of chance. What we saw in the CANVAS program, that wasn't the truth, because had it been, even we could have expected increase in amputation in patients with CKD, those who are much sicker than the CANVAS patient population. With regards to the CB outcome, so you can see the secondary outcome was, statistically planned in a manner that after the kidney outcome is looking positive, we can look for the cardiovascular outcome, and you can see all the cardiac endpoint, beat, heart failure, composite of CB death, heart failure, all 3-point MES, significant reduction. Here is the, the forest plot in front of you, again showing for the second time after CANVAS that canagliflozin has a significant ability to reduce a composite of 3-point MES, even larger than what we saw in the CANVAS program. And you can see this is irrespective.
Excuse me, sir, 1 more minute.
Yeah, I'm finishing. This is second last slide. So as you can see, this cardiovascular benefit, is happening across the board, irrespective of the eGFR. So what we learned from this CREDENCE trial, that whether it is a renal outcome or it is a cardiovascular outcome, it is happening across the board up to the eGFR 30, and that's the unique findings from the CREDENCE trial, that SGLT2 inhibitor works even someone with a eGFR up to 30, especially what is this seen in the CREDENCE trial. So with regards to the real benefit which we understood in CREDENCE trial, when look into the eGFR curve, this is the largest benefit with regards to the reduction in eGFR. As you can see, compared to the placebo, the Cana could reduce the eGFR by 4 milli per minute, as you can appreciate, and this is the largest benefit which we saw with any drug so far which is useful for protecting kidney disease, including ACE inhibitor and ARB. So there was preservation of eGFR by 4 ml per minute, as you can see in the CREDENCE trial. And what this translates into, this is a mathematical modeling. When I shown you my first slide, I suggested you, the moment you develop a diabetic kidney disease, your life is reduced by, on an average, 15 to 16 years. CREDENCE, what we taught us, that it can increase your life by 15 years by protecting the decline in your eGFR by 4 ml per minute per year, and thereby meaning that indirectly suggesting that it can prolong a life of a diabetic kidney disease by same approximately 15 years. So that's amazing data. No wonder the different guidelines in the world recommended canagliflozin to be used. As you can see, this is the FDA, this is Canadian guidelines, and recently, a few days back, Indian DCGI has given them approval for reduction in the MACE endpoint. This is based on the CANVAS program. The based on the CREDENCE trial, as you can see, US FDA and Health Canada have given them an additional level for protecting diabetic kidney disease and reducing heart failure in patients with type 2 diabetes and kidney disease. Similarly, DCGI have given them this permission just a few days back that you can use canagliflozin to protect kidney disease, to protect heart failure and CB death if someone has got a diabetic kidney disease with albuminuria more than 300. Thank you very much for your patience. Listen.
Thank you, sir, for a wonderful presentation.
Thanks.
Thank you, sir. Due to lack of time, we will be moving on to the next session. And for the next session, I would like to invite the chair, Dr. Radhakrishnan AP. He's a consultant physician and diabetologist at Palakkad Diabetes Center, Palakkad. Welcome, sir.
Good afternoon, everyone. And let me thank Dr. JYOTHYDEV and his team, Jpef team, for asking me to chair this session. Wonderful session on interesting topic, that is pneumococcal vaccine in diabetes. How can you hear? Suppose can you hear?
Yes,
Hello?
I can hear.
Yes. Okay. Yes. To talk on this topic, we have an eminent endocrinologist from the country, Dr. Bansi Sabu. Just few words about him. Can I have his intro slide? Yeah. So Sir is being honored with the fellowship of American College of Endocrinology, USA, and American College of Physicians, and Internal College of Nutrition, and Royal College of Physicians, Glasgow, Edinburgh, and London. And MNMS in diabetology, and he's a president of RSSDA 2019 and 2020, and president of AIAARO, Indian Obesity Society 2016 to 2020, and honorable secretary of Diabetes in Asia Study Group and Diabetes India. And he has more than 113 publications in index journals and have contributed chapters in various textbooks and monograms. He has awarded the most impactful health leaders of World Health and Wellness Congress and awards, and completed many public awareness projects under Diabetes Care India. So to talk on this topic, sir, I think we would like to hear more about you, because this is one topic which we hardly discussed in majority of the meetings, diabetes conferences. Over to you, sir.
Thank you. First of all, thanks, Dr. Radhakrishnan, for kind introduction. I am also thanking Dr. JYOTHYDEV for giving me an opportunity to discuss on a relatively uncommon topic, but I think very, very important and interesting topic that all of us Can you see my slides?
Yes, sir. Yes, sir. Continue.
Okay. Am I audible properly?
Yes, sir.
So once again, thanks to Dr. JYOTHYDEV for giving me an opportunity, and thanks to MSD to support this. So I'll be talking about the pneumococcal vaccine, recommended pneumococcal vaccination in diabetes. As my timings are only 20 minutes, but I have little more slides, so I'll be little fast for that. I'll be talking about the understanding the respiratory disease outbreaks. I'll be talking about the relevance of adult immunization, mainly of pneumococcal immunization with the patients of diabetes. We'll be talking of something scientific evidence why adult pneumococcal immunization should be done in our routine practice in diabetic patients. As we know, in last 25 years, if you just see the respiratory disease outbreaks, it was very high. From 1998 to 2019-20, the COVID outbreak, we have multiple respiratory virus infection, and many of them are dying also because of that, but multiple cases which are diagnosed. In 1918, we were having Spanish flu pandemic, and after 100 years, we have COVID outbreak. The important lessons what we understood from these respiratory disease outbreaks. One is that elderly and comorbid patients are at higher risk of infection. This is, I am sure all of you will agree with that. The second important thing is pneumococcal pneumonia have been commonly seen as a co-infection along with other respiratory viral infection. This I think we must know also. So the elderly patient, we know that they develop more problem, but at the same time, pneumococcal pneumonia is a commonly seen co-infection. The preceding respiratory viral infection, a possible affecting the clinical severity of pneumococcal pneumonia. So the person with respiratory viral infection have more chances of severe pneumococcal pneumonia. If you see that it is commonly seen a co-infection, a retrospective observational study from 2019 to 2013, we found that respiratory viral infection in 30 days prior to isolation of S. pneumoniae pathogen was found. The severity of pneumonia was defined by comparison of PSI, which is pneumonia severity index. It scores in two groups, non-severe pneumonia. The study found that 51.8% of the 191% patients with pneumococcal pneumonia exhibited PSI score of more than 91. So the higher pneumonia-related mortality and prolonged hospital stay was also noted. It means those who have pneumococcal pneumonia found to have more mortality and more hospitalization stay also. This study was in 2014, also underlined the importance of early detection of respiratory viral infection in patients of pneumococcal pneumonia, and preventive strategies such as adult vaccination for influenza as well as for pneumococcal pneumonia should be done to prevent both the problems. The preceding respiratory viral infection, that what we learned from 2009 flu pandemic, that bacterial co-infection is common in patients with H1N1, Bacterial co-infection was more common with the hospitalized cases of influenza. Bacterial co-infection more with the severe cases of influenza. Bacterial co-infection was more with the hospitalized case of influenza A, who were having diabetes and they were requiring ICU care. Bacterial co-infection was more among pediatric hospitalized cases of influenza also. So streptococcal pneumonia attributed to 29% of total co-infection cases which were studied. In group 2, it was found to 54%. So from 29 to 54% of that, we found that it is a streptococcal pneumonia which is responsible. In group 3, the streptococcal pneumonia co-infection was resulting in ICU admission was 26%, and in another group 4, it was found to have co-infection of 33%. So in short, the co-infection of streptococcal pneumonia was found to be more with the patient of influenza in H1N1 pandemic, and what they found from 29 to 54% of the patients. One of the very important key learning, as I talked to you, but one important thing which we can do is vaccination against streptococcal pneumonia is often neglected, and this is very important. I don't want to talk other, but the vaccination against S pneumonia is often neglected, and in pandemic, I think we must understand that respiratory tract infection followed by bacterial infection is very, very common. If you see the current recommendation, the WHO is talking H influenza type B vaccination along with pneumococcal vaccination. If you talk about NFID, which is a National Foundation for Infectious Disease, in 2020 March, the latest update which I am talking of, they are also talking about the influenza and pneumococcal vaccination. If you see the ACC, which is American College of Cardiology, in their clinical bulletin about the COVID-19, they had also talked about pneumococcal vaccine and vaccination against the influenza, which should be as a part of their current guideline of ACC and EHA. Now, diabetes are at increased risk of respiratory tract infection. I'm sure we all know about that. The diabetics are 6 times more likely than non-diabetics as far as they have to get hospitalized with the diagnosis of influenza, 3 times more likely to die of pneumonia or flu. They are also among diabetics have death rate increased by 5 to 15%, and case fatality rate for flu is about 12%, while those with pneumococcal infection, it is between 21 to 36%. So why we miss on a protecting diabetic adults from vaccine, which is a preventable respiratory disease like adult pneumococcal disease and influenza? This is very important question. I think we all are treating our diabetic patients, but we are forgetting to vaccinate them, and which is completely a preventable respiratory problem. Now, let me talk about what we can do. What are the scientific evidence why we should routinely practice pneumococcal vaccination for our diabetic patient? The one important question which always comes is adult pneumococcal disease is a really cause of concern. So first thing, when we talk to the physician, they are saying that is it really a cause of concern? The second big thing, is it possible to reduce the pneumococcal disease burden? So if I vaccinate all of them, can I reduce the burden of pneumococcal disease? Does adult pneumococcal vaccination have any role in diabetes management? So other side around. So in patient with diabetes management, do I have all my patient, I should have the pneumococcal vaccination? What the evidence for PPSV23 in preventing adult pneumococcal disease, and what are the recommendation of using PPSV23 uses in adults with diabetes? So these are some of the important questions which I think each and every physician would like to know. So let us the first is adult pneumococcal disease is really a cause of concern. Now, lower respiratory tract infection responsible for 23.8 lakh death in 2016. Now, believe me, I mean, this is the data which has been published data. The lower respiratory tract infection 23.8 lakhs. Out of them, it is streptococcal pneumonia is in 11.9 lakhs. It is more than that what we are having today at present. The COVID death is around 6 lakhs. So as per WHO, 6 to 8 lakh adults will lose their life because of invasive pneumococcal disease every year. So IPD predominantly affects the elderly patients with comorbidity. This is the statement about the invasive pneumococcal disease, and lower respiratory tract infection is very, very high and responsible for 23.8 lakh deaths. What we see in pneumococcal disease, it is not just the IPD, not just the invasive pneumococcal disease. Many of the patients who may not have invasive pneumococcal disease, but they have pneumococcal pneumonia or community acquired pneumonia. But there are patients who have non-bacteremic pneumococcal pneumonia or other non-invasive form of pneumococcal disease, which is also there, like sinusitis and bronchitis. So when you are treating a patient with a pneumococcal, you can also, other non-invasive form of pneumococcal disease can also be prevented. Community acquired pneumonia is the second most common reason of death from infectious disease in India. This is a data from Mumbai. 36% of isolates from community acquired pneumonia patients have S pneumonia. One more paper which was published from Shimla, that 1/3 of the patients have community acquired pneumonia is because of streptococcal pneumonia. 40% of all community acquired pneumonia have invasive disease, it means IPD, and this is the 7th tertiary hospital, biggest center of India. They have almost 40% of that because of S pneumonia IPD. WHO report, Indian subcontinent contributes the largest share of pneumococcal disease burden in Asia. So I mean, as we have highest number of the person also, but more than China, we have the largest share of the pneumococcal disease in Asia. The second important, is it possible to reduce the pneumococcal disease burden? Yes, it is possible, because the best way to prevent pneumococcal disease is to get the vaccine. The pneumococcal vaccine helps protect against some of the more than 90 types of pneumococcal bacteria, and this is a Center of Disease Control and Prevention. This statement is coming from there. There are multiple governments across the globe recognize the importance and they implemented adult pneumococcal vaccination program. So whether you talk of Australia, Canada, but these all are developed countries, and they all have a program for adult vaccination. Even all adult is above the age of 60, those we have immunocompetent, or even with the persons who have immunocompromised situation also. Does adult pneumococcal vaccine have any role in diabetes management? As we know that diabetes is associated with higher risk of invasive pneumococcal disease. It is also higher risk with pneumococcal pneumonia. It is almost 3 times higher with the patients with diabetes, whether you talk of IPD or you talk of pneumococcal pneumonia. And this incidence rate is further increased in elderly population. As the person age is increasing from 25 to 65, you can see there is a significant increase in the risk of invasive pneumococcal disease. Diabetes is associated with high risk of pneumococcal pneumonia, and risk is higher even in young population also. So if somebody is, normally what happens, it's an elderly who gets more IPD. But if somebody is young but he is a diabetic, the chances of getting for him invasive pneumococcal disease becomes more, or a pneumococcal pneumonia more, in compared to other non-diabetic population. So even a person whose age might be even less than 50, still he is getting more chances of pneumococcal disease in compared to a person who is not diabetic. What's the evidence? Can we prevent it by using PPSV23? Yes. The efficacy we would like to understand, the effectiveness, broad serotype, the relevant serotype which are in India, changing serotype prevalence in light of childhood PCV vaccination, because we give PCV13, which is actually a vaccine which should be given in a young adults or the children. The importance of pneumococcal vaccine versus flu vaccine, which we should give, or rather both we should give. So the efficacy and effectiveness of PPSV23, it is 82% effectiveness against vaccine type IPD 12013, a Cochrane meta-analysis, which is with 5 randomized control trial with more than 31,000 patients. It is 73% efficacy against IPD, which is caused by any serotype. 2016 German STIKO meta-analysis, again 4 randomized control trial of PPSV23 in older adults. So we have a data to support that it is effective and it is efficacious against invasive pneumococcal disease. If you see the 3 years follow-up study of CAP-EMIS study, it is 22% of total study subject with diabetes. Results restricted to those vaccinated within 5 years before study start. 62% effectiveness against bacteremic pneumococcal community-acquired pneumonia. 48% effectiveness against non-bacteremic pneumococcal community-acquired pneumonia. or 25% effectiveness against all-cause community-acquired pneumonia. So PPSV23 has shown its effectiveness against IPD, non-bacteremic pneumococcal pneumonia, and community-acquired pneumonia. And this was a population-based Spanish study where more than 27,204 individuals more than age of 60 years were studied, and this data is published after that. Efficacy of PPSV23 in patients with diabetes, the efficacy against IPD is 84% in persons with diabetes, and this is from a US data of 1978 to 1992. There is a significant reduction in COPD exacerbation after PPSV23 vaccination. If you see the effectiveness of PPSV23 in patients with COPD, there is an Indian study which was by Dr. Mohanty, which was published in 2018, a randomized non-placebo controlled trial of 150 patients between September 2013 to August 2015. The PPSV23 more effective, reducing the mean number of COPD exacerbation in patients with comorbidity compared to those without. Higher reduction in COPD exacerbation in COPD patients with comorbidities like diabetes. Now the broad serotype coverage. We know there are two pneumococcal vaccination available, PPV-SV23 serotype 23 and PCV serotype 13. If you see the PCV 13, it contains all 13 serotypes which are available. 12 of them are already there in PPSV23, only one of which is unique to PCV13, which is available and which we give to the children and to the elderly or immunocompromised patients. More than 80% of invasive STGs causing disease in adults in India are included in PPSV23. So all those serotypes which are available in India, they are more than 80% of them invasives, they are already covered by PPSV23. 66% is the coverage offered by PPSV23, whereas 48% is the coverage offered by PCV13 based on the isolates for more than 50 years of community-acquired pneumonia. 67.4% of IPD in India is caused by 23 serotypes included PPSV23, whereas 58.7% is caused by 13 serotypes included PCV13. The relevant serotypes coverage of PPSV23 in India. If you see, the PPSV offers coverage to all 5 most common serotypes in Indian adults across various clinical syndromes and comorbidity. So you see everything. PPSV23 offers coverage to all the 5 most common serotypes which are across various clinical syndromes and comorbidities, including serotype 8, which is one of the most common. So I mean, all 5 most common are covered by this PPSV23. There are serotypes, as we said, the pneumococcal may have changing serotypes, prevalence in the light of childhood PCV vaccination. So if you have a children who is already given the PCV13, now we have PCV13, before that was PCV7, and then the 50% is related to 11 unique serotype in PPSV23. But there is a large decline in PCV7 and PCV13 and non-serotype IPD. So those children who have already PCV13 vaccination is given, definitely adult infection because of pneumococcal pneumonia is less, but still there are 11 unique serotypes which are still there, and that can be decreased by giving them a PPSV23. There is a significant residual IPD burden relevant to 11 serotypes which are unique to PPSV23 in older adults who are already given PCV13 vaccination in their children. So I mean, even those who are given the PCV13 vaccination in childhood, still there are 11 different serotypes unique which are available only with PPSV23, and that infection still remains. So that significant residual invasive pneumococcal disease burden still remains, and that's the reason those children who are given with PCV13, still adult pneumococcal vaccination should be given by PPSV23. Are there any recommendations? Now, recommendation by American Diabetic Association, which is one of the most reputed organization in the world. We also ADA very religiously. ADA 2020 is talking that in patients, in person with 19 to 64 with diabetes, one dose of PPSV 23 should be given. Above the age of 65, if he is already been taken PPSV 23 before that, he should be given one more dose. And this is what we follow in India. The same RSSDA Endocrine Society guideline, which we published in 2019, we also talk same thing with all persons with adult person should be given PPSV 23, and if they are above the age of 65, already one dose of PPSV 23 is given, a second dose is additional is required. Vaccination against those who are already children where it is already given PCV 13, again in adults they should be given PPSV 23 too. The summary of importance of pneumococcal vaccine. Pneumococcal disease is associated with significant burden in diabetes in India. Many countries across the globe adopted adult pneumococcal vaccination program to prevent pneumococcal disease. Adults with diabetes are at higher risk of invasive pneumococcal disease and pneumococcal pneumonia. PPSV 23 has established effectiveness, broad and relevant serotype coverage for India. The importance of 11 unique serotypes in PPSV 23 is increasing due to PCV program in children. One-time vaccination for pneumococcal disease is essential along with annual flu vaccination. ADA recommends one dose of PPSV 23 in all 19 to 64 years of age with diabetes, and additional dose of PPSV 23 of after crossing 65 years of age, regardless of vaccination history. Who most influence adults' decision to get immunized? So, as I told, it is the physician which is the most important person who can influence. Other than that, definitely family member and many of them, but it is the doctor, it is the physician, it's the person, whether it's a general practitioner, whether it's a diabetologist.
Sir, your time is almost over, sir.
Yes, sir, it's the last talk. So the strong physician recommendation is all it takes to protect adult with diabetes with pneumococcal disease through vaccination. So knowing is not enough. We must apply. So I mean, we know that it is a very important problem, but we must apply. We must vaccinate our patient, and we must not lose this opportunity. When the patient is coming to our clinic, we must explain the patient the pneumococcal vaccination which is available to us, and we must complete. Thank you very much. Once again, this is the ACIP recommendation, which shows about both PPSV 23 and PPSV 23 and PCV 130. Thank you very much.
Thank you, Dr. Bansal, for the interesting talk on this topic on pneumococcal vaccine. And do we have any time to have a questions? The two questions. This
Yes,
one,
sir.
would you recommend pneumococcal vaccine during this COVID time?
Yes, it is there. I had already shown you that. Rather, during any pandemic, we are forgetting. We can prevent and I think during this pandemic, we must give the pneumococcal as well as influenza vaccine, both, because other flu we can prevent definitely, and pneumococcal vaccination should be given to all our diabetic patients. Even all adults should be taken also. Then somebody asked, what is the schedule for younger diabetics? I mean, already if they are children below the age of 18, they might have taken the PCV 13. If they are not, they must take PCV 13. And once they get above the age of 18, they should be given PPSV 23 also. Is there vaccine for MRSA? No. Anonymous, would you recommend pneumococcal vaccination during this COVID time? Yes. Dr. Shashank is already there.
You can keep answering. You have finished before time.
Yeah, fine. Okay. Sir, thank you, sir. Thank you for that.
From the panelist, any more questions from the panelist?
Yes.
We have 6 more minutes, sir. You can anyone can ask questions. Any more panelists can ask questions, sir.
My time was 3 to 3:20. So I finished that, but I think Shashank topic to be started at 3:30. Shashank is very interesting talk, so everybody would like to listen him more for 10 minutes more.
No, if there are any questions, you can take them. We can keep I've just shared my slide, that's all. For a change, Dr. JYOTHYDEV has changed my designation. He has made me a male health specialist.
No, but Shashank, you are expert of everything. All endocrine problems, you are the expert of everything. whether it is diabetes or whether it is a COVID also. So you are expert of everything. You want to make any comments, Shashank, on the vaccination schedule?
I think JyOTHYDEV, I wanted JyOTHYDEV to make a comment because JyOTHYDEV has written a lot of guidelines.
I was a part of that guideline also along with it.
Yeah.
Actually, in the other hall, he's coming soon.
So Sunita, a couple of
I am
comments.
here. I'm
Yeah.
proxy only.
Yeah. So you can give as much comments as Bansi can. But two things, Bansi. What do you feel if we give what you call the pneumococcal vaccine? Do you think it will offer protection of innate immunity for non-pneumococcal infections?
Not for non-pneumococcal, I don't think it can protect. It is because the 40 to 55% patients with a different, data had shown the patients with previous respiratory tract infection followed by a secondary bacterial infection, they have isolated in 29 to 54% of them have a pneumococcal disease. So to prevent that, I think it will help. But I don't think it will, for non-pneumococcal disease, it can increase the immunity. But at least that much we can prevent, Shashank.
This whole vaccine, I firmly believe in this vaccine. And in the COVID times, all of us have taken these vaccines who are above 55. So I firmly believe that we should protect ourselves. But there is one comment that is vaccine is based on molecular mimicry. So it not only prevents invasive pneumococcal disease, but I have a feeling that it probably stimulates non-specific innate immunity.
Okay.
And nowadays we are seeing in COVID, we are using BCG, oral polio, MMR. But I feel even a pneumococcal vaccine, particularly in geriatrics, one can have a good use. I can see JyOTHYDEV there, or is that his photograph there? But Dr. Sunita, I am okay to start if there are no more questions.
Yes. On a new molecule, YO.
YO plus.
YO plus is with depoxytate.
Shashank, I am supposed to introduce you, but your slide has introduced you. I have been asked to chair your session, Shashank. Once you wonderful job you did.
Yes, sir. Dr. Ekedar, yes, sir. Yes, sir.
Yeah.
So you can introduce me. You can introduce me. I have no problem.
Yeah. Can you put my video on, Bina?
Thank you, sir. Sir, there are some more questions in the question.
Oh yeah. Please finish the question. Yeah. It was dragging, so that's why I thought I'll come in.
Okay, sir.
Please ask the question.
Is there any information on co-infection with COVID with S pneumonia? And I think now Shashank can give this answer better, because with COVID, is there any isolation? But yes, we had seen that around 40 to 54% of the patient with secondary bacterial infection, if it is isolated, we will find the streptococcal pneumonia is there because it's a causing invasive pneumococcal disease. In a patient who has not been vaccinated earlier and now 65 years dead, it should have a 2 doses. No, it is only 1 dose which is required above the age of 65, irrespective of their vaccination history. If he is immunocompromised, then first you give the PCV13 and then after 1 year PPSV23. If not immunocompromised, in a diabetic patient, still only 1 dose of PPSV23 is sufficient. What is the sequential schedule for pneumococcal vaccine in diabetic patients? As we had talked, it is only once in a below the age of 65. After the age of 65, 1 more dose of pneumococcal vaccine has to be taken. So all our diabetic patients, we should give to them. Over to JyOTHYDEV now. Thanks.
Thank you, Benshimai, once again.
Thank you.
Once again, very elegant.
Thank you, sir. We'll move on to the next session. For chairing the section, I would like to invite Dr. Ashok Kumar Das. He is currently consultant endocrinologist at Pondicherry Institute of Medical Science, Pondicherry. Welcome, sir.
Yeah, thank you. Is my video on? Yeah, I think.
You can speak, sir.
Yeah. I think it's a great pleasure to preside over a session where Shashank is the speaker. I don't have to read out his biodata, and suffice to mention that he's one of the most brilliant endocrinologists of our times. He is currently the Dean of the Indian College of Physicians. He has held all the top positions, like the President of the Indian Academy of Diabetes, past President of the ESI, past President of the API, past President of the RSSDI, and OB Society and HSI, Hypertension Society. But what is most important in Sasank is his very brilliant character of reading things, assimilating things, and producing it beautifully before everybody. That's his greatest habits, and which has made him very popular. He has the gift of the gab. He is also a very fantastic person with the best of the heart connections and the best of the brain connections. The topic he's going to speak to us is very, 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 very interesting. He's going to speak to us about the latest in the erectile dysfunction. I'll just say one sentence that human beings live for three things: food, wealth, and sex. Sasank, am I correct? They're the three strongest attractions for the human ego. Therefore, the sexual dysfunction becomes of paramount importance in human being as a whole, and in diabetes in particular. Because, you know, one of the studies has shown that above 60 years of age, it is almost 100%. And between 55 and 60, it's about 66%. Some studies, Garg study showed 78%. So hugely prevalent. And it is plagued by three things: ignorance, which the Sasank is going to dispel the ignorance, and the embarrassment, which we have to do ourselves to remove it, and also the lack of information. Dear friends, I present you Professor Dr. Sasank Joshi to do the honors to speak to us about this very important, very intimate, closest to life topic in the seminar today. Sasank, all is yours.
So thank you, Dr. Das, for having this intimate subject, given to me. I have to really thank Dr. JYOTHYDEV Kesavdev. Dr. JYOTHYDEV Kesavdev is a andrologist and sexologist par excellence, and he is a global sexologist. So from Thiruvananthapuram, he treats patients in Mumbai, he treats patients in Dubai, he treats patients in United States. And if you need any time to visit a sexual health shop and you want to know any guides on what aids to buy, he's a very good, he knows all these things because he has done a special diploma in sexual aids. And I had told him long time back that he should start this as a parallel business. Unfortunately, he didn't listen to me. But I wish had he listened to me, he would have been a multi-billionaire by now. So this lecture is dedicated to Dr. I'm thankful that they have given me this wonderful topic. My good friend Dr. Juman is also here, but he's already covered his part of sex. So I am not going to discuss really, some things which are normally there. But I am going to really talk on diabetes and ED, which is a very common topic. And I'm going to see how much science we can put it into it and how we can make it a little more interesting. Are my slides shared?
Yeah, I think your first slide has come.
Yeah.
Can you advance? Yeah. It's working.
So you see, erectile dysfunction is equal to endothelial dysfunction, and it is a starting point of all cardiometabolic complications. And endothelial dysfunction is the first at which artery it starts, and obviously it is the smallest artery which gets the first hit. So obviously, throughout the arterial tree of our body, the endothelium is the same. If there's a problem in one part of the circulation, the problem will be elsewhere, but it may not be symptomatic. For example, the penile artery has a diameter of 1 to 2 millimeters. So the clinical event of the penile artery is erectile dysfunction. The coronary artery has a diameter of 3 to 4 millimeters, and the clinical diameter, which is much larger, and the clinical manifestation is TIA and stroke, and the femoral artery is much larger, and the clinical event is a claudication. So because of the small size and the greater surface area, the same level of plaque burden or endothelial dysfunction will have a differential impact, but the greatest effect is seen on the penile arteries compared to coronary artery, carotid artery, femoral artery. And therefore the penile endothelial dysfunction is the first marker and gets evident first before actually you get coronary artery disease, peripheral vascular disease, and any other vascular disease. So actually this is the first symptom test that somebody has bad vessels is ED. So ED is a systemic vascular disorder. And this is the same slide which I put in a very different way, in a different way. You can see here that if it is ED and the arterial size is 1 to 2 millimeters, it is ED. The lumen artery obstruction is much more compared to, say, a proximal LAD, which is 2 to 3 millimeters, or an internal carotid, which is 5 to 7 millimeters, compared to femoral artery, which is 6 to 8. So I hope that this slide stays in your mind and clearly tells you that penile artery is the first artery to get the plaque hit or the penile attack, which is the first attack before a heart attack, brain attack, or a stroke, or a leg attack happens. So by the time the larger arteries get significantly obstructed beyond 50%, penile blood flow is already considerably compromised. And therefore, ED is more frequent in diabetic patients, particularly when there is silent coronary artery disease, and even when though they don't have it. And that percentage is as high as 33% with asymptomatic CAD. So an erectile dysfunction predicts coronary artery disease independently of other risk factors, and is the strongest risk factor on planet Earth for silent myocardial disease. So if you have occult heart disease or a need to look at symptoms of erectile dysfunction. But things don't get that simple. They get more and more and more and more complex. So we know that diabetes can cause hypogonadism, which can, where the testes don't make adequate testosterone, that will reduce the endothelial nitric oxide synthetase, which will cause endothelial dysfunction. We also know diabetes is oxidative stress. So it's an immune inflammatory stress. When there is immunoinflammation, you get the INOS, which is the inducible nitric oxide synthetase, which is upregulated. The IL-6, which is a negative cytokine, goes up. The TNF-alpha, which is an inflammatory cytokine, goes up. And you get histological damage to the penis. And you get erectile dysfunction. But not only that, when there is inflammation, we also have something called as ADMA. What is ADMA? Asymmetric dimethyl arginine. And that is upregulated. That also causes a lot of endothelial dysfunction. So diabetes causes hypogonadism, testosterone deficiency, and the endothelial nitric oxide synthetase to come down. It also causes a lot of inflammation, which upregulates the asymmetric dimethyl arginine, which will cause endothelial dysfunction, and it will also stimulate and upregulate all the negative chemicals, TNF-alpha, IL-6, and the inducible nitric oxide synthetase, which will cause not only endothelial dysfunction, but histological damage to the penile as histopathology. So hence we can very clearly say that ED is equal to ED. And what I mean, what ED is equal to ED is erectile dysfunction is equal to endothelial dysfunction. And treating erectile dysfunction at the right time can prevent coronary artery disease at a nascent stage. So for preventing coronary artery disease in diabetic patients, there is a strong need for a drug to ensure that we treat erectile dysfunction. Professor Das, our senior doctor and our teacher to many of us, mentor to many of us, very nicely said that life has 4 pillars: love, happiness, health, and wealth. And it's important, and my good friend Dr. JYOTHYDEV, as I have dedicated this lecture for his conference and for him and his wonderful wife, Sunita, you can see love is very important. Happiness, health, wealth, all can go for a toss if there is no love. And therefore, the erectile dysfunction can break one of them, which is love, and which we all know very well. So obviously, the ED is equal to ED. Erectile dysfunction is also equal to emotional disturbance, because if there is a break there due to ED, there is a clear-cut emotional disturbance which happens. So we know erection physiologically is a vascular event, and it is a result of balance of arterial inflow and venous outflow. So artery comes in, veins go out, but the vascular event is neurally controlled. So it's important to understand the anatomy. It's a very simple anatomy. The vascular event controlled by inflow, outflow, and the neural control. So when we talk of ED, many times impotence and erectile dysfunction terms are used interchangeably. And NIH had a conference way back in 1992 which said that we should not use the word impotence because there is a stigmatization to this word, and we should use and label the term erectile dysfunction. This was the consensus development statement on impotence, where they changed the name from ED, impotence to ED. ED is difficulty in achieving erection, and the definition of ED is consistent or recurrent inability of a man to attain or maintain penile erection sufficient for sexual performance. So it is consistent or recurrent inability to attain or maintain erection, and that recurrent inability must be 3 months or greater. So it cannot be one-off. It has to be recurrent ability. That is very critical in the definition of the 1999 WHO definition, which was the first WHO first time recognized sexual dysfunction in ED only in 1999, much later. Dr. Das alluded to this, that if you are above 70 years, then 95% of likelihood of facing difficulties with erectile function. While if you are 40 years old, it is 5%. These figures will vary. And there are two major types of ED. One is psychogenic, caused by emotional stress and psychiatric disease. And therefore, there are 3 doctors which are involved in ED management. One is psychiatrist, second is urologist, and third is endocrinologist or diabetologist or physicians. 10 to 50% of causes of ED are psychogenic, while organic ED is caused by vascular, neurologic, endocrine, and physical disease, usually in 50 to 80% of the disease. So there is also something called as primary erectile dysfunction and secondary erectile dysfunction. Primary means it's a condition in which man could never attain or sustain erection. Neither attain nor sustain. That's the key word. No attainment, no sustenance. It is rare, usually, always due to psychological factors, guilt, fear of intimacy, depression, severe anxiety, or clinically obvious anatomic abnormalities. So anatomical abnormalities are rare, but it's usually guilt, fear of intimacy, depression, severe anxiety. Even excessive watching of porn can lead to primary erectile dysfunction. It has been now documented because of sensory overload. One can get into a severe anxious syndrome. Secondary ED is what we see as doctors, and it is a condition where somebody could sustain or attain, but now it cannot happen. It has an organic etiology, and in many men with organic disease, ED leads to secondary psychological difficulties, compounding the problem. So are there risk factors for erectile dysfunction? Well, the waist circumference, smoking and alcohol, diabetes, hypertension, stress, anxiety, unhealthy diet, physical inactivity, smoking, alcohol intake, all of them are clear-cut there. So we know that ED can be caused not only just by anatomical disorders, but hormonal disorders like hypogonadism or hypopituitarism, peripheral disorders, neurological disorders, vascular disorders, and never forget drugs which cause ED. So the commonest drugs which cause ED are antihypertensives like beta blockers and diuretics. Never forget them. Antidepressants like tricyclics, antipsychotics like carbamazepine, simple antihistaminics. I had a patient just 3 weeks back in the lockdown, was very frustrated and almost landed up with a separation with his wife, and because of the fear of the corona was taking antihistamine, and because of the antihistamine intake for 2 months landed up with a severe ED. It's a very common cause. Simple H2 blockers like cimetidine, ranitidine are very common causes of ED, and recreational drugs, of course, like tobacco, alcohol, and many others. So remember, don't forget antihypertensives, tricyclics, antipsychotics, anticonvulsants, antihistamines, very common, and H2 blockers like cimetidine, ranitidine. Now, it is important to understand that a penis can be flaccid, and it's important to understand an organ in the penis called corpus cavernosum. This is the sponge filled with a lake of blood in the penis during erection, and it is the cavernosal arteries which run along each of the corpora cavernosa. So basically, the facilitation of a penile erection is due to a flood inside the corpora cavernosa, and it's very, very important to recognize that in a very simplistic way. The other term which we need to understand, so one was the corpus cavernosum, second is the corpus spongiosum, that is the mass of spongy tissue which surrounds the male urethra within and inside the penis. And that's very important because the function of corpus spongiosum in the erection is to prevent the urethra from being pinched or closed, thereby maintaining the urethra as a viable channel for ejaculation. So spongiosum is important for ejaculation, while the cavernosum is important to maintain the erection. So erection is cavernosum, 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 and ejaculation is spongiosum, spongiosum, spongiosum. That's how it is. So pathophysiology of erection is normally neural signals are sent by the NANC mediator. Once the NANC mediator is activating, the nerve cells in the penile corpora cavernosa start producing a lot of nitric oxide. This nitric oxide stimulates the guanyl cyclates, and this guanyl cyclates converts the GTP to cyclic GMP. This cyclic GMP causes relaxation of arteries, increases the blood flow, and this needs to be sustained. And that sustenance is done by a very key enzyme, and it is the phosphodiesterase. And this phosphodiesterase is decomposing the cyclic GMP, turning it back into GTP. So if you want to have the cyclic GMP prolonged, as long as the brain is sending messages down the nerve fibers in the artery to generate nitric oxide and keep the cycle going. So basically what the phosphodiesterase is doing is keeping the erection going with a lot of nitric oxide available for blood flow. When the brain stops sending the signal, all the cGMP goes away because the phosphodiesterase is deactivating it. So if we switch off that by a tablet, which is basically a phosphodiesterase inhibitor, then obviously the erection is maintained, and that's what most of these molecules do. So clearly, this is a histopathology of a flaccid penis and an erect penis. And you can very clearly see the spongiosum as well as the cavernosa, and you can see how the cavernosa is bloated up in an erect penis, and the spongiosum is maintaining the urethral aperture for the ejaculation. So the key critical enzyme is the phosphodiesterase type 5, which breaks down the chemicals caused by the muscles to relax and allowing the muscles of the penis to constrict and the veins to open. And that allows the penis to retract into a soft flaccid state. So clearly we know that cyclic GMP reduces concentration of calcium, smooth muscle relaxation, increase in the flow of blood into the penis, and you get a very good erection. But unfortunately, diabetes, almost 30 to 70% of male diabetics have some degree of erectile dysfunction, erection problems in their lifetime. And men who have diabetes to develop erectile dysfunction usually get it around 10 to 15 years earlier than the men who don't suffer it. So why is it in diabetics? Because diabetics have abnormal metabolism, they have a lot of oxidative stress, their endothelial nitric oxide is poor, they get endothelial dysfunction, and they get ED. And ED is a recognized marker of vascular disease. CAD, all-cause mortality is gone up, and it's a marker of silent CAD. And the time window between ED onset and CAD event is 2 to 5 years. But erectile dysfunction also causes problems like premature ejaculation. Just like you get erectile dysfunction, premature ejaculation is ensuring that people get ejaculation quick. What is the definition of premature ejaculation? The definition of premature ejaculation is that a male sexual dysfunction characterized by ejaculation is always or nearly always prior to, with or within 1 minute of vaginal penetration. Inability to delay the ejaculation on all or nearly vaginal penetrations. So the DSM-4, and now of course there is DSM-5 available, they call it IELT. I am sure many of you all know this. IELT is the intravaginal ejaculatory latency time, and that has to be a minute or more. So persistent or recurrent ejaculation with minimal sexual stimulation before or shortly after penetration and before the person wishes it is premature ejaculation. So P is a very, very specific entity. It is basically persistent or recurrent ejaculation with minimal sexual stimuli either before or immediately at penetration and much before the will of the person is there, and the IELT is virtually less than a minute, and that is something which we know. And therefore the key index for measuring drugs which increase the ELT, intravaginal ejaculatory latency time, is something which is there. How do you classify PE or premature ejaculation? Lifeline premature ejaculation, 80% of people within 30 to 60 seconds, or 20% will have 1 to 2 minutes. Usually it is from the first sexual encounter and with nearly every woman. So that's a lifelong problem, which is called as a lifelong premature ejaculation. It needs to be analyzed. You need to do the IELT properly. There is also something called as acquired premature ejaculation, which is normal ejaculatory function initially, but later on you get premature ejaculation. So ejaculation has 3 phases. The physiology of ejaculation is emission, bladder neck contraction, expulsion. Emission is defined as deposition of seminal fluid on the posterior urethra. Semen is pushed into the urethra by contraction of prostate, seminal vesicles and vas. Clearly, we know that emission phase, when the deposition of seminal fluid from vas deferens, seminal vesicles and prostate to the posterior urethra is very well seen, and you can see the role of the spongiosum. The erectile tissue of the corpus spongiosum and the bulbospongiosus muscle has a huge role in coordination of the emission phase, where the seminal vesicles from vas deferens, seminal vesicles and prostate from the posterior urethra is being led. The second important thing is bladder neck contraction. Bladder neck contraction is a sympathetic stimuli of alpha adrenergic receptors. So bladder neck closes so that semen is not pushed into the bladder. So this is a reflex, and usually this is something which we need to recognize, and we often forget the bladder neck contraction. And the third phase after emission and bladder neck contraction is the expulsion phase. And we know this very well, that the somatic nervous system, which is the brain, actually controls the expulsion phase of the ejaculate, and the rhythmic contraction of urethra ejects as semen, and that is something which is extremely well coordinated function of the expulsion phase. What controls ejaculation is serotonin, serotonin, serotonin. Serotonin from the brain is a key substance which prevents ejaculation, and if your levels of serotonin are low, you can experience premature ejaculation or ejaculation in short time. That is the simplest way of calling premature ejaculation. So how do you manage erectile dysfunction? Well, lifestyle, eat well, quit tobacco, stop alcohol, regular exercise and medication. Which medications? You have this YOS symposium here, which is tadalafil, which is still the best among the logs. Sildenafil and vardenafil are also there, but you know the half-life of tadalafil is almost 17.5 hours. Onset of action is the fastest. It is a fastest acting PD inhibitor, 15 to 20 minutes. Occasional side effects of headache, flushing, stuffy and runny nose are there, but compared to sildenafil and vardenafil, they have lesser of them. And sildenafil, vardenafil often cause upset stomach, which the tadalafil doesn't cause. And uniquely, tadalafil has 80% bioavailability compared to sildenafil or vardenafil. So the whole reason, you know, and this was the last of the PDE5 inhibitors which was discovered. How does the tadalafil work? We all know that the brain signals go and there are nerve signals sent to make the corpus cavernosa make a lot of nitric oxide. And we know nitric oxide stimulates the GTP to GMP, and we know the PDE5 is decomposing to cGMP, and tadalafil is a very specific PDE5 inhibitor. And in absence of PDE5, the cGMP will not convert into GTP. More GMP is available, so high blood flow for penile artery and a proper erection. So that's something which we know. Why is tadalafil better than sildenafil? It is more acceptable, improves sexual confidence. Minimum dose of 2.5 is needed. It could be 2.5, 5 or 10, but usually most patients do very well with 2.5 and 5. Do not need to plan sexual activity because of long half-life. So there is no stress compared to sildenafil, where you have to plan the sexual activity within 4 hours. And the onset of action is quicker and faster. So it gives you a lot of flexibility, improves sexual confidence, and therefore clearly now globally in the sexual world, tadalafil is far ahead of sildenafil citrate, which we know now. Sildenafil citrate has other uses like primary pulmonary hypertension, etc., and also has some serious adverse events which tadalafil is devoid of. What about premature ejaculation? Well, premature ejaculation, we need to do a detailed medical and sexual history, physical examination, appropriate investigations, and biological causes of genital and urinary tract infection have to be ruled out. The treatment of premature ejaculation is a lot of behavioral therapy, psychological therapy, and of course, pharmacological therapy. The aim of pharmacological therapy is to restore the IELT, intravaginal ejaculatory latency time. We have to go beyond a minute or two, address relationship issues, a lot of intimacy counseling and confidence building measures are needed. And one of the treatments of choice is serotonin in the brain, serotonin.
Sir, time is almost up.
And depoxitin, these are my last two slides. Depoxitin is a short-acting selective serotonin reuptake inhibitor. It is the first SSRI which is approved worldwide for treatment of premature ejaculation. It is safe and effective. It is approved in European countries, Asian countries, and very clearly it inhibits the serotonin reuptake, increases the serotonin level, expulsion phase, delays ejaculation. So that's clearly there, and often we combine the patients who have ED and PE together with tadalafil. That's what we do. These are my last 2-3 slides. We know that heart attacks occur because of ED, and we know also never rule out hypogonadism in them. And statin, testosterone, PDE are directly related to age-related mortality. And this is the Gomez curve, and you can see that estimated mortality of a man with statin treatment is very similar to estimated mortality of a man, and the curve separates here with PDE5 treatment. So actually you can see the mortality impact. So the first recommendation is, if you are suspecting coronary artery disease, ED is the first sign, and it is probably signifying a severe coronary artery disease. The level of recommendation is level 1 grade A. And obviously we know that the second recommendation is the time interval of onset of ED symptoms and CAD event is 2 to 5 years. So obviously you get some time to identify CAD symptoms of cardiovascular event. So the level of recommendation is level 2 grade B. That is something which is very clearly seen. Again, I'm going to skip the slides, but remember that erection is important, ejaculation is important, sexual health is often not talked. We are very shy to talk of it. I have been grateful to Dr. JYOTHYDEV for including this topic, particularly because our diabetics often have this problem. And I think the sexual attack, probably emotionally as well as physically, is more deleterious to health compared to even a heart attack. Thank you.
Thank you, Sasank, for a wonderful talk. Really, you have given the latest. I have only two things to start with to ask you. Number one, Government of India has accepted. We had a lot of women health initiative, bone health, menopausal health, and the nutrition, vitamin D. But the only criteria for the male health initiative, or one of the most important criteria of MHI, is if or she is a diabetic, to look for it. No, I'm not joking, Sasank, erectile dysfunction. Because as you rightly said, MHI, CAD, the marker is erectile dysfunction. The second thing I'd like to tell you, your comments on that. Second thing I'll tell you that like Paresh Dadora had showed, you have beautifully said about the younger age testosterone deficiency in diabetic. You can outline the treatment for the people. Just remember the question. Third and last question is very simple. Now, we know, as you rightly touched upon the point, sex in India is a taboo. People do not speak. Should we voluntarily ask them and give them the treatment, or what's your comment on that? 3 questions my side before it's open to everybody.
I'll answer the last question first. We must voluntarily ask them.
Yeah.
Because people are shy. Men are more shy than women.
Yeah.
Okay, so that's very clear cut.
Yeah.
Second thing is very clear that MHI is equal to coronary artery disease. So
Exactly.
this is the sexual attack is having more devastating consequences. And I don't have such elegant slides like Dr. Deepak Jumani. He has explosive slides about all these things, which are wonderful. And he has an environment, ambience. He makes everything dark. I wanted to, so it's a wonderful way he presents. And what was the middle question, sir?
Middle question was the testosterone deficiency.
Yeah. So that I didn't touch on because I think I was losing out time.
Yeah.
And my good friend Mithun Bhatia is also here. He's a very elegant sexologist,
I know.
reproductive endocrinologist from Guwahati. And I have to be thankful that testosterone slide is known from him. And that testosterone, very clearly there is data from not only Dr. Dandana's group or Shelly Bhasin's group, that hypogonadism, and if there's a testosterone deficiency, replace it. It matters. It is just like estrogen deficiency in women. So that's very clear.
Yeah. Now we'll have a lot of questions from the audience. You can either post it on the QA or in the chat box. Let us start. Did you have any question in your question and session?
Thank you for that, sir. We are moving on to the next session. We are out of time now. And next we have the Sanofi Symposium, the Basal Insulin Symposium. And for moderating the session, I would like to invite Dr. Jayalakshmi R. Kurup, who is a Senior Medical Officer at Cochin Port Trust Hospital, Cochin, and also Dr. Chandani R., who is a Professor of Medicine, Head of Department of Emergency Medicine, Government Medical College, Calicut. Welcome all.
Good afternoon. I'm audible, right?
Yes, ma'am. Yes, ma'am. Continue, please.
Okay. Thank you. At the outset, I would like to express my sincere thanks to Dr. JYOTHYDEV sir and the entire team of Jpef for making me a part of this annual academic extravaganza. It's an honor and privilege to co-chair this session with Dr. Chandani ma'am. The past 3 decades have seen a quadruple rise in the number of people affected by diabetes mellitus worldwide, with the disease being the diabetes being the 9th major cause of mortality. Type 2 diabetes often remains undiagnosed for many years, owing to its asymptomatic nature during the initial stages, during which body is exposed to hypoglycemia, bringing about irreversible organ damage. In India, 70% of diagnosed diabetes cases remain uncontrolled. Current guidelines, though, endorse the initiation of insulin early in the course of disease, specifically in patients with HbA1c more than 10%, as the use of oral agents alone is unlikely to achieve glycemic targets. It also stresses the timely and appropriate use of basal insulin in type 2 diabetes. Last year, a paper was published in the Journal of Diabetes Therapy by a panel of experts in the field of diabetes called BSMART, that is Basal Early Strategies to Maximize HbA1c Reduction and Oral Therapy. And the expert opinion was focused on the timely and appropriate use of basal insulin in type 2 diabetes mellitus treatment. To talk more on this topic of basal insulin in type 2 diabetes mellitus, the changing Indian perspective, I would like to invite Dr. JYOTHYDEV Keshavdev sir. He has done his MBBS and MD from Government Medical College, Trivandrum. His endocrinology fellowship training at Mayo Clinic, USA, FRCP from London, Glaxo, Edinburgh. He is the chairman of JYOTHYDEV Diabetes Research Center, Trivandrum, Kochi, Attingal. He is the vice president of Aero Kerala chapter. He is reviewer of more than dozen index endocrinology journals, including Diabetes Care, Diabetes Therapy, IJEM, etc. He's the associate editor, Journal of Diabetology, publishes a monthly internet-based free diabetes newsletter for the past 11 years. He's the first author for Indian guidelines on vaccination, insulin pumps, and glucose monitoring. Pioneer in cost-effective treatment of diabetes with use of telemedicine and technology. He has delivered lectures in ADA, IDF, and ATTD Europe. Lectured in more than 500 forums within India and in more than 20 countries.
Thank you. Thank you.
Over to JYOTHYDEV sir.
Yeah. Thank you, Dr. Jayalakshmi, for the nice words of introduction, and thanks to the co-chair, Dr. Chandani madam. So I am sorry that we abruptly stopped the earlier session on sex with our Shashankji, and prior to that was our RSSDA President Benshi Sabu, since we have to accommodate speakers from other countries. So thank you so much. And this is my topic. Basal insulin in type 2 diabetes, the changing Indian perspective. So these are my disclosures. So let me start with a couple of questions. Number one, which is the safest and time-tested therapy for diabetes? So the question is very precise. The safest, the oldest, and the time-tested therapy for diabetes. And this is a crisis for all of us. And this is a global pandemic, and all over the world, not only the doctors, the entire humanity is in a crisis. And during a critical illness, when all the oral therapies are contraindicated, when the patient is in the ICU, for example, which is the only therapy for diabetes, which is the safest? Of course, there is only one answer, and that is insulin. Again, during this crisis, when management of diabetes is of significance, the pivotal importance, very, very important in managing hyperglycemia, which is that insulin which can be initiated safely. And the last question is, which is the relatively inexpensive, potent, and safe insulin which can be initiated during this crisis? And the answer for these questions will be a basal analog insulin. And there are multiple reasons why we have arrived at this consensus. And this is the story of diabetes during the COVID days. More than 60% of COVID deaths in India are in subjects with uncontrolled glucose. And we all know that the numbers with diabetes, numbers with COVID are increasing in India and all over the world. And diabetes is now recognized along with hypertension, as we are well aware, and even a layman is currently aware, that it is a very high risk factor for severity in COVID infections, for the patients getting admitted into the ICU. And as a registered medical practitioner, how can we, as a doctor community, serve the society during this critical point of time? And the solution, I believe, is safe insulinization. Safe insulinization, since the patient safety comes first. This is a screenshot from our diabetes telemanagement system over the last more than 12, 13 years of the patient being followed up. And this is the first visit. That was 15th July in 2008. She is still on a regular follow with us, both virtual and in-person visits. In the year 2008, when the A1C was 8.7, she was initiated on Landes 6 units. And currently, during the last visit, it was 6.3. The A1C was 6.3. The dose of Landes is currently 8 units in combination with a gliptin and metformin. And this is the magic of U100 Glargine. A consistent glucose control, a durable glucose control over the years, over more than a decade, without not even a significant increase in the dose of insulin. And there has been a transition happening recently in India. This is the Diabetic study. And earlier, a decade ago, in India, majority of our patients used to be on premix insulin. And it's only 13.8% of the population on basal insulin in that study. But currently, there is a steady increase in the use of basal insulin. There is a steady increase in the adoption of basal insulin. And this has happened since the turn of this decade. And look at the landmark study where the basal insulin is scoring high and premix comes next. And why that shift has happened? So these are the changing realities. So there used to be a thought, and these were the perceived barriers or the beliefs that insulin of choice in India should be a premix insulin. And there was a reason for that. It was thought that the Indian patients had a very high A1C value, and hence the patient should be put on a premix insulin. But this is a very, very familiar picture for all of you, a cartoon demonstrating that when there's a high A1C, the major chunk, the contribution is from the fasting glucoses. And when the A1C drops, the contribution from the fasting gradually gets reduced. So when you are targeting the fasting glucoses with a basal insulin, you are definitely going to target both. You will target both and you reach your targets. And this is one such example. You have 9 randomized controlled trials over there. You have Inside, you have Apollo, you have Laptop, all of them with a baseline A1C of close to 9%. And with U100 Glargine at 24 to 36 weeks, there is a remarkable drop in the glycated hemoglobin to 7 or even below 7. So U100 glargine effectively can reduce the glycated hemoglobin to less than even 7% in those eligible type 2 diabetes patients. And this was another perceived obstacle, that basal insulin will not provide a postprandial coverage. Of course, there is a reason for that, but you look at this one. This is a subgroup analysis, a sub-study from the origin clinical trial, where the patients who were enrolled were having early type 2 diabetes. And this is a subgroup of those patients where the fasting glucoses were targeted to below 100 milligrams. And they were measuring the postprandial glucose excursions, the standard deviation, mean amplitude of glucose excursions. And this was compared with those without diabetes, with a control population. It was found that when the fasting is aggressively and intensively controlled to below 100, the postprandial glucose excursions, the MAGE, all of them were comparable to those with a normal glucose tolerance. So a stricter fasting glucose control mitigated the PPG excursions without an increase in hypoglycemia. So this is the fasting, and this is the postprandial baseline and 12 weeks, and the significant pronounced drop in the glycated hemoglobin from 11.5 to 7.7% with a basal insulin. So now moving on to the question on why basal insulin and how basal insulin. And this presentation is typically for the COVID crisis. Why basal insulin? Why? And here is the recommendation. These are the recommendations from all these scientific organizations, the International Diabetes Federation, the American Diabetes Association, the RSSDI, all of them recommending basal insulin either alone or in combination with metformin. Of course, you start with metformin. And this is one of the safest and most convenient insulin to initiate. Back to origin trial, again, an analysis on the sustainability. And this is something which is replicable. And you remember the patient whom I have shown you from our electronic medical records. And this is over a period of 7 years in the origin trial. And glargine, in contrast to the standard of care in diabetes with U100 glargine, there is a sustained glycemic control, and origin and later on devote, and they have all shown the cardiovascular safety of analog basal insulins. And when compared to premix insulin, this is the initial trial, a basal insulin will have significantly less hypo events, significantly less weight gain, and there is a significant reduction in the total dose of insulin. And now the question on how basal insulin, how are you going to administer or initiate basal insulin? And this is one guide, an approximate guide, a recommendation for the body weight, since one dose doesn't fit all of our patients. So this is a patient with 60 kilograms body weight, and on the other end of the spectrum, you have 100 kilograms. So you can start with 0.2 units per kilogram, or you can start at 0.3 units per kilogram based on the baseline glycated hemoglobin value. Of course, the dose at which an insulin is initiated depends on multiple factors, such as the concomitant oral medications. So this is a recommended algorithm, a titration algorithm, B-SMART recommendations. So you start basal insulin and then keep on measuring the fasting glucoses. You can take the average of 3 most recent fasting glucose values and then increase the dose of insulin by 2 units if it is above 130, by 4 units if it is above 160, by 6 units if it is above 180 milligrams per deciliter. And this titration can be performed once in every 3 days. That is once or twice every week, depending upon the necessity, since all our patients will have customized glucose goals. It can be a customized FPG, it can be a customized glycated hemoglobin goal. But as a rule, we need to be more aggressive during this crisis. A couple of our own observations on early insulin initiations, and this is in newly diagnosed or with the diabetes duration of less than 1 year, a total of 5-year data, and these are 452 subjects from our electronic medical records. And this is the baseline A1C of 9.7, and this is at the end of 5 year, the glycated hemoglobin of 6.3%, with majority of the patients controlled only with a metformin monotherapy. Another one, and this is on improved short-term and long-term outcomes with early insulin initiation in type 2 diabetes over 1 decade. And this has been published in Endocrine Practice. And this is along with Dr. Shashank Joshi and Dr. Benshi Sabu, our previous speakers. And these are the observations. 57 patients from the electronic medical records, and this is at the end of 10 years. So we have de-identified those patients whom we had data for as long as more than 10 years. So this is the glycated hemoglobin at baseline, 10.9. And this is at the end of 10 years, 7.5. And this is this is at the end of 10 years, the total daily dose of insulin. So this is something I wanted to emphasize. The total daily dose of insulin need not increase, need not exponentially increase over the years if the patients are initiated on insulin early in the natural course of diabetes. Because we are going to salvage the beta cells if insulin is initiated sufficiently early. And our presentation at the ACE at Austin, Texas, it was highlighted in the newsletters at ACE. And these are some of the newsletters highlighting our study on early insulin therapy, improving and the long-term benefit in type 2 diabetes. So moving on to the question on the adherence. So when compared to the premixed insulins, so this is the diabetes treatment satisfaction questionnaire, the adherence, the patient adherence to the basal insulin, to glargine, is much higher. And this is 94%. The treatment adherence basal insulin, the baseline DDSQ score and the end of study DDSQ score, 94% of the patients are willing to continue Lantus. And when compared to a real life experience, because I have been using Lantus since 2002, I would say that probably I have no discontinuations from the patient. It is a 100% tolerated insulin. And this is the celebration of 100 years of discovery of insulin. And it's going to be in 2021 to commemorate 100 years of discovery of insulin and the insulin delivery devices. We recently published this review on the evolution of insulin delivery devices. Insulin has established itself as the most potent glucose lowering therapy and one of the most safest and time-tested therapy in diabetes. I have started with questions, and let me end my presentation with one question, which is the largest selling insulin in the world? And there is only one answer, and that is Lantus, because that insulin has been a very safe insulin, convenient to titrate. And during this COVID crisis, basal analog insulins will be highly acceptable in India, recommended by all the international and country-specific guidelines, and quite easy for the titration, both patient-driven and physician-driven. And in this pandemic, let us, the doctor community, help our patients survive. So thank you. Thank you so much for your patient hearing.
Thank you,
Thank
sir.
you so much, sir.
I would like the moderators to now introduce the next speaker.
Okay.
Dr. Jayalakshmi, would you like to add few points? Or
I think they have asked to introduce the next speaker.
okay, okay, okay. Thank you, Dr.
We will have a discussion, ma'am. After this session, we will have a panel discussion.
Thank you.
Now you can introduce the next speaker.
Okay.
Thank you.
Thank you, Dr. JYOTHYDEV, for giving me this opportunity and making this stressful COVID time to a learning time. And in fact, we are all seeing very much uncontrolled diabetes, and that too with many fluctuations. And it's really interesting to have this symposium today. And we have the second topic, evaluating role of second generation basal insulin GLA 300 from initiation to titration to maintenance phases. And as we all agree that when we want to treat diabetes, we want to achieve glucose control, and we need to have a timely initiation without hypoglycemia. Can I have the introductory slide, please? Okay, I'm happy to introduce Dr. Kamlesh Kanti. He's Professor of Primary Care Diabetes and Vascular Medicine at University of Leicester, UK, Director of UK National Institute for Health Research in Applied Research Collaborations, East Midlands, and Director for the Real World Evidence Unit. And I'm very happy to see that he is the principal investigator of several major national and international studies, and is advisor to Department of Health, member of International KDIGO in Diabetes and CKD, National Institute of Health and Care Excellence. And he has many achievements and awards, and he has over 750 scientific publications, and he is going to talk on a very important topic which is going to be very useful all of us in day-to-day practice. Forward to Dr. Kamlesh Kanti.
Thank you very much for those kind introductions. Can you hear me all right?
Very much, very much.
Yeah, Dr. JyothyDev, colleagues, real pleasure, and thank you for the introductions. I will share my slides now. Okay, can you see my slides?
Yeah.
Wonderful, thank you. My topic is evaluating the role of second generation basal insulins. Dr. JyothyDev gave a really nice overview of why basal insulins. I'm going to take this the next step in terms of the longer acting basal insulins. But before we go on to that, I'll just give you my disclosures.
Your video is not working now.
Okay, let me just
check. Can you click on the video? Yeah.
Yeah, working now?
Yeah, fine.
Excellent. Okay, have you got my slides now? Can you see my slides again?
Yes, perfect.
Excellent. Okay, Leicester Diabetes Center. Leicester at the moment is in crisis. We are now dubbed the Wuhan of UK because we've had a massive rise in cases of COVID, but we are dealing with that locally. Leicester is a beautiful city, 100 miles north of London, and the majority of people in Leicester are of Indian origin. 50% of Leicester is non-white. Professor Melanie Davies and I are the co-directors of this center. We have a number of positives, which include a fantastic football team. We've got King Richard III, who was buried here. And it's a lovely market time if you're ever here, because the best Indian food outside of India is in Leicester. Well, the next few minutes, I'm going to just go through some of the evidence and the recommendations, the evidence in particular for tight glycemic control, the real world implementation of what we see from the evidence, the consequences of not applying that evidence into clinical practice, and some methods of overcoming and some tools that we may have for managing people with type 2 diabetes. In terms of the guideline recommendations, Dr. JyothyDev has already mentioned, all guidelines now recommend basal as the first approach, as you can see here, and even ADA guidelines have said that basal insulin is the most convenient initial insulin regime in people with type 2 diabetes. I'm not going to dwell too much onto the evidence for tight control, but we know as far back as UKPDS, we showed that this reduction in hyperglycemic legacy over 20 years reap the benefit later on in the 10-year follow-up of the trial, with reductions in microvascular complications, reductions in myocardial infarction, and significant reductions in all-cause mortality, the so-called legacy effect of all the metabolic memory. But since then, there's been a number of trials initiating even insulin from newly diagnosed patients showing the legacy effects. So we have fantastic guidelines, fantastic recommendations, and one of these is this guideline here, the ADA ESD consensus report, which has been updated with John Buse as the key author for the next guideline. As you can see, now the evidence base is strong for people who have established cardiovascular and CKD, and we should be initiating with GLP-1 receptor agonist or with SGLT2 inhibitors with proven benefit. Then we need to consider risk to minimize hypoglycemia, risk to consider weight loss, and obviously cost is the major issue. And most people, when I ask at the audience, and I'm sorry, we can't be having a live conference, but every time I've asked the audience, everyone knows about this. But what people don't know is this one here on the right-hand corner to me, which is the most important thing, saying that to avoid clinical inertia, we need to modify and reassess our patients every 3 to 6 months. And we used to call this clinical inertia, but we have now redefined this as therapeutic inertia, as failure to advance therapy or de-intensify therapy when appropriate to do so. De-intensification at the right time is also important so that we don't harm our patients, but I'm not going to go into that in detail today. In terms of therapeutic inertia, we used to think that the major hurdle was when we came to basal insulins or insulin initiation and then insulin intensification. However, we now know that inertia is pertinent throughout the paradigm of management of type 2 diabetes. Now, this is data on 80,000 people in the UK. This is on the left-hand side, people who were on one oral therapy, people on 2 oral therapies, and here going on to insulin. And all these patients had an HbA1c above 7.5%. We excluded people with an HbA1c below 7.5%. When people are on one oral therapy, we wait a median of 2 years before we intensify with the next therapy. When they're on 2 therapies, we wait a median of 7 years. And when people are on 2 or 3 oral therapies, we wait a median of 6 years before we initiate insulin. So we're waiting far too long despite all the great evidence that we have. This is Bansi Sabu, who collected data from 18,000 people. This is prospectively collected from the physicians in India, and this was presented at IDF, and we're just writing this up at the moment. And what we see here again, that inertia occurred in 73% of the patients who presented to physicians in India. And these are the predictors of inertia. People who were elderly were more likely to have inertia. People who were on more oral therapies were more likely to have inertia. And for some reason, people who were on insulin didn't have any inertia. If we look at the global data for inertia in terms of initiating basal insulin, this is the SOLVE study, 24-week observational real-world study of nearly 17,000 people. And this is the baseline at which HbA1c at which insulin is initiated in these various countries. And you can see it varies from 8.3% in China to 10% in UK and Turkey. UK has always been bad for insulin. But that's not the worst thing. In terms of intensification, as I mentioned to you, there's also an inertia there as well. So at 24 weeks, we know from randomized control trials that we can get up to insulin doses of 0.5 units per kilogram to even 0.8 units per kilogram. This is Julio Rosenstock study. But in the real world study, in the SOLVE study, as you can see, some started insulin at a low rate, 0.1 units per kilogram, and at 24 weeks, they went up to 0.45 units per kilogram. In others, they started at a high dose, but did not intensify at 24 weeks. And the mean insulin dose at initiation was 0.15, and at 24 weeks, the mean dose was around 0.3 units per kilogram, despite these people not getting any hypoglycemia. This is a nice paper from India. This is using Delphi consensus method. And again, this showed that in India, insulin doses remain low. 18 units is the current mean dose that people get up to. Although again, in the Indian scenario, titrations of up to 40 units can be done safely. And this is the first consensus document that's been generated by Delphi on insulin titration. The reason it's important that we get people to target early is if we do not get them to target early, then we're not going to get them to target later on. And this is a study we did of over 45,000 patients using electronic records from 6 countries. Dedek Mauricio was the initial author on this one. And what we see in this study is that if patients do not get to target at 3 months, then they are 4 times not likely to get to target at 24 months. So it's really important that we get patients to target at 3 months, because if we get to target at 3 months, we're more likely to stay on target at 24 months. The reasons for inertia are varied. It's very complex, so we can't go into detail, but some of these hypoglycemia, lack of education, complex regimes, weight gain, resource issues, and lack of adherence as well. One key reason is hypoglycemia. And this is the global HAT study, and Ramu from India was the principal investigator from India on this study. What we saw in this study is that overall, this was the first prospective study of over 25,000 from 25 countries where we did diaries for 1 month, which is a better way of ascertaining hypoglycemia. Overall hypoglycemia rate, as you can see, about 14 per person per year in Southeast Asia. So this is mainly India. When we come to nocturnal, about 3. So you don't see much difference. They're similar to what we would see globally. But for some reason in Southeast Asia, the proportion of people having severe hypoglycemia was much, much higher, significantly higher. So global was 2.5 units per person per year for severe hypoglycemia. In Southeast Asia, 3.4. Now, we're not sure why this was, whether it was the regimes of insulin used, whether there was no education, but we do not know the exact reasons for this. So we know now that inertia does occur despite having good quality randomized control trial evidence. What's the consequences of inertia? Well, this is a really nice study from the US showing people who with type 2 diabetes who had inertia compared to those who didn't have inertia. So they were titrated in terms of their management in an appropriate manner. And at 5 years, we see that those who had inertia had a 5-fold increased risk of progression to diabetic retinopathy. So showing that inertia is associated with diabetic retinopathy. This is a study, Sanjoy Paul, who did the UKPDS analysis, and now he's in Australia. And I did this study looking at people exactly like UKPDS, newly diagnosed patients, and then we followed them up for 5 years, retrospective analysis. And we looked at patients who got to target within 12 months to below 7%. And this was about 74% of the population got to target from diagnosis within 12 months to below 7.4%, but 26% didn't get to that target. And over 5 years, what we see is that there's an increased risk of myocardial infarction, strokes, heart failure, and composite cardiovascular event. So inertia leads to worse outcomes in terms of cardiovascular outcomes. And finally, this is a really nice study from the US that looked at inertia and mortality. And what this analysis was done very well. Then they looked at years since diagnosis and inertia by year. So if there was inertia, this is 8%. So not getting to target of less than 8%. If there was inertia for 7 years, there was a 64% associated risk of mortality. If there's inertia for 3 years, there was a 37% risk association with mortality. So now we have data showing that inertia leads to microvascular complications, macrovascular complications, and mortality as well. So what can we do to overcome inertia? Well, there's a number of interventions, education like we're doing today, trying to improve adherence, trying to improve guidelines, developing quality measures. And there are some interventions that have been shown to improve management of people with insulin, self-management education programs, empowering primary healthcare professionals, to improve care, insulin and analogs and combination therapies. And in view of time, I'm not going to go into detail. All of these interventions have been shown and have an evidence base based on randomized control trials to improve outcomes. We also know that adherence is poor, and we need to improve adherence because self-reported adherence, we've shown, Melanie and I showed this a few years back, is about 43 to 80%. But again, randomized control trials have shown that education of these people can improve adherence, proportion of people reaching target outcomes, and long-term complications. Now, the final phase of mean is the tools that we have, and we have heard from Dr. JYOTHYDEV regarding insulin glargine, which is a great insulin in terms of basal analogs, but now we have the longer acting. We have two longer acting ones, have a profile that lasts anything from 36 to 48 hours. And here we have two insulin degludec and insulin glargine 300. And I'm going to show you the efficacy to effectiveness data. So efficacy, where we say it's the randomized control trial here for a number of studies that have been conducted with insulin glargine 300, and effectiveness, the real world implementation of this to see does this do exactly the same as what we see in randomized control trials, which is very, very important because the people in the real world setting are very different, as you all know, compared to randomized control trials. Sanofi have a huge program, so do Novo in terms of looking at randomized control trials and the real world evidence. But in view of time, I'm just going to go through a couple of studies. And first of all, let's look at insulin glargine versus insulin degludec in terms of trial level meta-analysis. So this is the addition program here. And this is the begin program for insulin degludec, addition for glargine 300. Both of them comparing to glargine 100. And as we can see with addition, anytime hypoglycemia, a 20% significant reduction. And as I said, must stress this is study level meta-analysis, not individual patient level. And when we look at nocturnal hypoglycemia for glargine 300 in favor of that, for 25% relative reduction compared to glargine 100. When we look at insulin degludec trial level meta-analysis, no difference in terms of anytime hypoglycemia, but a significant reduction of 21% in favoring insulin degludec for nocturnal hypoglycemia. Now, it's very difficult to compare these because they're different trials, different patient populations as well. So the only way one can do this is by having head-to-head trials, and we're very fortunate that we have two head-to-head trials now. BRIGHT study comparing insulin glargine 300 versus insulin degludec 100, and CONCLUDE study insulin glargine 300 versus insulin degludec 200. I have a conflict of interest with both, and because I've been involved with some analysis for both of these studies. BRIGHT study is a multi-center, one-to-one randomized control trial comparing, as I mentioned, glargine 300 with insulin degludec 100, starting dose of 0.2 units for glargine 300 and starting dose of 10 units as per label for insulin degludec. Eligibility criteria quite wide here, and then it was a 24-week trial with initial active titration and then a maintenance phase and then a follow-up post-trial for 7 days. As you see in every treat to target trial, we see HbA1c reductions with both with no significant reduction because these are treat to target trials. We're going to target and treat these patients to that target. And we never see any differences in most trials, as you know. In terms of HbA1c reductions, we see similar reductions, about 1.6% reduction, both for insulin glargine 300 and insulin degludec 100. What we see is the differences in terms of hypoglycemia. This is looking at anytime hypoglycemia during the titration phase. There's significant reduction for the two criteria of hypoglycemia, less than 3.9 or 70 milligrams per deciliter and less than 54 milligrams per deciliter, favoring glargine 300, anytime hypoglycemia during the titration phase. And then this is the event rate. So this is incidence rates, this is events per person per year. And again, what we see here is the number of events for the tight target is quite low, 0.5 per person per year. So two people per 200 getting one episode of this severe hypoglycemia for glargine 300 and 0.86 per person per year. And again, favoring insulin glargine 300. In terms of nocturnal hypoglycemia, again, we see event rates in favor of glargine 300. Now, the CONCLUDE study, and this, there were issues with this study, and there was an amendment in this study. This was a very large global study, 1,600 participants, randomized to glargine 300 or to insulin 200. And again, a very well done study. It had a titration period and a maintenance period. However, during the maintenance period, they identified that there were defective glucose meters that were transferring the blood glucose reading to the central trial registry. And I take my hats off to Novo Nordisk, because some companies would have stopped the trial and restarted with a new trial. However, they looked at the root cause analysis of why this was the case, and they then changed the meters, and then they went on to a second phase, maintenance phase of 36 weeks. And the primary objective here was the number of severe or confirmed hypoglycemia during the maintenance phase 2. So 16 weeks of titration period, 16 weeks of transition. Because of a defective glucose meter, there was a further 36 weeks of a maintenance period using the new glucose meters. In terms of initiation dose, 20% reduction in insulin degludec and glargine 300 as per label, and risk ratios were examined. And what we see, I'll just go to the summary slide. Overall, in terms of the primary outcome during the maintenance period, no significant reduction. 12% relative risk reduction, which was not significant. So if you look at the other secondary outcomes, which are hypothesis generating, nocturnal symptomatic severe hypoglycemia during the maintenance period, and during the treatment period, total treatment period, overall symptomatic, nocturnal symptomatic, and severe hypoglycemia in favor of insulin degludec compared to insulin glargine 300. However, as I mentioned, the primary endpoint was not met, so these are all exploratory analysis. There's been some new subgroup analysis from the BRIGHT study, stratifying people with EGFR, EGFR of less, greater than 90, 60 to 90, and EGFR of less than 60. What we see here in this study is that there was a reduction of about 0.43% favoring insulin glargine 300 compared to insulin degludec in those people with CKD, which was quite interesting. And there's some analysis coming out from degludec showing similar results as well. So highlights overall is from the BRIGHT study is there was a greater reduction in terms of people with renal impairment. I haven't shown you some other data of greater reduction in those aged greater than 70 years of age. More people achieved the target without hypoglycemia. There's also data about anxiety, and less people had, the people were less anxious about hypoglycemia, and there was increased treatment satisfaction as well. Now, real world evidence, this is, I'm just going to show you a BRIGHT study comparing to DELIVER-D naive study. BRIGHT study I've already just gone through. DELIVER-D was to compare glycemic control and hypoglycemia and treatment discontinuation in the real world setting of people on glargine 300 or insulin degludec. In terms of glycemic control, we see there was a equipoise in terms of reductions, treat to target, no significant difference, the same in the real world setting as well. Hypoglycemia, again, hypoglycemia I've just shown you for BRIGHT study. In the DELIVER-D real world setting, overall inpatient emergency department associated hypoglycemia was similar in both insulin degludec and insulin glargine cohorts at 24 weeks. Just to summarize the results in terms of the HbA1c, this is a randomized control trial, BRIGHT study, reductions of about 1.6%, no difference between insulin glargine 300 or insulin degludec here. This is the real world study, again about a 1.6% reduction between the two. Again, no significant difference. The only difference is, as you always see, randomized control trial patients, their HbA1c is much lower than when we initiate insulin therapy. in the real world setting, about 9.7% at baseline HbA1c when insulin was initiated in these people in the real world setting. Looking at hypoglycemia, anytime hypoglycemia, this is the incidence, proportion of patients having it. This is events per person per year. Again, overall, when we look at the confirmed at 3.0 millimole or 54 milligrams per deciliter, low rates, as I mentioned in the BRIGHT study. And when we look at the delivered naive, they could only look at inpatient or ED hypoglycemia rates. Overall, pretty low. We can't classify them in the real world setting like we can in a randomized controlled trial setting with these levels, but no difference between insulin degludec and glargine 300 in the real world setting for all hypoglycemia and inpatient and emergency department hypoglycemia. So in summary, type 2 diabetes, we all know, is a progressive disease, and early preventive interventions, tight glycemic control, is associated with long-term benefits. There is a major efficacy to effectiveness gap, and there are various reasons for this, but we need different solutions because there are so many reasons. We need different solutions, different settings to overcome this inertia. But I've shown you that one of the things in our armament is the new longer-acting basal insulins with lower risk of hypoglycemia, but we need to individualize these therapies and interventions to our patient populations. Thank you very much for listening. I'm happy to take questions now.
Thank you, Dr. Kamlesh. That was a very nice presentation, and it is always interesting to see translating evidence into real clinical world practice. This is something we are always looking for. And apart from this thing, one important point you have mentioned is about therapeutic inertia. Can you hear me? It's my voice.
I can hear you. I can hear you. Thank you.
Yeah, I just wanted to know how far it is the initial inertia from the clinician.
Okay, so again, in live broadcast, I always ask, what do you think it is? Is it patient level or is it physician level? The majority say it's because most people say it's patients when you ask, but it is physician. There's a study, lovely study by Nakar, small study, which asked people who were insulin naive patients, what are their fears about insulin initiation, and about 10% said their fear of hypoglycemia, fear of blood glucose monitoring, fear of injections, etc. And then they asked their physicians, these patients' physicians, what do you think the barriers are? And they said the same barriers, but the barriers, they classed them at 90% compared to the patients at 10%. So we think that our patients will have the fears, well, the patients don't. So it is a physician barriers, I think.
Okay. And I think that there's a question to JYOTHYDEV, I think. Can you please see?
Yeah. So how Lantus compare to IDGASP when initiating new patients in your experience?
There are a couple of trials available comparing glargine with a co-formulation. Of course, when there is a co-formulation, you know, there is a prandial insulin component in it, and it will address the postprandial glucose excursions. But I will say that to initiate insulin, which insulin to select depends on the duration of diabetes and the prior history of which drugs have been used in the treatment of diabetes. And if there is a long history of diabetes, probably a basal insulin alone will be insufficient. But remember, I have been emphasizing on treating patients and initiating insulin during this crisis, when our patients are fearful, stressful, many of them are staying at home, and many of them cannot exercise properly. So you need to initiate some insulin. So if you're initiating with an insulin such as glargine or an analog basal insulin, there will be least chances of an emergency, because it is difficult for our patients to even visit the hospital. So to initiate insulin, basal will be the optional, the best insulin currently, and that to an analog basal insulin, since there will be least chances of a hypoglycemia induced emergency to visit a hospital.
Thank
you, sir.
Jyoti. I think there are two questions to Professor Kunti. One is COVID-19 patients have low levels of albumin. As per recent papers, will degludec cause more hypo episodes in COVID-19 patients since it binds to albumin?
Yeah, there's a couple of studies that have looked at this, that you do get more hypoglycemia with degludec. One is a Japanese study and another sort. So there is some evidence for that, but these were not randomized trials. One was an observational, one was a crossover study, but quite small studies as well. There's a potential.
Okay. And I think there is one more question. I'll just read it. How far can we go to increase the dose of basal insulin glargine U300 beyond 0.5 units per kilogram per day to fix fasting?
Okay, so again, Dr. JyOTHYDEV gave a nice overview that fasting is what we're targeting when the HbA1c is high. Sorry, just getting my video. And I mean, you know, in the UK, we go up until people have hypoglycemia. As long as the HbA1c is coming down without hypoglycemia, as I showed you, Julio Rosenstock study has shown that people get to 0.78 units per kilogram at 54 weeks. But in terms of the Indian scenario, patients have lower weight, so you may not get to those high level of doses. But I think 0.5 units, 0.6 unit, you can get to safely as long as patients are not getting hypoglycemia.
Okay.
Specifically address the postprandial glucose excursions. So the insulin that you are going to choose for a particular patient should actually have an influence on what the patient is currently suffering from. Is he suffering from an early diabetes, or is he suffering from a late or burnout diabetes? And was he previously on sulfonylurea's maximal dose or not? Is he having a critical illness at present? So many factors are there. So putting all these factors together, we address them as individualization therapy. That was what Professor Kunti was just stating. So each individual need to be treated separately. So we will have a good majority of patients who require only a fasting to be addressed. When the A1C is pretty high, only a basal analog insulin to be there administered to address both the fasting and the postprandial, provided you are aggressively lowering the fasting. And for aggressively lowering the fasting, you will require an insulin which is safe enough so that there won't be any major hypoglycemic episodes. So that is why we are recommending only basal analog insulins. But when in the natural history of diabetes, when the disease is progressing, when the postprandial glucose elevations are also very significant, you might require a premix or a prandial glucose to be addressed with a different insulin component, with a different insulin formulation. So this is the era of a personalized diabetes management, and hence each patient is different, and hence inertia is there, of course, from the part of the patient, inertia is there from the part of the physician. And the message here during this COVID crisis, when majority of our patients getting admitted in the critical care is having hyperglycemia, we need to initiate them on insulin sufficiently early at any stage of their disease, and that insulin should be a safe insulin which can be titrated via a telemedicine, if possible via telemedicine. So that is the message. So we have the RSSDA president over there. I don't know whether he is busy or not, but I think RSSDA is coming out with some recommendations. So back to the chairpersons.
Yeah, I think I can ask this question to Dr. Santi. So can Glargine 300 be given in the morning?
Yes, it can. They are long acting, so whatever's suitable for that patient, it certainly can be. Yes.
And there is one question, maybe Jyoti Devi, can you take this one? What about role of biosimilar insulin in Indian patients?
Yeah, biosimilar insulins are becoming very popular, not only in India, but all over the world. And even the American Diabetes Association in the guidelines, Dr. Kamlesh Kundi has shown the algorithm, the guidelines. It all depends upon, again, the individualization. So we have the broad categories, the 5 categories over there to choose a specific therapy for the patient. So the therapy can be chosen based on the presence of an ASCVD, a chronic kidney disease, or a priority could be weight reduction or elimination of hypoglycemia. But there is one choice at the end, and that is when your priority is the cost of a therapy. So when you are very much concerned with the cost constraints, then you might have to go for those therapies which are the cheapest. And insulin should be the insulin of the lowest acquisition cost. And for that, probably in a resource limited situation, you may have to go for the biosimilar insulins. Otherwise, the innovator molecules are far different from the biosimilars, so that we are all aware of.
And I think we can take one more question.
Yeah, absolutely.
Okay. And this is after, maybe after listening to real world data on SOLVE, BRIGHT study and CONCLUDE study. This is to Dr. Kamlesh. How do you compare IDEC 100 versus U300 in your clinical practice?
Okay, so certainly we're using more and more Glargine 300 and insulin degludec, but the reason is at the end of the day, cost is an issue. It doesn't matter where you are, whether you're in the UK, whether you're in India. So if the cost is at parity, and at the moment the cost, there isn't a much cost difference between the two insulins, then we're more likely to use Glargine 300 and insulin degludec, because they do give that benefit of longer acting. There's a flexibility for the patients and the low risk of hypoglycemia as well.
So I would like to ask the RSSDA president over there, Dr. Benshibai. So Dr. Chandini, you can ask him the RSSDA recommendations on
Yeah, I
insulin
was
during this
looking
crisis.
for him. I think I'm not seeing his name anywhere. Is he here?
Yeah.
He is there. Can you
yeah. I was just looking for. Yeah, please give your comments. Yeah. Dr. Banshi, sir. Dr. Banshi, sir.
Can you unmute? We are asking you your opinion on. Yeah.
Yeah. Could you please unmute? We are not.
So we are actually, Dr. Chandini, we are asking you the opinion of the RSSDA. You being the president of RSSDA, we were discussing about insulin during this crisis and insulin for the poor patient when there is a cost constraint. So please unmute and please reply. Yeah.
Yes. So from RSSDA, what we have done, Jyoti, during this crisis period, some of our type 1 diabetic patients who are in remote place where they could not get the insulin. So what we have done, we asked all the industry partner who are insulin supplier for our company. We asked them if they can give some helpline number which we can circulate to all our physicians friends, as well as we put it on our social media. And all these insulin making companies had given their helpline number. So those patients who are not getting through the regular pharmacy, because either because of closed down lockdown situation, or they are in the village where pharmacy is not available, if they call this number, they could get the insulin. And what we realized, this we have done in first week of April only. The lockdown was started after 24th week. So on the 1st and 2nd April, we have done it. And what we realized after 2 weeks, there are hundreds of patients across the country. I mean, to our surprise, they were not able to get the insulin supply, and then they can get through this helpline number. So the same time, we also realized that there are patients who might not be getting the regular monitoring strips also regularly. And then we contacted all the companies who are supplying the insulin, I mean glucose monitor strips, and we requested them if they can also give their helpline number, and we circulated that too across the country, and many of our patients really got the benefit. It was not only for type 1 where it is life saving, you know that, but for many of our type 2 diabetic patients also it is really a difficult situation. If they don't get insulin at right time, they get significant hyperglycemia and they may develop complication. So as there was one data, if you remember, from Dr. V. Mohan, that in India only 1/3 of pharmacy are having insulin in their, to sell it. So this is the rural India situation. I mean, this is the true conditions of our rural India pharmacy. So they may not have the insulin supply regularly, because in whole village of 10,000 to 20,000, hardly 5 patients are taking insulin, or they might not be keeping insulin supply regularly for them. So by giving this helpline number, and RSSD also having a 24/7 a helpline number, which is a toll-free number, and which we are also widely popularizing to our physician friends and colleagues, and they can give it to their patients for any matter, on any matter, or on related to any education also. But now with the growing technology, uses of internet and all this, I'm sure, and because of this only we are doing this Jpef, and we are getting, even online also we are educating our colleagues and physicians across the country, across the world rather. So this will help more and more physicians to understand the problems of our rural India, and the insulin supply can reach to real needy patients. And with the help of telemedicine, now we can educate, we can teach, we can do everything, all these things. So even this COVID situation, everything was locked down, but neither education and not diabetes care is being, compromised at any level.
Thank you, thank you. So something is better than nothing. So some insulin,
yes,
to be initiated during this crisis. Yeah. Thank you, thank you.
Thank you, Dr. Bansi, and thank you for giving us this opportunity to Dr. Jyoti especially. Thank you so much.
Thank you, Professor Kunti, Dr. JYOTHYDEV Keshavdev, Dr. Jayalakshmi ma'am, and Dr. Chandini ma'am for an enlightening symposium on basal insulin. Next, we have a very important session, the Insulin Symposium. The Novo Nordisk Symposium is titled Pragmatic Choice for Insulin Initiation, Taking Cues from the Realities. To moderate this session, we have Dr. Harish Kumar from Kochi. He is the Professor and HOD, Department of Endocrinology and Diabetes, Amrita Institute of Medical Sciences, Kochi. And we also have Dr. Ashok Kumar Das, currently the Consultant Endocrinologist at PIMS, Puducherry. I humbly invite both the moderators.
Thank you very much for this, for asking us to moderate this very important session. Before I hand over to Harish, I must mention one thing which I'm very passionate to. Now, we know that diabetes is a relentless disease with relentless morbidities and mortalities, but the advances in insulin is equally relentless. And one such advance is the ushering in of this co-formulation, a combination of the IDEG plus aspar, and this co-formulation, because their unique properties, allows them to be here together to take care of the diabetes. Dear friends, we will discuss various aspects of it. I must mention this insulin has potentialities, possibilities of very unlimited quality. I will hand over to Harish for giving his comments and inviting the first speaker.
Thank you, Dr. Das. The first speaker is Dr. Mala Dharmalingam. She is a close personal friend since, I think, more than 2 decades now. So it's always a pleasure to introduce her. She is the professor and head of Department of Endocrinology at MS Ramaya Medical College. And she's also the director of Bangalore Endocrinology and Diabetes Research Center. She has won 11 awards, including the Epicon Vocational Excellence Award. And she has given 13 orations, including the Sam Moses Oration, the P.N. Shah Oration, and the MMS Ahuja Orations at the Endocrine Society of India annual meetings. And she has also delivered the presidential oration at the Karnataka RSSDI. She has published over 134 articles and has a number of chapters in textbooks. She is also a member of the ethics committee of the ICMR, and she's going to talk to us about the high carb diet that we take in India and its effect on the postprandial glucose levels and what it does to diabetes as a whole and how best we can look at targeting. Over to you, Dr. Mala.
Thank you, Dr. Harish, for the very kind invitation. It's really a pleasure to see you, and at least in this distant communication, at least to see you. And thank you, Dr. Ashok. It's always a pleasure to see both of you. So just give me a minute for me to share my slides. So my topic is going to be recognizing and addressing the realities of high carb diet and the high postprandial glucose in type 2 diabetes. So some of it we know, some of it we are going to learn, and understanding what we really need to do to address the peculiarities, which is us. So what is the challenges of managing diabetes in India? What is the reality? So we do know that we have a high carb diet. In fact, I think the highest carb diet in the whole world. We have high postprandial glucose levels, and we are on, patients are on uncontrolled in spite of taking multiple oral antidiabetics. And what all of them ask is, please give me something simple, doctor, once a day, something simple. I don't want to get confused with too many medications. This is the problem that we face in India. And of course, and another important problem is they don't test enough. So that is something that we need to understand. So now my first part of my topic is, do carbs matter? So what do the NIN, which is the National Institute of Nutrition, recommend, including the Indian Consensus Guideline for Healthy Eating? What does it recommend? It recommends that we should take our calories, 50 to 60% should come from carbs, preferably complex carbs. 10 to 15% should come from proteins, and about 20 to 30% should come from visible and invisible fats. But what do we actually eat? This is something which is very interesting. This is the famous START study, which I was also part of. The main author was Dr. Shashank Joshi. And what was interesting, whether you were from the east, west, north, south, or central, roughly our carb intake was as high as 65%. This is an average. So you can understand that some people were going up to 75% also. And if you can see, the protein was around 15% and fats were also about 18 to 20%. So our carb intake is much higher than what it should be at around 50 to 60%. So this was a very elegant study, which was done by the Mohan's group. What they did was, this was all non-diabetics. They took less than 20 years. This was part of the Chennai Urban Rural Epidemiology Study, which is the CURE study. And they looked, and this was around 8,000 people, 8,700 people. And they looked at their carb intake, and they divided them into different quartiles. So the lowest carb was in the first and the highest was in the fourth quartile. And then they adjusted for everything else, the BMI, as well as their family history, the sedentary habits, all that was adjusted. And there was a good follow-up of roughly around 10 years. And what they found was, when they adjusted for odds ratio for everything, the carbohydrate load, if it was more, there was a more chance of becoming diabetic. If the glycemic index of the food they did was more, in the fourth quartile, their chances of becoming diabetes was more. They looked at the glycemic load. And again, if your quartile was more, your chances of becoming diabetes was more. And dietary fiber was inversely proportionate to the chances of getting diabetes. That means your fiber was more, your chance of getting diabetes was that much less. So this was a very well done study, and it was a long study with a good number of population, and it was a rural study. So that's what is very interesting. This is another again, a very interesting study, and huge number of people. This recruited people from the Nurses' Health Study. There were 75,000 women
And it looked at the health professional follow-up study of around 45,000 men. And what they did is they followed them up to see for an increased risk of incident coronary heart disease. And what did they look at? They looked at various parameters. They looked at carb, they looked at fiber, they looked at cereal fiber. And as you can see from this graph, and there was a follow-up of 20 years. And what they found, if you see, the carbohydrate to cereal fiber was the most significant. In fact, it was more significant than the carbohydrate to total fiber. So the cereal fiber coming from cereals was found to be more significant. And that showed that the risk of CHD was significant when this ratio was abnormal. So this is the PURE study, which is again a very interesting study, which is the prospective study, which was done in Europe, European countries. They looked at 18 countries from 5 continents. And what did they find was, again, they looked at mortality. In the other study, they looked at coronary heart disease. Here they looked at total mortality. And they looked at major cardiovascular disease. So they looked at different parameters of whether it was the energy from the total, or looked at the saturated fatty acids, monounsaturated fatty acids, and polyunsaturated fatty acids. And they looked at carbs. If you look at this slide graph, you can see that it was only the carbohydrate, when the energy came maximum from the carbohydrate, you see the graph is going up. That means the mortality is going up, so is the cardiovascular disease. Even if their food came from saturated fats, which was really surprising to me, it still did not affect mortality significantly, nor did it affect the major cardiovascular disease. It was only when it was coming from carbs did the mortality increase and the major cardiovascular disease increase. And these were all studies, again, with long follow-up, very well done studies, very academically done studies, which have shown that maybe we should start looking at carb as the culprit of most of these problems. Now, I showed you before. So then let's look at the quartiles or quintiles and see what happens. What did we find that the majority of the patients in our country take? They take about 65 to 67, and that would come into quintile 4. And if you look at this, the mortality odds ratio is about 4.9, and there are 17% times more chance that you would die compared to a person with a normal intake of carbs when you look at 67%. So maybe that is one of the other reasons that even the cardiovascular disease is in a huge number in India. So it's very important that we should look at what is the food intake in our population. And next, let's come to what about the PPG levels? What are the postprandial levels in Indian type 2 diabetes? So very often earlier, people used to just do a fasting glucose. They never even used to do a postprandial glucose. It's only of recent times that many people, especially all India-wise, but people have started testing the postprandial itself. So let's look at some of that data. Now we all know of the famous Monier trial where he has made the HbA1c into different quintiles, and he has found that what contributes more, whether it's the fasting or the postprandial, typically in what Monier showed was that in the initial HbA1c less than 8.5, it was the postprandial which was important, and after that it was the fasting which was important. But no, the Indians are quite different, and what we see is whatever the HbA1c, even from 8.8 to 12.7, this was a very elegant study done, which has looked at this data by looking at a 24-hour CGM. And they found that even at higher levels of HbA1c, the postprandial is a major contributor in Asians, unlike the Caucasian data. So now, okay, why are we worried about this postprandial? What exactly does it do? So when there is increased postprandial hyperglycemia, we know that there is endothelial dysfunction because of decreased nitric oxide release. There is triglyceride-rich lipoprotein and low-density lipoprotein removal. So it's not removed, so it increases. The early phase insulin secretion is reduced. Insulin resistance is increased. Free fatty acids, oxidative stress is increased. Fibrinolysis is reduced. Glucose autooxidation is increased. Plaque stability reduces, and there is increased blood coagulation. So all of these factors all happen with the postprandial hyperglycemia. So all of you would have seen this very nice picture of oxidative stress, is one of my favorites. So when you eat, there is a sudden gush of hyperglycemia, which causes oxidative stress and inflammation. Oxidative stress is nothing but the free radicals are reduced, or rather are increased and secreted more, and they play a pivotal role in the pathogenesis of vascular failure. So there's increased inflammation, there is thrombus formation, and there is endothelial dysfunction. And we know that this endothelial dysfunction is the first stage to develop atherosclerosis. And what is important is this endothelial dysfunction is not there only in diabetes, it is there in IGT as well. So this is possibly the common soil hypothesis, but also the fact that in IGT, the fastings are normal, but the postprandials are high, and even that enough to cause endothelial dysfunction. So it's imperative that we should control the postprandial. Where did all this data on the macrovascular complication, the postprandial hyperglycemia come? We had the PPG study, then we had the HOON study, and we had the Honolulu Heart Program, the Chicago Heart Association study, diabetes intervention study, which was an 11-year follow-up, and the incident cardiovascular events and glucose level, a meta-regression analysis study. All of them showed that the postprandial was very important, and it could contribute to carotid intima media thickness, mortality, coronary heart disease and mortality, and so on. So all these studies definitely showed us that it is important to control postprandial. So we've looked at the macrovascular complications. What about the microvascular complications? So here, if you look at different variables of nephropathy and neuropathy, as well as retinopathy, we know that in South Indians with type 2 diabetes, and again, this was a 25-year study which was looked at and by Dr. Mohan, and he did find that all of the postprandial was associated with microvascular complications also. So it's important that we control not only for macrovascular as well as for microvascular. And this is again a very, very interesting, one of the first. This is the decode. Most of us have seen this study way back in Lancet in 1999. And irrespective of what was the fasting plasma glucose, if the 2-hour glucose increased, the risk of mortality was much higher and the hazards ratio was much higher, whatever was their fasting. The postprandial contributed to mortality much more. And this was again done in non-diabetics, GTT done, very elegant study, one of the initial studies which really showed that the postprandial hyperglycemia was very, very important. Again, this is one study which was done for about 121 patients, looked at their CGM and seen what is the contributor to HbA1c. They found that the PPG, if it's high, it causes a high HbA1c. Now, we need to control, we know we need to control both the fasting and the plasma postprandial. So let's see. So the HbA1c, that is a collection of both the fasting and the postprandial. So now controlling all of this, of course, will control HbA1c. But if you want to have a greater decrease, supposing the fasting is normal and still your HbA1c is a little high, the postprandial reduction will cause the greater reduction of HbA1c than the fasting. Also, so better sensitivity, specificity, and a positive predictive value than fasting plasma glucose. And this was very elegantly shown. This was again a very interesting study which looked at, it was a meta-analysis of a lot of studies. But let's look at what happens in Asia. This was another study done by Shen. It was another meta-analysis, and this was with insulin glargine. And he controlled everyone's fasting to the same level with the increase of glargine. And what he found was, if you look at non-Asians, about almost 47% got to an HbA1c target of less than 10%. But in Asians, less than 40% could get to a target with the same amount of fasting sugars and glargine also. So he concluded that the prandial component needs to be addressed in Asians, and that could contribute to why they could not reach 7%. So what are the RSSDI clinical recommendations? They say avoid using insulin as a threat. I think that's very, very important. and elevate patient anxiety. Patient is worried about low sugars. Oh, I will become dependent on it. It will pain. So we need to reassure them, and then we need to maybe give the first shot in the clinic itself so that they know it's almost painless. And then when should we start? Possibly, I believe that if your half maximum dose of more than 3 agents is given and it's not controlled, that is the time you should be starting insulin. So in India, the pragmatic solution to control diabetes is, what is the problems? We have a high carb diet, high postprandial glucose. We need convenience in insulins, and we need to, if they are not controlled on multiple OADs, this is the Indian reality. We need to see that we give them some insulin, which is very easy to give, easy to understand, and yet get it.
Ma'am, we are almost running out of time.
That is my last slide. So to summarize, Indian reality is that people with diabetes have high carbohydrate diet, resulting in high postprandial, high carbohydrate intake, high postprandial glucose are independent risk factors for CV disease. And the studies have shown that the postprandial has a strong correlation with HbA1c than fasting. So we need to use insulin correctly, initiate early, so that we get good control and prevent both macro and microvascular complications. Thank you for patient hearing. I'm stopping to share so that, yeah.
Thank you. Thank you very much, Mala, for highlighting a very important issue, how the Indians are different and what are our priorities, what are the Indian realities. The next topic is achieving total glycemic control with safety. The emphasis is total and also on the safety, a solution that fits into the realities which Mala has outlined and also beyond it. To do the justice to the topic, we have a wonderful speaker, the international speaker, Roger Chan. Can I have the biodata? Now, can I have the biodata of the speaker? Now, Roger Chan is not new to India. Roger, we welcome you, and you are very close to our hearts. He has the senior staff specialist in the endocrinology at the St. Vincent's Hospital, Sydney, and the visiting scientist at the Garvan Institute of Medical Research. He was awarded his PhD following translational research in the metabolic effect of the growth hormone. His clinical interests are general endocrinology, but diabetes, thyroid, adrenal, and pituitary, and in andrology are his main forte. His research interests are on the diabetes comorbidities, such as mental illness, cognitive dysfunction. He has been the endocrine lead in the establishment of the joint metabolic mental health setup in the East Country. He coordinates the endocrinology unit of the Masters of International Medicine for the University of Sydney, and he is also a reviewer for a number of international journals. Dear friends, I have great pleasure in presenting Dr. Roger Chan to do justice to the topic that is very important, practical, and clinical. Over to you, Roger.
No, thank you very much indeed. I'm just going to try to share my screen, and I think we are there, right? Can you see my screen now?
Yeah, you have to make it
Okay,
full
wonderful. No, thank you very much, Mr. Chairman, and thank you, Dr. Mala, for a wonderful talk. I also enjoyed the previous session. I wish I was there in India with you, but that's not to be. So greetings from Australia, everyone. You've had a brilliant session, I think, on the importance of postprandial hypoglycemia and why, when we initiate insulin, we really have to think about the patient. We've talked about individualizing therapy. We've talked about, really tailoring therapy to the individual. Now, we know that in India and in Asia and in Australia and many parts of the world, that certainly carbohydrate play a very, very large role in our diets. So this is the agenda, insulin initiation with co-formulation. We'll talk about some of the efficacy and the data, and then the simplicity illustrating with a couple of cases. So the first case is from India, and this is Jessie Thomas, who's a 54-year-old female who has had type 2 diabetes for nearly 9 years. She has probably peripheral neuropathy, hypertension, and we know that she is also a little bit overweight. Her fasting plasma glucose is elevated, but her postprandial levels are even higher, and her postprandial dinner levels are, in fact, the highest. We know that there is significant postprandial hyperglycemia, along with an HbA1c of 9.3%. Got reasonable renal function, as well as a normal blood pressure. And you can see her medications, metformin at maximum doses, DPP-4 inhibitor, as well as the usual use of glycoside as well. So we've talked about the fact that she has a high carb diet, and it's very difficult, I think, to change people's diet to a very significant degree if they're so used to having that carbohydrate, although certainly some modifications can be made. She's not very active. She has an elevated HbA1c, and we've thrown all the oral therapies at her. So she also has had a long duration of diabetes and requires insulin, where both postprandial and fasting glucose levels, I think, should be addressed in a simplistic way. I think the audience is very familiar with the use of Ryzodec now, or IDEC-AST, and this, as you all know, is a combination of insulin degludec, the basal insulin, as well as insulin aspart. I'm always having a bit of trouble with the slide sharing, but you can see there here that we have in green the illustration of the premixes where there's a bit of a hump, if you like, the so-called shoulder effect, which can increase the risk of hypoglycemia approximately 3 to 4 hours after giving the injection, such as the premix. But with Ryzodec, there is very, very little shoulder, in fact, no shoulder effect, and you have the two insulins working completely independent to have the prandial component to address the meal and then the basal component to work for the rest of the day. So I think Dr. Mala has really alluded to this, so I'm not going to go through it too much, but basically when I think you want to start a patient on insulin, you want to do it as simple as possible, and you want to try to give them, a reasonable degree of control with the first injection of insulin. And as we'll discuss, often that is not achieved by a basal insulin, which does not contribute at all to control of postprandial levels. Basal insulins will control fasting plasma glucose levels, but not any postprandial levels as well. They're both easily initiated. I think they're both easy to explain and understand, single device. But once you need to intensify, which you often need to past the basal insulin, then you are using two devices when you add a basal plus regimen as compared to just one with Ryzodec or IDEC-AST. So I think this is very well known to the audience. So again, just to recap, the so-called start and stay therapy, patients uncontrolled on oral therapy, they can be used in people with type 1 or type 2 diabetes over the age of 18. Anyone who's uncontrolled on basal insulin, this Ryzodec will give a very, very reasonable option of intensifying by adding the prandial component along with the basal component in one injection. Also, patients uncontrolled on premixes where the protaminated aspart often does not last till the morning, and if you increase the dose too much, you get hypoglycemia overnight. And this is where, again, the beautiful nature of IDEC-AST for Ryzodec is that the degludec component will last through in the morning with very, very low risk of hypoglycemia. And then patients uncontrolled on a basal bolus therapy, and I have quite a number of people on basal bolus who are just not coping, and they then do very well indeed, I think, on once daily Ryzodec with aspart or twice daily Ryzodec. If we move to the right-hand side, I think it's also fair to say that we're getting a very, very large number of the elderly with type 2 diabetes where this insulin Ryzodec is absolutely appropriate for them. So they have one big meal a day, usually dinner, sometimes lunch, but usually dinner. Their relative comes and gives them the meal. They have the insulin, and it keeps them out of significant hyperglycemia for the rest of the day. And there's a very low rate of hypoglycemia as well. We know there's very nice data in terms of renal and hepatic impairment with the safety of degludec. So again, combination of degludec and aspart. We're very familiar with aspart, but with degludec, we also know that there is no need to adjust with renal and hepatic impairment. And we're also using this with other comorbidities. So just to go to one of these trials, and this was alluded to partly in the previous sessions. So we have a group of patients, what do we put them on? Their HbA1c is high, they're on maximum oral anti-hyperglycemic therapy. So in this study from Japan, patients were either randomized to receiving Ryzodec in blue or Glargine in gray, and they could give the insulins either at dinner or breakfast, but they had to keep on with that specific time for the 26 weeks. So this is the treat to target study, which Kamlesh, I think, explained, and all of you are very familiar with. So you titrate, so the fasting plasma glucose is achieved. So you can see from the left-hand side that the fasting plasma glucose is absolutely the same. That is the treat to target study. But interestingly, the HbA1c is actually lower in the Ryzodec group, and that's shown in the light blue line. Again, I think many people are familiar with this data, and it was, somewhat surprising. So similar fasting plasma glucose, identical, but lower HbA1c. And that's achieved because you can see that after dinner, so the majority of people had the Ryzodec given at dinner. So after dinner, in the light blue line, you can see that those receiving Ryzodec have a lower postprandial level, and that probably contributes to that lower HbA1c. Nice data. But again, interesting. So similar fasting plasma glucose, lower HbA1c, but numerically also lower risk of hypoglycemia, both overall on the left side, but also on the right side, nocturnal confirmed hypoglycemia. Not statistically different, but numerically lower. So just to summarize, in patients uncontrolled on drug therapy, orals, insulin initiation, offers better efficacy without compromising safety. So if you look at patients receiving an HbA1c of less than 7% on the left-hand side of that slide without a hypo, in the Ryzodec group, it's 43% as compared to 25% receiving insulin glargine U100. Or put it another way, 72% more patients with IDEC-AS or Ryzodec will achieve their targets without experiencing hypoglycemia. So going back to Jessie, this again is her pattern. So she's got a particular high sugar level after dinner, which I think is so common amongst our patients because they come home, they have a big carb meal, and therefore we need to address that. I think Dr. Mala mentioned this, but I just wanted again to mention that, even if you are non-Asian or Asian, you will not achieve your HbA1c despite a similar fasting plasma glucose reduction. And yes, it's higher in the non-Asian population, but only 47% of people will achieve their target HbA1c in the non-Asian, and it's much lower in the Asian population. So the conclusion is that prandial component needs to be addressed in Asians, and I'll actually enlarge that to the prandial component needs to be addressed in many other people as well. And we in Australia, I think in our group and in Professor Fulcher's group, also well known to you, and Ted Wu's group, we're all using this co-formulation as the start because it's very effective. We've also talked already about the concept of a high intake of fat and protein and energy at dinner and breakfast. Dr. Mala was absolutely brilliant in her way in which she discussed this. So we know that this is the majority of our patients, unfortunately. So Jessie has her main meal at dinner and the postprandial glucose level is high. So we discontinue the glycoside and we continue metformin and we continue vildagliptin. And as per label, we start 10 units with dinner. Simple, straightforward. That's only 3 units of aspart. So, people often ask me, aren't you afraid of hypoglycemia? But no, I'm not, because the sugar levels are going to be very high after dinner. And we start off with just 3 units of aspart. So it's 10 units of Ryzodec, and we gradually titrated over 12 weeks based on the fasting plasma glucose level. So at the end of 12 weeks, she's on 20 units of Ryzodec, and her sugar levels have improved very significantly. HbA1c down to 7.2%. I did a rough sort of survey on my first 100 patients on Ryzodec, and they all improved very significantly by about 3 months. So I think this case study really tells us that, look, we've got to assess the diet. We can't put everyone on the same insulin. As we've mentioned in the previous session, it's very much individualization of treatment, but many, many people, and I'll say the majority of people in India, Australia, Asia, Hong Kong, etc., will need some prandial cover. And this is where perhaps this co-formulation should be considered very, very strongly as the starting insulin. So we also know that 50% of patients with type 2 diabetes on basal insulin do not achieve the target HbA1c. And, you know, Kamlesh Kunti is the treatment inertia king, I think, in Europe, if not the world. So we've heard him before, and he's very, very keen to say we've got to try to overcome treatment inertia. So using simple and uncomplex regimens can only be beneficial. So now we have a group of patients who are on basal insulin, and we have tons of people here as well. What do? Do we put them on some prandial? Do we go basal plus, basal plus plus, basal plus plus plus, or a basal bolus? And often people on glargine end up being on 2 injections of glargine a day anyway. That was one of the questions, I think, in the chat button. Also, these group of people ended up either being randomized of glargine and 1 injection of aspart with the main meal, or Ryzodec with the main meal. And at week 26, if they didn't achieve the HbA1c target, those on Ryzodec achieving 1 injection could go to 2 injections. That's light blue, I'm sorry. And those receiving glargine and 1 aspart injection could have another aspart injection added. And at 32 weeks, that could be intensified further. I like this study more and more because you would never, ever think that a basal bolus treatment and versus a co-formulation could be fairly equal in terms of HbA1c, which you can find on the top left-hand corner. Similar HbA1c in the top right-hand corner, similar reduction in fasting plasma glucose. But when you look at confirmed hypoglycemia, it's lower overall, okay? Overall, 14% lower, not statistically significant, but nocturnal confirmed hypoglycemia, 40% lower essentially at the end of the study, and that's statistically significant. And we all fear this nocturnal confirmed hypoglycemia because it's the hypoglycemia which kills our patients. They don't wake up. And to add a little bit of, other sedatives or whatever, it's incredibly dangerous. So this is very reassuring data. Also very reassuring is this nice analysis just presented at the ATTD meeting in Madrid. I wish I had gone. I think it would have been the last international meeting I'd gone to, but I didn't go. And you can see that if you do a calculation of the HbA1c reduction from 8 to 7%. And on the y-axis, you look at the predicted hypoglycemia rates. It's higher when you have glargine plus aspart as compared to Ryzodec. So, that reduction from 8 to 7% with the basal bolus or basal plus regimen is associated with a higher risk of hypoglycemia. We're also sometimes, why 30-70? Is it appropriate? Well, interestingly, when you analyze this data, and it's from the world, different countries, it turns out that those on basal plus or basal plus 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 or basal bolus end up also being on about 30% aspart, 70% glargine overall. So it's a very appropriate ratio, in fact. So this again confirms and summarizes some of the data from the step-by-step studies. Similar HbA1c, overall confirmed hypoglycemia lower, but not statistically lower, but nocturnal confirmed hypoglycemia significantly lower, less insulin, and clearly, 2 injections maximum with the Ryzodec as compared to 4 or even 5 with basal plus or basal bolus using aspart and glargine. So just to illustrate one of our cases, Tom, nearly 60 years old, type 2 diabetes for 14 years. And like the rest of us, he's on multiple medications for his diabetes over the years. He's also got hyperlipidemia, hypertension, a bit overweight, or rather significantly overweight. Metformin, glycoside, empagliflozin, typical, very common combination in Australia. Glargine, 20 to 30 units before bed, got sick with DPP-4 inhibitors, I'm not sure why, and also developed fairly significant nausea, unfortunately, with GLP. Now, his sugar levels, according to him, are always up to about 160 milligrams per deciliter before breakfast. So he's happy to say, okay, I suspect my evening meal is big. I'm going to add aspart at dinner. So he's got glargine at bedtime and aspart at dinner. Reviewed 3 months later, and I'm not sure how you feel about this, but we often have patients occasionally who come back and they are no better. So we've got to really try to work out what is happening. So I get him to do 6 sugar levels a day for 1 week and email them to me. And we find that the highest sugar levels apparently are around 216 milligrams per deciliter, not desperately high and not accounting for the HbA1c. And he tells me, though, he sometimes forgets to give the aspart. So he gives it at bedtime, which is clearly not appropriate. And with the glargine, or I suspect he sometimes doesn't give it at all. So thank goodness we had the ability to perform some CGMS using the Libre. Absolutely brilliant. I'm sorry, all this now is in SI units, so millimoles per liter. But here on the left side is midnight and 6 o'clock here, breakfast. I hope you can see the arrow. And here, interestingly, although he says he doesn't eat much lunch, universally his sugar levels go up about 12, 1 o'clock. So, you know, clearly his concept of not having lunch is a bit different from the rest of us. So he is having a very significant carbohydrate intake at lunchtime, and then his sugar levels stay up all through that time. And I suspect he's not giving his aspart because he's forgetting. So he says he wants simplicity. So look, we tried him on Ryzodec. I thought, let's just try him. And we'll just say, you know, you're getting a bit of carbs at lunch. Why don't we try it at lunchtime? So 30 units with a midday meal. So that was a 1-to-1 swap almost. And he said that he still forgets to give the insulin when he's very, very stressed at work because he is not getting on with his boss. But 6 months later, you can see that there's a very significant improvement when we perform the Libre again, and the HbA1c is fallen to 7.2%. So I thought this gives a very nice illustration of, you know, what CGMS is telling us and how, you know, appropriate this once daily injection has been for him. So to summarize, we know that Ryzodec or IDEC-AS addresses the common reality which Dr. Mala has so elegantly outlined and comprehensively outlined about the high carbohydrate diet and the high postprandial glucose levels in people with type 2 diabetes. And really, I've thought long and hard about this. And I think apart from, you know, Scandinavia and perhaps Northern Germany and maybe a few other places in the world, I think the rest of the world really does have a very significant amount of carbohydrate. I'm sure most of you have been to Italy, Southern Europe, Spain, and they have lots of carbs, just as we do in Australia and you do in India and also East Asia. We know that the combination of these two insulins in the co-formulation can address both postprandial as well as the basal insulin, and it's flexible. So we've got patients who have their biggest meal, for example, Monday, Tuesday, Wednesday, Thursday, Friday. They have the big meal at dinner, but then they say on the weekend, I want to change, you know, my biggest meal is probably 11 o'clock. We go out for breakfast. We have a very big carb meal with bread, and we have corn cakes, and we have pancakes and things. So they can easily just shift that Ryzodec injection from dinner that night to that brunch time, 11 o'clock. And then on the weekday, just shift it back. So it does offer flexibility, and it's a simple and convenient solution. So with that, I thank you. But just to finish, we've got some wonderful articles from India about the use of insulin degludec and aspart, and there's a whole range of my very learned Indian physicians or physicians from India. And I'm very proud to say that this has just been published, and we got it into Diabetes, Obesity, and Metabolism. So again, a wonderful contribution from some of our colleagues from various parts of India, myself, and of course, Rupa Mehta, whom you know well. So that's a global consensus paper about the tricks, I guess, the practical use of Ryzodec in hospital, you know, in various settings. What do we do, and what do we do with the medications that a patient is already on? So with that, I thank you and look forward to taking some questions. Thank you.
I think Roger, you have beautifully addressed the position of this wonderful molecule in the treatment of type 2 diabetes, and given through 2 cases, absolute illustration how this scores above other insulin. There has been a question in the question box. I have modified it. The questioner wants to know that many guidelines, say Western guidelines, have advocated a basal insulin. But in the background of the Indian reality, and now you said Australasian, Italian, other realities, where we have a high carb diet, we have to address both FPG and PPG. And he says that people think that controlling FPG will also take care of PPG. The questioner wants to know how far it is true, but we believe in India that patient will definitely benefit from an insulin that can provide what you addressed in your talk, a total control, fasting control and postprandial control without any extra burden. You said basal plus. Basal plus is 2 injections. Basal plus 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 is 3. Basal plus 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 4 injections. So basal bolus is, my friend calls it, invading into somebody's life. If you can do it 1 injection of a combined co-formulation, or maximum at times 2 injections. So he would like to have your comments on this. I think it's a very important question.
Yes, so that's the second last question about whether the basal corrects some of the postprandial rise. Well, it's going to drag the baseline down, so it will, bring overall sugar levels down, but it doesn't specifically address the postprandial rise. And as all of you know, we love our carbs, we love our food, and that you have to have some form of prandial cover in the majority of patients. It's interesting. The last question just asked: is there a risk of significant hypoglycemia? Well, not, because if you're starting at 10 units, really that's 3 units of aspart, which does nothing. If you're having, your rice and you have your roti, oh, the food in India is just amazing, miss it desperately. And, then you have your dessert. It's not going to cause hypoglycemia. And you slowly titrate it upwards according to the preprandial breakfast readings. And then, the risk of hypoglycemia is very, very low. Very, very low. But of course, all insulins can cause hypoglycemia.
Yeah, I think the questioner also wanted to know which guideline does recommend to start with these mixtures, whether it is IJODEC or India, Roger, we have pre-mix insulin guideline where for 4 reasons, Indian doctors do not have enough time, enough training, enough tools, and they do not have enough team. So therefore, they find starting a pre-mix is important. It's quite convenient. Similar line, starting IDEGASP also is convenient.
Sure. And I think Dr. Mala will agree that with the Ryzodec IDEGASP, is 1 step less. There's no resuspension, and there's no error there. So it's just turn and press. It's even easier. Yeah. So, I'm hoping that those consensus, the ones that we just published, will address some of those issues. Look, it's not for everyone, and some people will benefit from, using a GLP first, but with the Asian phenotype, I think many people will benefit from the use of this co-formulation.
I hand over to Dr. Harish Kumar. I have only one question. You referred to the step-by-step study, and you referred to the titration of the IDEGASP. Now, IDEGASP is a FDC, fixed dose combination, 70-30. How did you find it from a basal bolus, where you can vary both vis-a-vis IDEGASP titration?
Yes, sure. So I think I understand the question, but that was interesting because that's been the criticism of why do you not have different ratios? Why not a 15-85 or 50-50 to cope with the high carb diet, the highest carb diet in some cultures? But it turned out that this study was done in many different countries, including Asia, with the high carb diet. And it turned out that the ratio of aspart to lantus or glargine was still 30-70. Magically, I think it was 29 or 28, it was 30-70. So it's a very appropriate ratio to use.
Harish, over to you for the other questions I'd like to ask.
Dr. Chen, I have a question. This is a question which has been asked to me a number of times. That is basically IDEGASP is seen as a once daily injection. When it's used twice daily, there's a lot of concern in the mind of many physicians that whether there is stacking and how can you use long-acting insulin, ultra long-acting insulin twice daily. And so I think if you could just touch on that aspect and explain.
I think it's an excellent question.
That's a great question, and I'm sure all of you know the answer, but I guess it's the total daily amount of basal that you use. There's many studies now which show that there is no stacking with twice daily IDEGASP. There were 2 very large studies which showed that. in fact, the rates of hypoglycemia were less, and there's also studies on glucose variability, etc. So really, you know, it's twice daily. There's no issue with stacking, and there's very nice illustrations mechanistically to show that too. I'm very happy to share them on another occasion with the questionnaire. But we generally we do not recommend using it 3 times a day. If there's a third prandial elevation, we use aspartate. Yeah.
Could you also comment on the use of insulin in situations of hepatic impairment or renal impairment, elderly patients, and so on?
I'm sorry. Well, there was a question about the use of an elderly and hepatic
The use
impairment.
of this insulin in hepatic impairment, renal impairment, elderly patients, and so on.
Sure. Well,
Is
we
there
know
any
that
particular advantage or any cautions that need to be taken?
Sure. Well, we know that the data with degludec, that regardless of the degree of renal function, that there is, you still use your clinical acumen and, you know, start slowly and probably titrate slowly as well. But there's no need to alter the dose generally with degludec in terms of hepatic or renal impairment. And with the elderly also, there's nice data with degludec, again, showing no change in the amount of insulin required. But it's just so convenient to use in the elderly. You know, Australia is sad because a lot of people don't live with their families, so they just get visited once a day. And so this is an ideal insulin to give when they're having that one, you know, reliable meal, I guess. Yeah.
There's one question, Harish, for Mala. Very interesting question. Mala, the questioner says that with very, very strict diabetes, strict dietary control, can you intensify the intensifying insulin or going over to IDODEG, IDEG-ASPAN, etc.? Can it be controlled? Can it be avoided? Probably she sees you as a strict endocrinologist. How strictly you can establish a strict dietary control not to increase postprandial hyperglycemia?
So that's a very good question. Yes, as endocrinologists or physicians and diabetologists, when someone has a postprandial hyperglycemia, that's the first thing we look at. What is his food? Is it balanced? Has it got enough of fiber? And will that control decrease his postprandial glucose? That's the first thing we tell him to do. And in spite of that, if he's not able to control, you should understand in diabetes, the metabolism of carbohydrate is different. And in spite of all this, his postprandial may still go high, in which case he would need the co-formulation of a short and a long acting to control the spike that happens post-meal. But if you can do it with diet, why not? So I think that's a very interesting question. And I would definitely tell the patient to look at his diet again and help him with that.
Yeah, but Mala, the joke is the patient asks us, this diet you said is before my meal or after my meal? The strict diet will be before my meal or after my meal. They don't understand. I think that's a very, very interesting question, Harish. I'll just take up this question. That it says that to Roger, Chad, or Mala, both of them can identify the situation where you will give IDEG-ASP. I think Roger is a very, very, very innocent question. Where you will give IDEG-ASP, where you will give, he asks, GLP-1, where you will give SGLT2. Do you have any particular characteristic of the patients where you do this? Roger,
Dr. Mala, do you want to go first?
Mala, you can take up first.
Ladies first, always.
Ladies first, yeah.
So
conveniently, Roger has given to you. Yes.
No, I'm glad, because whatever I miss, he will take up later. So what I would do if you look at any of the other drugs, whether it's SGLT2 or GLP-1, all of them have a limit of reducing the HbA1c. It may be maximum of 1.5%. It won't happen more than that. So obviously, when you want a very tight control and your sugars are very high, you have no choice but to give an insulin. And when the HbA1c is very high, it's always better to give a co-formulation rather than just the fasting being high. So in a typical situation, if the patient is on a very simple medication like metformin and his postprandial is high, possibly an SGLT2 or a GLP-1 would be a treatment of choice. But when he's finished it, he's on 2 tablets or 3 medications, oral medications, I don't think there's any point in further trying to increase the dose or adding more tablets, because we have to understand that the insulin reserve also will be less. And at that time, it's the best to start.
I think at the case we showed, it showed 4 oral hypoglycemics already used in that case. So I think Roger, that is superb. And also it is better to have one injection taken twice a day or once a day than having multiple varieties. Yes, Roger, you are saying something.
I can't agree more with Dr. Mala. I think those are very pertinent points. I'm smiling because that's the art of diabetes, and that we have all these choices, and then we have to work out what is the best medication for the patient. And I completely agree with those comments. I mean, often we have people who are very overweight, who maybe HbA1c is not that high, and so we might use a GLP-1 receptor agonist in those. But again, I think diabetes is so heterogeneous, and amongst our Asian population, by Asian, I mean Indian, South Indian and East Asian, often I think it's a different type of diabetes as compared to the typical overweight white person. And that's why insulin, I think, really needs to be considered a lot more often, rather than just going through Dr. Kamlesh Kunti's, inertia. We just wait and wait and wait. We try one thing and another thing and another thing. Well, we know insulin is actually going to work.
Yeah, Harish, would you like to add anything else?
Yeah, I think I'd just like your comment on whether any concomitant diabetic medication should be stopped when you initiate IDEGASP.
Brilliant question.
Somebody
taking sulfonylurea, etc.
Yeah, so I think metformin always continue, SGLT2 we try to continue, DPP4 we continue. The sulfonylurea, what we decided is that there was no actual consensus. We have some centers where once you start a premix or a co-formulation, you will stop the sulfonylurea. Other people said we halve it, and some people said we just continue it and stop later. But I generally halve the dose of the sulfonylurea while the co-formulation takes a while to work. And we know that the sulfonylureas, to a small degree, have some insulin sensitizing activity. I mean, it's not their main function, but often when we do stop the sulfonylurea, the sugar levels go high. So I tend to sort of halve it and then wean it. But again, I'll be interested in see what the others say.
Yeah, Mala, will have any comments on this, Mala?
I think I fully agree with Roger on this particular point. I do the same. I'm not a very terrorist saying, okay, once you start short acting, you should stop sulfonylurea. If you do that, your sugars will go so high and the patient will come and say, doctor, you gave some insulin, the sugar is gone high, it's not working.
That's right.
So I usually continue half it. And then once the sugar comes into control, then if the medication load is too high, then I would stop the sulfonylurea once.
Mala, I have some difference. We used to practice sometime, at long time by beats, bedtime insulin, daytime sulfonylurea. Remember the combination therapy?
Yeah.
But with the advent of IDEGASP, I'm not very sure whether it is. I think, Harish, you are the questioner. You can be the final answer giver. I think once the advent of IDEGASP, I think I mean, that's my personal feeling, that we need not give sulfonylurea, which can produce some difficulties. Because
that's right. I think if it's given once daily, then I think certainly it should be given with the major meal.
Yeah.
And so there's no need for a sulfonylurea or anything along with that.
So for example, if you give the Ryzodec in the evening with the biggest meal, then the patient is still having breakfast. Sometimes the sulfonylurea will do the job then. Yeah.
That's right.
Yeah. I think one of the things that was built in Mala's talk, that have a breakfast like a prince or a king, have a lunch little less, and dinner of a pauper. So I think, Roger, in Indians, I think I don't know, I stand to be corrected. In the areas that I practice, it is mostly a heavy breakfast and a moderately heavy lunch, and a dinner which is very few and far between, at about early dinner. And that has been recommended, Mala, in your paper you had that has been recommended as a contributor to prevent heart disease, early death, and also that. Roger, what's your take on that? Is Australia famous for a very heavy dinner?
That is the biggest meal normally. So most of the Ryzodec we do at dinner time. Yeah. But then again, the weekend they have a very big.
You said that. That's a beautiful concept of changing. We can change it. So the bottom line is, give Ryzodec. It is simple. It is convenient. It works. And now in India, price has been slashed. And also this drug gives wonderful control without hypoglycemia, and give it with the measure meal, whatever the measure meal. Am I correct, Roger? That
Absolutely.
should be the.
I can't say it any better, Dr. Kumar.
Good. Very well. I think I'm just seeing the chat box. Is there any other question left? But I think we have taken up all the questions that had come, and we like to have that just last. We have got 2 minutes left. Can you just, Roger, tell us about the Rupa Mehta's and yours this latest guideline that you have brought out? Anything extra that we did not discuss in this meeting?
Sure, sure. I mean, I think it's based on, I guess, clinical experience, and there were a few people from India, one from Turkey.
Yes, I saw the name of my close colleague, Uni. That is Harish colleague also.
Uni Krishnan, yeah.
Yes, I saw his name. Yes.
And he's always very entertaining during the airport. But basically, it was what to do with the oral therapy. It was what to do in hospital, where we generally don't recommend that Ryzodeg is used if you're very ill in hospital, because you want to titrate things very quickly. Then you probably should switch back to a premix just for that hospital stay, or basal bolus, and then when they're out of hospital, put them on the Ryzodeg. But we also did, for example, considered, the recommendations are that if you're on a basal such as glargine, you just do a 1-to-1 switch. But what happens if someone's on 90 units of glargine?
Yeah, exactly.
So you're not going to put them on 90 units of Ryzodeg. So that's why you have to think about, splitting the dose. So there's a few little issues here and there. Again, what is well known that there's no safety data in pregnancy, etc.
Yeah. Thank you very much. I think Harish, final word from you. Harish?
I think it's quite clear that there's just one last clarification I'd like. Again, a practical question. When you titrate the doses of Ryzodeg twice daily, which sugars should you check and target? For example, you're giving Ryzodeg at night. Do you titrate it according to the fasting? And the morning Ryzodeg, which sugar should you check to titrate the dose?
I think it's, and again, I'll invite discussion, but it's very similar to what we do with premixes, I think. So I realize the Ryzodeg is very long acting, but we still use the breakfast glucose reading for the evening dose titration, and then probably the pre-dinner reading for the morning dose titration. But then, yes, it would be a little bit of an overlap. Yeah.
Thank you, sir. Thank you very much. Thank you, everyone, for that wonderful symposium. Up next, we have the MSD Symposium, Gliptin Symposium.
Thank you.
And as the moderators, I would like to invite Dr. Vijay Neglur. He is the general endocrinologist, diabetologist, and consultant physician at Dr. Neglur's Diabetes and Thyroid Specialty Center, Thane. And also Dr. Matthew John. He is the endocrinologist at Providence Endocrine and Diabetes Specialty Center, Tirunelveli. Welcome, sir.
Dr. Vijay, you want to introduce Dr. A.K. Singh, or shall I do it? Yeah, I'd like to.
Yeah, you go ahead.
Yeah, I'd like to welcome Dr. A.K. Singh. Dr. A.K. is a very personal friend, and he's the senior consultant endocrinologist at Calcutta. And his very recent achievement is being the editor of Williams Textbook of Endocrinology, South Asian edition. I'd like to ask A.K. to start his lecture. A.K., you can start sharing your screen.
Yeah, thanks, John. Again, back. Thank you, JYOTHYDEV and team for this invitation. So, Chairman, I would like to remind you that please give me a alarm if I am able to, so that I can finish on the time, 2 minutes before my talk. Although I have got only 12 slides, so this is a big topic not to be covered in 15 minutes. That's the first disclaimer. This is MSD Symposium, but MSD has nothing to do with presentation. They don't possess my slides. Everything is brand new. Yeah, okay, so I would just shift focus to metformin and DPP-4 inhibitors. So as you can see, my topic is on anti-diabetic drugs in COVID-19. So we are talking about type 2 diabetes, and we are focusing on metformin and DPP-4. In fact, we could not have focused on pioglitazone and SGLT2 or GLP-1 because we don't have any study published so far in COVID-19. The good thing is that I have got two papers on metformin and DPP-4 individually as well, and I looked into the data in detail so far published on metformin and DPP-4 in patients with COVID-19 and diabetes. So let's look at where is the literature and where is the data with regards to these two drugs in the treatment of diabetes in patients with COVID-19. So this paper came in DRCP, as you can see, two of our colleagues from PGH Chandigarh. This was one of the very first paper came somewhere in March, 2020, in the initial phase when several paper linking, ACE and ARB with the COVID-19, because we come to know that the ACE2 is the principal receptor for SARS-CoV-2 entry into the human being, and any drug which has a potential to increase ACE2 may have a theoretical potential to increase COVID-19. With this limited knowledge at that point of time, people have started writing and proposed that certain anti-diabetic drug could be dangerous, with regards to the SARS-CoV-2 infection. So this is the table which hints at that the drug which should not be used in patients with COVID-19 and type 2 diabetes. First of all, let's look into insulin. What is the data for insulin? Since insulin has nothing to do with regards to the level of ACE2, so these group of others propose that absolutely fine with insulin, and you can use insulin at any stage of COVID-19, mild, moderate, severe, or critical. When it comes to metformin, although this paper said that concern with regards to the ACE2, so you can go ahead with the metformin, but several people said that don't use metformin if your patient has got a COVID-19, and I will come back to those details a little later. When it comes to sulfonylurea, since sulfonylurea has nothing to do with the ACE2 level, so they said fine, it doesn't seem to have anything to do with SARS-CoV-2 infection, susceptibility to contract the disease, and I mean to say, so you can use with sulfonylurea. They were very concerned about pioglitazone and offered not to use pioglitazone because pioglitazone increases ACE2, especially in the experimental studies, as well as the human data suggests that it can increase ACE2. So there is a theoretical risk of poor outcome if you contract or there is a chance of contracting SARS-CoV-2. The is for the liraglutide one as well, because these drugs increases ACE2 and actually in terms, because of increase in ACE2, that reduces the cardiovascular risk. So theoretically, it was proposed that if you increase the ACE2 like liraglutide, you can contract SARS-CoV-2 infection. The SGLT2, again, the SGLT2 increases the renal ACE2, but then that's the mechanism by which it protects kidney and as well as the heart. So theoretical concern with SGLT2, they proposed, to not to use SGLT2 in patients with COVID-19. DPP-4, these others suggested that's a fantastic drug, and DPP-4 could be one of the entry receptor for SARS-CoV-2, like their elder brother, MERS-CoV, where the DPP-4 was the principal key receptor for the entry, and people thought that DPP-4 inhibitor might be even useful in preventing SARS-CoV-2 infection, and the people proposed that theoretically DPP-4 inhibitor should be useful as a repurposed agent. Hydroxychloroquine has been approved in India, and as you know, in the initial stage there was a lot of small papers came out showing some positive result, and therefore the authors opined that this could be a wonderful drug in the setting of COVID-19. But remember, as I said in the beginning, that this paper was published in early March, and it was the early time, so I will not blame the authors for the initial concern they looked in. But remember, there was no data at that point of time upon which these proposal was based. Nevertheless, several guidelines came into the picture. We were the first to propose, guidelines for diabetic patients. But remember, this is just expert opinion based on our experience without any data. And we did propose that with regards to the anti-diabetic drug, in patients with severe COVID-19, to preferably use vitamin N2 just because of consideration of the risk of lactic acidosis in a compromised renal and hepatic setups, as well as the risk of euglycemic decay with SGLT2 inhibitor. But we were maintained caution only in patients with severe COVID-19. We did not say to stop metformin and SGLT2 in mild to moderate. But again, remember, with a caveat that we didn't have any data, that was a common sense proposal for treating clinicians. So we proposed not to use metformin SGLT2 in severe COVID-19. We were the first to go ahead with this proposed guidelines, and that's the reason this paper has been cited now 150 times, perhaps the highest in the diabetes any expert group consensus. Next came in this Lancet Diabetes Endocrinology paper, a group of experts across the world, as you can see the authors list. They also proposed not to use metformin, but then in every patient with COVID-19. That's not the criteria for only severe like we proposed. They said not to use metformin, not to use SGLT2, not to use GLP-1. They've showed the concern, just a similar concern of lactic acidosis, euglycemic decay with SGLT2, and chance of having more nausea and vomiting with GLP-1. But they were fine with DPP-4 and insulin as everyone. The third guideline came from the UK, and this is a ABCD position statement published in Diabetic Medicine. They also went like us and proposed not to use SGLT2 and metformin in patients with severe COVID-19. They allowed up to mild and moderate. But then again, with a caveat, during all these three proposals, there were no published data so far with any of the anti-diabetic drugs. So let's look into what happens next. So we looked, as the time passes by, we looked into the data, and this is our paper published recently in DRCP, and we took one by one point with regards to the different anti-diabetic drug, and the data emerged, during the last 3-month course of time with different anti-diabetic drugs. What we proposed in this paper that all drugs are fine as long as you have got mild to moderate COVID-19. There is no data with regards to experimental, pre-COVID lungs data or data in patients with sepsis, as well as the COVID data, which suggests that you should not use, these particular drug in patients with COVID-19. Of course, insulin remains the drug of choice in, any degree of COVID-19. But then with regards to the other anti-diabetic drug, we propose that absolutely fine. We don't have any wrong signals with these drugs. And you can use at least up to mild to moderate. However, time has changed, so we need to look into, as this space is very dynamic and fast, so we have to keep pace up with recent data. So we looked into, individual drug again, one by one. So we published this recent paper less than 2 weeks back, and we proposed the metformin data as one of the useful drugs, especially someone with COVID-19 and type 2 diabetes. And where from this we proposed in this commentary with this emerging evidence with the metformin. As you can see, the lowermost panel in this table, we have got 4 studies where people looked into whether metformin users had a different kind of outcome compared with the metformin non-users. So the first 4 papers is, pre-COVID data, and the next 4 paper is the during the COVID, pandemic. And as you can see, what is interesting to note that majority of these studies, almost all studies so far, suggested that metformin can reduce all-cause mortality. It's not only the reduction in the severity, but the reduction in the all-cause death in the metformin user compared to the non-users. Especially the last study clearly proposed that metformin users with type 2 diabetes had 4-fold less death compared to the non-users. After this publication, a new paper came into, although this is not yet published and this is not yet peer-reviewed and published data came up in the Medrix, and this paper became very popular, came into many newspaper and Medscape as well. And this paper was very fascinating with regards to the metformin. And as you can see here, this paper suggested, huge data, more than 6,000 patient data, suggested that metformin users, especially women, had a significantly less death compared to the metformin non-user. And as you can see in this graph, although there was no difference in the death in men, but there was a significant reduction in death, especially in women. Those were the metformin users compared to the metformin non-users in the propensity mask model. So this paper has actually, taken everyone into different kind of thinking that metformin could be one of the agents amongst the anti-diabetic drug that can reduce death in patients with COVID-19. That more to in the women from this particular study. What about the DPP? So this is a paper right now. It's in a preprint stage. It will come anytime in Journal of Diabetology, edited by Professor Mohan. So again, we looked into the DPP-4 data, and from the very beginning, DPP-4 looked very lucrative for the treatment of COVID-19. For the several reasons, the people thought that the SARS-CoV-2 can also use DPP-4 along with the ACE2, and we proposed many papers which suggest that DPP-4 can be a co-entry receptor with the ACE2. We know that DPP-4 was already the key receptor for MERS, so there is a possibility that these, SARS-CoV-2 virus during the due course of time can mutate and behave like their elder brother and can involve DPP-4 as well. And so there is no harm in using a DPP-4 inhibitor. There is also new data which came which suggested that DPP-4 inhibitor chemical structures are very similar to the SARS-CoV-2 viral protease. So if you use a DPP-4 inhibitor, it is looking like a competitive inhibitor to the viral bindings to the DPP-4 enzyme, and many proposed through the X-ray crystallography that some DPP-4 inhibitor could be used.
Excuse me, sir, you have 2 minutes left.
There was also a theoretical proposal that it could have anti-inflammatory, anti-fibrotic, and immunomodulatory properties, as we saw in various experimental as well as human data. And the final important point that, as you can see, the people with having diabetes and obesity, and those in particular are elderly, are more susceptible with the SARS-CoV-2 infection, and have got higher mortality. All of these patients had heightened DPP-4 activity, so it was proposed that DPP-4 inhibitor can be used as a repurposed agent in the patients even without diabetes. Now, where is the data? So we looked into the data. As you can see, we have got now 6 papers which looked into the role of DPP-4 in patients with COVID-19 and their outcome. So initial 3 papers suggested no harm, no benefit. I am not going into the details because of lack of time, but the first 3-4 papers suggested there is no harm, there is no benefit with DPP-4 inhibitor users compared to the non-users. The last 2 studies, although gave a very different hint, and the last paper is the largest paper so far on the DPP-4 inhibitors. You can see this is data from South Korea, 263 patients receiving DPP-4 inhibitor, and they found there is a 64% decreased risk of having a severe COVID-19 compared to a DPP-4 non-user. So that's amazing data which are emerging even with the DPP-4 inhibitor. But again, remember, this data is not as good as metformin, which suggested 4-fold decrease in the death, like metformin. DPP-4 has data on severity risk reduction only. So, ladies and gentlemen, there are few trials undergoing. Sitagliptin is undergoing trial in Italy. 2 RCTs currently being done with linagliptin, one in Israel and one in USA. We need to wait for these RCTs, especially for the DPP-4, because whatever the data we have is from the retrospective at this point of time. So to summarize my presentation with regards to the metformin and DPP-4, what we understood through these papers, the metformin has shown a significant reduction, as I have shown you, 4-fold decrease in death compared to the metformin non-users, and these are much more beneficial in women. For the DPP-4, there was a significantly relative risk reduction in DPP-4 user compared to the non-DPP-4 inhibitor user. So you can propose that combining a metformin and DPP-4 could be useful during this pandemic of COVID-19 in patients with type 2 diabetes. When it comes to finally concluding my thoughts on these 2 particular agents in anti-diabetic, although the data for DPP-4 inhibitor is the retrospective one, and therefore we need to have a randomized control trial, which I have shown you at least 2 trials right now going on with the DPP-4 inhibitor. However, the reduction in all-cause death that with metformin, even in the retrospective data, cannot be overlooked, even in the absence of randomized control trial. Thank you very much for your patience, please.
Thank you, Dr. Singh, for your amazing talk. It was very wonderful. We'll have a question answer at the end of all sessions. Stay on. And next speaker, I think, is Dr. Manoj Chawla. We have his CV, Dr. Manoj Chawla. I think there is no need to introduce him. He's such a popular person in Bombay and India, in fact, in the world. The young, dynamic diabetologist from Bombay. And he is a director and consultant diabetologist at Lena Diabetes Center and honorary visiting faculty at DY Patil Medical School in Mumbai, co-trainer in National Diabetes Education Program. And
thank you, sir.
Okay, with this
yes,
brief interview, I think I
yes.
hand over to Dr. Manoj for his talk on what we talked is the normal role. What is it? The new normal, the new normals. Okay.
All right. Thank you, Dr. Neglur, and of course, thanks to Dr. Jyoti and team. Let me dive deep directly into the topic after Dr. A.K. Singh's presentation. Right. So, okay. So I'm going to be talking about the new normal, specifically the role of the gliptins. So this, for many of us, is the new normal, and I apologize to my dear friends who I am speaking today with. This is what I guess all of us are doing, and this may be the new normal in the near future. We'll probably talk more about it in the panel discussion, and I'm open to whatever Galis AK and JJ have for me. So the objective is to discuss the challenges faced by type 2 diabetes patients and HCPs, prepare for the uncertainties in the near future, discuss the role of gliptins, and of course, discuss simplified and easier to adopt approaches. So Dr. A.K. Singh gave us some excellent emerging data. Yes, I think we all understand that this pandemic is still pretty much on, and a lot of things are being realized and discovered as we proceed ahead. A lot of our concepts and beliefs are changing, so nothing is final yet. We are still coming to terms with this dreadful pandemic. So the considerations is, for obviously the type 2 diabetic patients are more vulnerable. Initially, it was thought that it was only the increased incidence of complications in patients with diabetes, those who contract the disease. But today we know there is clear emerging data that patients with diabetes may be in fact more vulnerable to this infection. And of course, worsening of glycemic control. There has been reduced patient healthcare touchpoints. A lot of the clinics were shut initially. People who were not using telemedicine started gradually getting into using softwares and connecting with patients. So things have improved, but there have been overall reduced touch points between patients and the healthcare practitioners. From the patient's perspective, there's been difficulty in maintaining a healthy lifestyle. Most have not been allowed to move out of their homes, their areas, their buildings for a long time, so not enough exercise. And of course, the challenges with medications, nutrition. I think all of us have been aware of how some of the medications have not been available. Patients have struggled to get the medication. So all these have been issues faced by patients, and this is the fact that we have to face with. Some of the technology can help in here, but that's not been accessed by all. So the management objectives in this scenario is certain additional efforts in ensuring control that we as physicians need to take. Counseling, very important to stay connected with your patients and start making some shared decision making. Ensure better compliance, so to come out with suggestions for patients about them being compliant with medications, their ability to improve monitoring, and certain ways for them to be able to adhere to the lifestyle modification that we keep talking about. So somewhere here again, the patients are looking at their physicians of suggestions, help of how to manage that in this changed new normal. And making the right therapeutic choice, which is focusing today on using drugs which are both efficacious and importantly tolerable. And I think that also, besides the data which has been supporting metformin and gliptins as shown by Dr. AK, clearly today when we start thinking about managing our patients, we are looking at drugs which have the least possible chances of causing any of the side effects and complications. And of course, using drugs which are tolerable and proven efficacy. So we need to educate the patients about importance of good control. A lot of them themselves have realized about the same and want control to be better because of this fear of the pandemic. And again, I would emphasize, embrace technology wherever possible. Now, many illnesses can affect the blood glucose levels, be it the common cold or flu, including any of the viral infections and COVID-19, sore throats, UTIs, skin infections. Sometimes it is the use of steroids, which is taken during any of these illnesses, or the change in dose of steroids for those who are on some maintenance dose of steroids. Some of the suggested steps for COVID-19 infection and diabetes, important to remember, many patients with diabetes have symptomatic diabetes and symptomatic diabetes includes I think that has been one important aspect, which I'm sure all of us have been following, is staying in touch with the patients and emphasizing on more regular monitoring during this pandemic. Again, as I said, there was an issue. Some of the patients were struggling to get the strips, they were struggling to get the lancets. The first few weeks, there were practical issues with these, but things are settling in now. Now, these are the consensus recommendations for COVID-19 and metabolic disease. Again, there have been various multiple recommendations and expert group opinions for COVID and metabolic disease. I'm quoting the Lancet paper, which is talking about brief outlines for outpatient care and inpatient care management. So outpatient care, predominantly prevention of infection and diabetes seems to be the recommendation. Sensitization of patients with diabetes for importance of optimal metabolic control, optimization of the current therapy, caution with premature discontinuation of established therapy. So there were a lot of fears. Initially, there was some worry where DPP-4 inhibitors have to be stopped. Are they going to be harmful? Should ACE inhibitors, ARB, should be stopped? Are they increasing the vulnerability to the infection? So clearly, again, important to caution patients about premature discontinuation of any of these drugs without consultation with their healthcare practitioner. For the inpatient units, again, a completely different ballgame when a patient with COVID is getting infected. It's, of course, much more close monitoring of all the metabolic parameters, including looking at ketones and use of IV insulins wherever required. The therapeutic aims largely recommended is to keep the plasma glucose between 70 to 140, HbA1c less than 7, to have your CGM and FGM targets at the time in range more than 70%. If the patient is old and frail, then 50% is okay. Again, the similar TIR targets of having hypoglycemia less than 4%, less than 1%, again in the frail and the elderly, and keeping the plasma glucose time in range predominantly between the 70 to 180 target mark. Now, some of these drugs, when we talk about the predominant used drugs in the management of diabetes, they have been covered, and I think a couple of papers Dr. A.K. Singh also showed. But some of the fears that we come across, and that's why I have tried to highlight the final message from the drugs. Metformin would be extremely effective, of course, for hospitalization. For patients who are hospitalized and critical, we will be stopping most of the oral drugs. Worry with metformin in those times is dehydration and lactic acidosis. So hospitalized patients, critical patients, we stop. SGLT2 inhibitors, again, similar worries of risk of dehydration and diabetic ketoacidosis during illnesses. GLP-1 receptor agonists, again, chances of either GI side effects or dehydration. DPP-4 inhibitors, again, unless the patient is critical, and patients who are mildly symptomatic or asymptomatic, DPP-4 inhibitors are generally well tolerated. Insulin, important to continue insulin. Insulin should not be stopped. Again, important to remind patients to keep monitoring and using insulin as required. So for people with type 2 diabetes on insulin, remember that there are certain guidelines, again, put down by the IDF. If the blood glucose levels are more than 180, increase the insulin dose. Testing should be more often if the sugars are more than 270. If there is persistent blood sugars more than 270, then to start looking for the presence of ketones. And if there are ketones, to immediately contact the healthcare provider. So management of diabetes during the new normal, sticking to the basics. Importance of follow-up with the patients is to remind that patients with uncontrolled diabetes may be at higher risk. Glycemic status may worsen with infection. Glycemic status may also worsen because of the changes in lifestyle or inability to follow the lifestyle during the lockdown. There is important role of discussion and counseling, again, with the patient and shared decision making, and embracing technology where possible. Now, this was a Times of India article which spoke about diabetic patients report a rise in blood sugar level during the lockdown by 20%. And also, there were observations which were published about infections do cause loss of glycemic control. Important to manage hyperglycemia during these new normals, to maintain optimal glycemic control. So these were the earlier reports. There were certain other papers. I remember Dr. Binayak and others also have published data on this projected model of worsening of glycemic control. In fact, there are many more studies ongoing, and people are looking at, as this lockdown is extended and the pandemic is extended, is it true that the glycemia is worsening, or some by now are actually seeing an improvement in the glycemic profile? Well, the final word on that is still awaited. Important again to remember as we are facing this pandemic that we need to be prepared for a long haul and multiple waves. Currently, most of the cities in India are in a condition where we're seeing all these waves. So you're seeing that the population is also experiencing the rise and the surge with more mortality. You're also seeing issues with the second wave, which is impact of resource restriction. You're also dealing with patients having interrupted care, whether it's physiotherapy or any other assisted care, especially for the elderly. And then all the issues coming with the prolongation of the pandemic, which is to do with depression, mental illness, economic injury, and the burnout that probably everybody would be facing. So the take-home message from this slide is that disasters and pandemics pose unique challenges to healthcare delivery, and all of us need to be prepared better, which means that we need to develop a system to be remaining connected with the patients. And I'm sure all of us have adapted to that, to communicate with the patients with whatever means. There are important issues which are regarding insulin titration, avoidance and management of hypoglycemia, and management of hyperglycemia. So this is true, especially in patients who are more vulnerable, elderly, brittle, so-called, and of course those with gestational diabetes. Moving on to oral antidiabetics in the new normal, what are the desirable attributes? So when we talk about oral drugs, what could be used? Ones which are reasonably effective, don't require frequent titration or dosage adjustment. They are associated with less fluctuations of glycemic status. They are not associated with specific concerns regarding infections, which require immediate attention or more recurrent follow-up consultations with the doctors. They should be well tolerated, less chances of need to adjust the dosage or keep modifying the dosage, and of course the ones which require less monitoring. So let's look at the data for gliptins. Why are we considering gliptins in terms of efficacy? When we compare gliptins as shown in the green here to metformin, sulfonylurea, glitazones, or voglibose, it has similar or better efficacy compared to any of these comparators. When we even compare with SGLT2 inhibitors, we see a similar reduction in HbA1c for sitagliptin as compared to Cana 100 and empagliflozin 10 milligram. Now, gliptins generally do not require frequent titration or dosage adjustment as compared to most other drugs which may require starting slow and then up titrating, except for probably vildagliptin, which is used in a BD dosage. Most of the other gliptins are one standard dose and no issues with continuous monitoring and titration. Importantly, gliptins are associated with less glycemic fluctuations. So here in the data, we are showing DPP-4 inhibitors compared with sulfonylureas on the top, and DPP-4 inhibitors compared with all other oral antidiabetics, showing that the glycemic variability is much lesser for the gliptins as compared to the other drugs. And this was seen by a reduction of MAGE, which is mean amplitude of glycemic excursions. Also, gliptins have demonstrated durability over a prolonged period. Again, strong data for gliptins. They've been around for over a decade. Sitagliptin having some good data about monotherapy remaining durable over a 4-year period. We look at a combination of gliptin and metformin, something that Dr. AK also alluded to as compared to sulfonylurea and metformin. And we see that though there may be an initial better reduction by the sulfonylurea metformin, but that gradual weaning off which is seen in SU-MET is not seen in gliptin-MET combination. And this is great data over even a 7-year period. Also, in terms of adherence, so clearly when compared in this paper between sulfonylureas, TZDs, DPP-4 inhibitors, in terms of better adherence and more compliance, patients on the DPP-4 inhibitors have shown better adherence seen in the blue as compared to the other drugs in question here. What about safety? Again, safety of gliptins. So gliptins largely are also chosen because of the issue of no much headaches of safety, using the drug without drug modification or a dose modification, and no real concerns.
Excuse me, sir, you have 2 minutes left.
Right. So in terms of metformin, it has certain issues in terms of renal or hepatic impairment, and these are the contraindications listed. For DPP-4, there's none. Boxed warnings, again, for DPP-4 inhibitors, there are no boxed warnings. When we look at warnings and precautions, so for each group, metformin or SUs like hypoglycemia, glitazones with fluid retention and heart failure, SGLT2 inhibitors, of course, hypertension, ketoacidosis, urosepsis, and so on. For DPP-4 inhibitors, there's chances of hypoglycemia with SU. Saxagliptin has concerns with the heart failure, vildagliptin to be avoided in hepatic impairment, and teneligliptin with QT prolongation. So these are the warnings and precautions, but largely still considered safe. So in the new normal, our concerns is about bringing patients back to the clinic. We need to create an atmosphere and environment where we are making the clinic conducive for patients to come back post the lockdown. We are also trying to bring about new normals of minimizing the contact. So no touch registration, using of PPEs by the clinic members, using a lot of electronic methodology to again reduce the contact points for the patients, and importance of feedback and data from the patients and their families and the healthcare givers. This is important for us to note that there's been a decline in the outpatient consults, and a lot of it has moved to telemedicine. As seen, almost 30 to 40% of the practice for all of us is moving to telemedicine. Telemedicine is the delivery of healthcare service where physically you are not able to see the patient. There have been guidelines issued by the Government of India and Government of Health and Family Welfare, which is enabling the RMPs to use it. Also tells them to undergo a course within the next 3 years. Telemedicine application talks about 4 basic types according to the mode, according to the timing, according to the purpose, whether it's emergency or emergency, and also in between who it is involved, whether it is RMP to patient or caregiver to RMP. There are also restrictions on what kind of medications can be used. Important to remember that diabetes medicines like metformin, glibenclamide come in list A. Diabetes medications like sitagliptin, addition to metformin, come in list B. These are all okay to be done through video consults, and these are part of the guidelines. So to summarize my talk, tight glycemic control is important. Empowering physicians, patients, and healthcare workers in managing diabetes will support patient care during this pandemic. Gliptins continue to be a viable option during the new normal, all the evidence shown for the same. Use of telemedicine and technology will be part of the new normal, even as things open up. In the near future, you will be seeing some patients physically and some will continue to be through telemedicine. And holistic care of the patient with diabetes is far more important, and that's what we all need to be doing. Thank you so much for that patient hearing.
Yeah, thank you, Manoj. This is a wonderful lecture. I think it is quite comprehensive in terms of the coverage. The next speaker for the day is Dr. JJ Mukherjee. Dr. JJ does not require any introduction. He's an endocrinologist based in Calcutta, and he works with the Apollo Gleneagles. So he'll be speaking on again on gliptin and which gliptin to choose and how to differentiate that. JJ, the stage is yours.
Thank you, John. Am I audible to everybody?
Yeah, you are.
Okay, so I'll share my screen. Thank you for correcting the topic. The topic was not how differentiated is the differentiated one, but is which gliptin to choose. And I'm not going to focus too much on COVID because we have heard enough about COVID. There's one line I would like to say: all drugs are safe in COVID. Okay. No matter whatever you saw, all the data you saw, we can have question answer session and we can have fun. So I'm going to talk a very simple generic talk about which gliptin to choose. Now, ladies and gentlemen, if cost is an issue, if you want to bring gliptin and cost, please follow the ADA ESD guideline, which goes on the right-hand side that you see. Use metformin, use sulfonylurea, use pioglitazone, and then use basal insulin. And you'll be surprised that about 40 to 50% of people worldwide use sulfonylurea as a second-line drug after metformin. But if you want to manage diabetes in the right way, where you don't want them to gain weight, that you weight neutral weight loss, no hypoglycemia, get extra glycemic benefits, and have CVOT data, I think the newer generation oral diabetic agents, DPP-4, GLP-1, SGLT2 inhibitors come into the picture. We can keep discussing which is better, which to add when, but today the focus is on DPP-4 inhibitors. I'm going to focus more on DPP-4 inhibitors. And Manoj, this is what happens. If you go to a supermarket and if you have so many DPP-4 inhibitors to choose from, I sympathize with this guy. And I think this is the same thing which would happen if you go to choose a car, you know. I mean, Manoj maybe doesn't need to worry so much, but people like us, we need to think hard as to which one to buy. So many things to look for: cost, performance, etc. Which smartphone to choose, which laptop to choose. So Dr. Mukherjee, you're talking about, you know, not non-medical things. Okay, let's come to which sulfonylurea to choose. Glimepiride, viclazide, which ACE inhibitor to choose, which ARB to choose, which statin to choose. I mean, there's so many. So it's always difficult. It always depends. And depends on what? Number one, availability. Now look at the availability of DPP-4 inhibitors on the left-hand side. If you're in South Korea or Japan, you will have 12 of them. Fortunately, you're India. Not so fortunately, actually. You now have about 8 of them to choose from. Gemcitabine is out. We don't get gemcitabine so easily anymore. So you have Sita, Vilda, Lina, Saxa, Tenali, Allo, and Evo have just come into the market. Allo 2013 and Evo 2016, that's when it was launched worldwide. But if you come to India, 2019 and 2020 is when these two molecules have been launched. So exactly like that man who was lying flat on the supermarket floor, trying to decide which one to choose. So you see, decide your choice, what you want to buy, what you want to eat, but certain things you look at when you go to buy something. First and foremost is selectivity. We know that DP4 inhibitors do not only inhibit DPP4, they inhibit many other enzymes. They inhibit DPP8, DPP9, FAP alpha, PEP. If you want to know what is PEP, that's down there for you, propyl endopeptidase. So whichever one you want to choose, if you take evogliptin, not much data on PEP. If you take linagliptin, it's not so specific for FAP alpha. If you take saxagliptin, teneligliptin, or vildagliptin, they're not so specific for DPP8, DPP9. Does it mean that they're bad? Of course not. Of course not. 270-fold, 32-fold, 77, 390-fold is still quite safe. But then, you know, in diabetes, you're going to use the medicine for a long period of time. I have people on sitagliptin now for about almost 10, 12 years now. So if you give somebody a particular molecule which is altering DPP8, DPP9 over such a long period of time, it's very hard to tease out from the background noise of various malignancies as to whether this molecule is adding to that burden. So it is always safer to use something which is very, very specific. And if you take sitagliptin there, you see everything is above 2,500. So it's very specific DPP4 inhibitor. Then you will say, what's the efficacy? I'm going to buy a car. How much miles do I get, kilometers do I get for per liter of petrol? Fortunately or unfortunately, all of them are same. If you go to different studies, different meetings, evogliptin meeting, allo meeting, sita meeting, vilda meeting, you will hear subtle differences, we are better, etc. Actually, it's not. It all depends on the baseline HbA1c. If you have the baseline HbA1c same, playing field is same. HbA1c reduction is the same for most DPP4 inhibitors. There are very few randomized controlled trials between these molecules. You have between saxa-sita, gemi-sita, evo-sita, where you will find that the reduction in HbA1c was similar, i.e. Gemi, Evo, and for that matter, Allo, they were non-inferior to sitagliptin. One point to note here is the molecule against which every other DPP, new DPP4 inhibitor compares itself is sitagliptin, which tells you a little bit about sitagliptin, why it was first launched. It's been there for a longer period of time. It's got a maximum amount of data. That's why everybody wants to compare it with sitagliptin rather than vildagliptin, linagliptin, or any other gliptin. Then comes durability. You have observational data with sitagliptin. If this is elderly people, if you see the yellow bar in elderly people where they were given sitagliptin, you have 4-year data. I mean, see, sitagliptin is being used for more than, came in 2006, 2007 in India. We have 13, 14 years of data. But it's very hard to generate a non-stop data over 5, 7, 8, 10 years to get this kind of data. So this was, if the reference is down there below. This is the retrospective data, which tells you that when they gave sitagliptin 7.1, very nicely maintained over 48 months. That is about 4 years. And if you take sitagliptin plus metformin, they have a 5-year durability data as well. But again, this is, if you can see, this is retrospective data, observational data. When you were hearing a lot of COVID data, everything is observational, ladies and gentlemen. So we will have that in this discussion session. This is the one which is a randomized controlled trial. This is the verified trial. The verified trial used metformin and vildagliptin. I don't want to take you through much detail, but if you see people who are on early combination therapy, and mind you, I'm a very, very staunch fan of early combination therapy, the failure rate was less when you used the DPP4 and a metformin, and the time taken to failure was about 5 years. So you get good durability when you're using a metformin vildagliptin combination. This is a randomized controlled trial. And if you take our observational data, metformin plus sitagliptin also gives you a 5-year durability data, but that is observational data. Then comes experience. When you want to buy a car, you ask people, yeah, which company's car does the best, etc., etc. Which phone? When you buy phone, you ask, which phone should I buy? Similarly, experience. So if you see, sitagliptin was launched the first and evogliptin the last. So you have a lot of data with sitagliptin, but having said that, there is enough data with vilda and lina as well. Then you look for safety. Which of them is the safest of all? And if you take DPP4 inhibitors as a group, overall, if you see this slightly older data, there are better meta-analysis which have come now. This is 2016 data. Risk of heart failure is definitely higher if you're using DPP4, and risk of acute pancreatitis, no matter how hard or how much you cry, pancreatitis remains a risk with DPP-4 inhibitors. So be careful. It's very rare. I'm not saying be worried about it, but it's still there. So if you take the DPP-4 risk inhibitor, the risk of hospital and heart failure, you've seen these slides 50 times. But this is putting the Carolina trial as well here, if you see. So with saber-timi, saxagliptin, fortunately, unfortunately, due to the drug, not due to the drug, raised pro-BNP, elderly, CKD, you can put on so many papers have come out of it. But no matter whatever you do, there was an increased incidence, 27% increased incidence, which is statistically significant for HHF. Allogliptin, unfortunately, got dragged along with saxagliptin. There was 19% increased risk reduction. But if you see the confidence interval doesn't cross the line of unity, but the point estimate is to the right side. SITA and LINA, two very nice randomized controlled trials, the cardiovascular outcome trials, the TCOS and the Carmelina, clearly showed that they benefit, and this led to a lot of discussion as to whether this label of HHF should be taken off for all DPP-4 inhibitors. Vildagliptin doesn't have a randomized controlled trial for cardiovascular outcome trial. They did the VIVID trial. And I must say this is a brave trial. The VIVID trial, if you see, this was the first, in fact, trial done so early on, not a huge number of patients, 254 patients. Look at the ejection fraction. It was 30%. So Vilda should be congratulated that they foraged into this area of people with established reduced ejection fraction. And there they studied Vildagliptin. And what they found was, since the numbers are so small, it's very hard to believe on these p-values because, as we all know, in cardiovascular outcome trials, you need large number of events. But if you see, the cardiovascular death was numerically more. But what was important was there was increased EDF, end diastolic volume, and end systolic volume, which might suggest that there might have been increased risk of hospitalization due to heart failure. Again, if you see, that's numerically more, but statistically not significant because the numbers are small. And Vildagliptin, sorry, I went too fast. Vildagliptin also has an issue with the liver dysfunction. We know that quite a large chunk of people with diabetes now have non-alcoholic fatty liver disease. No, I'm not saying fatty liver, I'm saying NAFLD, where the ALT AST is raised. And this is one area where Vildagliptin has an issue because if ALT AST is raised more than 3 times Vildagliptin, you can't use it. And this is important to note that once it has gone up more than 3 times, you should not be reinstating Vildagliptin. What about drug interactions? SITA and Vilda are quite safe. Whereas if you take Saxa and Lina, Saxa has got more baggage with drug interaction. With linagliptin is mostly with the CYP3A4 inducer, especially like rifampicin. So somebody is on tuberculosis and you want to use oral antidiabetic agents, then Lina is written there clearly that should not be using linagliptin. Renal impairment and effects, there's nothing to comment. Only thing about linagliptin, you don't need to change the dose, whereas with the others, you need to change the dose. I've not gone into the Carmelina trial in detail here. Both saxagliptin and sitagliptin had post hoc analysis of effect of Saxa or Sita in their large cardiovascular outcome trials on proteinuria, and there was reduction in albumin in both the trials, but that was post hoc ad hoc analysis. Whereas in the Carmelina trial, that was a randomized controlled trial where they had renal outcome, they did not have major effect on the reduction in EGFR or renal death, but they had reduction in the proteinuria part with linagliptin. Hepatic impairment, you have nothing to choose between the various DPP inhibitors, except if you see vildagliptin should not be used. Teneligliptin, hepatic dysfunction is used in clinically significant reactions, and gemagliptin there's no point discussing now because we don't have it available. Last and not the least is CV safety. CV safety, I won't bore you. You must have heard this 500 times before. You only have Saxa, Allo, Sita, and Lina, which have data, and those were the trials. Saber-Timi, Examine, TCOS, and Carmelina. Carolina was not a comparison with the placebo, but with sulfonylurea. And we found that all of them were safe as far as cardiovascular outcome trial goes. With regards to vildagliptin, you don't have cardiovascular outcome trial data, but you have data from a lot of meta-analysis. Again, these are, some of them are randomized controlled trials, some of them are observational data. They try to tell you that there's no increased risk of heart failure by using vildagliptin. Teneligliptin, you don't have any data, fortunately or unfortunately. I don't know when this trial will be reported top level. And if you see there are only 936 patients, so you can realize in 936 patients in 2 years, you're not going to get any significant cardiovascular outcome data. And if you see, it's an echocardiographic data, E by E ratio. All the secondary endpoints which you're interested in are secondary endpoints, and this is not statistically powered to answer those questions. DPP-4, sorry, teneligliptin and QT interval, I'm not going to spend much time. We have heard this 50 times. If you want to have discussion during question answer, I'll tell you. Only this slide to show you that we use a lot of drugs during our day-to-day management of patients with type 2 diabetes, which can prolong QT interval. Amisulpiride, it's there in all the all the people who go with dyspepsia, gas, to our gastroenterology colleagues, that a combination drug where amisulpiride is there. Escitalopram is given like a vitamin to type 2 diabetic patients. Most of them are on an escitalopram, not most, right? A large chunk of them are on escitalopram. And if you're giving escitalopram, venlafaxine, I mean, this is so commonly prescribed. Amitriptyline, so commonly prescribed. So be careful when you're using a drug which can prolong QT, because patients are getting all these other drugs which can prolong QT. So which gliptin to choose, ladies and gentlemen? After all this talk, I'm sure you're like the gentleman who's lying flat on the supermarket floor. Sita, Vilda, Lina, Saxa, Tenali, Gemi, Aloe, and Evogliptin. So there are certain things which are common with all of them. These are the commonalities. They're all potent. They all reduce HbA1c by 0.8 to 0.9%. If you start with an HbA1c of 10, 11%, they can even bring it down by 1.5 to 2%. They address the core defects, the incretin defect, partner well with all of the drugs. You heard of basic metformin, DPP4, you have SGLT2, DPP4 combination, can be administered any time of the day, meal independent, no excess hyperglycemia, no weight gain, safely administered renal impairment, and overall they have atherosclerotic cardiovascular safety, except that HHF is a little bit more with Saxa and Aloe. But then these are the various differences there. They're chemically different, selectivity profile is different, I've shown you that. DPP4 inhibition over more than 90% of 24 hours. I did not discuss this, but Lina and sitagliptin does that very well if given once daily. Vilda needs to be given twice daily to do that. Metabolism, only Lina is slightly different. Hepatic impairment, Vilda is out. Concern for heart failure, Saxa and possibly Aloe is out. Drug interactions, saxagliptin again, unfortunately.
Sir, you have 2 minutes left.
Yeah, these are my last 2 slides. And there are differences in use, differences in documentation, evidence, access, and price. So, which gliptin to choose? Depends. If you want cost, I think go to the WHO and the ADA ESD guideline, which says use sulfonylurea, metformin, 5-glutathione, basal insulin. If you want quality, then we have discussed at great length. Quality, if you take all those things, I think two stand out, which is sitagliptin and linagliptin. If you want to take selectivity, sitagliptin slightly better than linagliptin with regards to selectivity. Durability, I'm surprised that Lina has not come up with the long-term durability data with linagliptin. Sita has got the observational data, and now vildagliptin has got its trial. CV safety, again, Sita, Lina do well. Renal benefits, Sita also does well. Lina in a randomized controlled trial does well. So in summary, ladies and gentlemen, please use DPP4 inhibitors. Why did DPP4 inhibitors do so well? Because they are very safe, can be given anytime, and they have a modest, they're not very strong anti-diabetic agents, but they're modest anti-diabetic agents, but they can be combined with everything. If you want to choose, you have 7 of them now. I think Jemmy is out. Out of the 7, I've taken you through the various things that you would like to choose. It's like choosing a computer on iPhone or sulfonylurea or DPP or a statin. You take your pick, you decide. I've given you all the information here. Some in favor of Sita, some in favor of Lina. The others have issues with regards to various aspects as we discussed. With that, I will stop. I'm sure there are plenty of questions. Happy to take them. Thank you.
Thank you, JJ. It was a very nice presentation, very crisp one. And like a bullet train, you went through all your slides. It was wonderful. We'll have some questions now. There are people who have asked questions. The first question goes to Dr. A.K. Singh. It says that metformin in Parkinson's disease, and Dr. A.K. Singh, metformin should be stopped in patients with severe sepsis or overwhelming infection. Is it true? Can they continue metformin in patients with sepsis and a massive infection?
Yeah, so that's a common, question. Although the common sense suggests that metformin should not be preferably used in sepsis, but interestingly, the data is just opposite. There are at least 3 meta-analyses done with metformin in patients with sepsis, where metformin shown a significant reduction in death in patients with a variety of sepsis. So, although you should be careful with regards to lactic acidosis, all these are theoretical. I don't know anyone from India, even someone who has experience of practicing in the last 50 years, has ever associated or documented or published a single case of lactic acidosis from India. It's not in my knowledge. So on paper, there is, always a question of lactic acidosis in a background of sepsis. But when it comes to protect your life and longevity the metformin is in fact significantly associated with reduction in death, even in a patient with sepsis. So in one hand, you have to be careful, closely monitor, but this drug should not be stopped. This is what is the evidence is all about.
So,
Thank you. Yeah.
Can I come in there and ask? So,
Yeah.
AK, that's been pretty interesting. So, are you suggesting that patients in a critical care setting, we should continue or start metformin if they're not on it?
It's not a question of starting, because you are not controlling blood glucose with metformin in a critical setup. If someone is on metformin, unless it has got a contraindication of eGFR less than 30, you should continue with the metformin, regardless of what kind of sepsis is there.
So, that's where the interesting thing coming in, and I would want opinion from others also. The entire association of metformin and COVID in the meta-analysis, the couple of studies that one has looked at, and they've seen, these are retrospective studies for patients hospitalized for COVID, diabetic patients, and then they've looked at their presence of usage of metformin or no metformin. Now, one of the aspects is, all of us do use metformin in our patients. Where do we not use metformin? It's only in those patients who would have contraindications because of low GFR or very poor ejection fraction, some of those minimal contraindications today. Otherwise, most of the patients are predominantly going to be on metformin. So how do you get that kind of cohort which is not on metformin in these retrospective? Are they biased in terms of only those patients where metformin could not be used, or obviously the ones which are more serious or having complications and hence having poor outcome of COVID?
Yeah, so things have changed a lot, even with regards to the metformin. If you remember, prior to the SGLT2 trial, metformin was the first line drug for the treatment of heart failure in patients with diabetes. Or in other words, the anti-diabetic drug of choice in patients with heart failure with diabetes was metformin. Remember, when we were medical students, metformin were contraindicated in patients with heart failure. But over the time, people realized that metformin does wonder even in patients with heart failure. So before SGLT2 CV outcome trial, that is still right now, if you see the ADA ESD algorithm, metformin is there in patients with heart failure.
Exactly.
SGLT2 is the second line. So even if you look into the current heart failure data, metformin was, actually never been thrown in patients with heart failure. So that point is there. As I said, right now, over the time, in past 50 years, what we have learned is only contraindication of metformin is right now. You should not start in someone with eGFR less than 30, or if someone is already on metformin, if the even eGFR has went down to less than 30 but more than 15, you can use metformin up to 500 milligrams. The only contraindication, to stop metformin is eGFR less than 15. So that's the wonder nature of metformin.
Can I comment here?
Yes.
Avdesh, I think given the evidence we have with metformin in infection and sepsis, it's not hard evidence yet. See, it's very hard to believe that there's a 4-fold decrease in mortality only in women, not in men. This is all observational data. And mind you, these were not severely ill patients. These were people with mild to moderate COVID who went into ICU where metformin was stopped probably. So to say so firmly, use metformin in people with sepsis, I think we should wait for more data, because I accept that the evidence for lactic acidosis is not so strong. We haven't seen so many lactic acidosis so far. But in ICU or severe sepsis, I would be hesitant. I would be happy to continue it in, say, somebody getting, having COVID and mild COVID who is at home quarantine. He can continue with any OHA he wants or any kind of injury he wants. But if he comes into the hospital or is from moderate to severe range.
I got your point. So let me answer your question. So that's what everyone's common sense suggested. And as I've shown you during my presentation, all the guidelines and expert opinion did suggest to stop metformin. But then we are coming wrong, because these data suggested these patients were not stopped with metformin, even in mild to moderate to severe cases. And let's not, mix the women data to the 4-fold decrease reduction in death is a different data. As of now, we have got at least 4 studies. All are going in a positive direction. So that's the key. So in one hand, we have got a suggestion that metformin should not be preferably used in.
Sir, we have 2 minutes left to move on.
And and everyone wondered and advised to stop metformin, but the data suggests something else. Data did suggest. See, I agree with you. These are retrospective data, and believing 4-fold decrease in death is unbelievable. but this is what is all data is all about. But then at this point of time, this suggests that metformin at least is not doing anything wrong, which we perhaps thought about to stop the drug.
Maybe, but
If it
AK,
is
with
doing-
any of us
Yes,
continue it, even here on the panel, how many of us would be comfortable in continuing it on critical patients, irrespective of what the data is showing currently?
When the patient gets into ICU,
Most of us would not be comfortable.
They stop oral drugs. Except in the ward, you can continue metformin. The moment the patient steps into ICU, most of the OHs are out, except the data only on sitagliptin. But almost all OHs cannot be given in a sick ICU patient, where the food intake is a question, patient has nausea, vomiting, and critically ill patient, I guess the oral drugs, the question of absorption also.
No, I think we have a nephrologist here. Probably we could take Dr. Bharat Shah's opinion also, So.
Yeah, Dr. Saurabh, Manoj. Yeah, Manoj, can I ask you one question?
Sure.
Yeah. See, this SGLT2 use has now the expansion. It's been expanded to people with even the A1Cs are normal. You use it in cardiovascular disease. You use it in people with diabetic kidney disease, diabetes. So different segments. So do you think all these people and most of these people who are having this sort of comorbidities are elderly? So in a COVID-19 situation, even if it is mild illness, what do you think of continuing SGLT2 inhibitors based on indication for which it was started? Heart failure, DKD, ASCVD prevention, glycemic control.
Right. I think if this patient is mildly symptomatic or asymptomatic, a lot of these patients at current times are being managed at home, even with being COVID positive. As long as their hydration is not an issue, they are able to monitor their sugars, their oxygen levels at home, and they are in home quarantine and keeping in touch with the healthcare practitioner, I would be comfortable in continuing SGLT2 inhibitors also in them. But the moment the patient is getting a little worse, more symptomatic, requires hospitalization, I would want to stop SGLT2 inhibitors and probably most of the other orals, depending on the severity of the illness.
So irrespective of indication, that's what I was trying to ask.
Thank you, sir.
Heart
We are
failure.
moving to the next section now.
So thank you very much. Thank you, Dr. JyothyDev, for this opportunity. Thank you, everybody, all the panelists. It was a wonderful discussion. Thank you.
Thank you.
Thank you.
Moving on to the next session. For the next session, I would like to invite the chair, Dr. Praveen R., Associate Director, Medical Affairs, BICON.
Hi. I hope I'm audible.
Yes, sir. Yes, sir. Continue.
Sure. Thank you very much. I thank Dr. JyothyDev and Dr. Gopika and the team for this wonderful academic feast. Last 2 days was quite interesting and a lot of thought-provoking discussion was been happening. Considering the current pandemic situations, the digital intervention disseminating unbiased science is quite interesting, and I appreciate the Jpef team for this. And yes, this topic, if you practice it, it will really change the huge cost reduction and can significantly improve the GDP of a nation, and also helps the patient to access affordable insulin. And ultimately, as a physician, we would try to see how the patient is reaching this kind of goal. Without much further ado, I would like to call the expert, Dr. Thomas Blevin, to speak on this topic. Dr. Thomas Blevin from USA. He did his MD from Bayer College of Medicine, Texas. He worked in endocrinology section at Austin Diagnostic Clinic from '86 to 2001. He's been in the private practice at Texas Diabetes and Endocrinology Metabolism since 2001 onwards. And he is a certified American Board of Internal Medicine and American Board of Internal Medicine subspecialty in endocrinology and metabolism and American Board of Lipidology. He granted being Fellow of American Association of Clinical Endocrinology and National Lipid Association. And he has been accredited with endocrine certification in neck ultrasound, and presented various papers in Cardio-Metabolic Congress in 2012. And he has been presenting papers in ADA since 2008 onwards. And he has presented the symposium at National American Association of College of Endocrinology meeting at Austin, Texas in 2017. Dr. Blevins, I would request you to take it over from here, and we love to hear your talk. Thank you very much.
Thank you very much, and thanks everyone for allowing me to speak to you. Thanks to Jpef for for allowing me to speak. And I will get my screen shared here in just a second. And Dr. Praveen, thank you for that very nice introduction. And I do want to, yeah, I'm sitting in my office here in Austin, Texas. Amazing the way this works now. And I'm impressed that you're all there in the evening time listening in on diabetes education. I'm very impressed. And I do want to point out that this talk is intended for HCP or delegates in India, and it's not for US HCPs. Dr. Praveen wanted me to point that out. And the guidelines and things may vary in different parts of the world, in different countries. So let's move right along. And Dr. Praveen, can you hear me adequately?
Yes, Dr. Blevins.
Okay,
please
perfect.
We could see the slide.
Thank you. Okay. Well, so the question is it safe to switch from reference biosimilar insulin? And then what is the evidence? And I do want to point out, and you know this already, that diabetes, of course, is increasing all over the world, and it's going to increase further. If you look at the rate of increase, Africa has the numbers in terms of percent. This is 2019 to 30 to 2045. But if you look at the absolute numbers, Southeast Asia and West Africa have the numbers. That's incredible numbers of people who are going to have diabetes and who have diabetes already. You already know that. And that just sets a backdrop. We know that insulin has been around for some time, and it's a very, very, very important tool that we use, and it's saved many lives over time. And I am going to move fairly quickly because we have a lot to cover in a short period. And of course, numerous studies show that insulin lowers A1C very effectively. Many other medicines do too. And if you look at different kind of aspects of this, disability adjusted life years averted by insulin usage and lowering the A1C to certain targets like under 7 or various targets. Certainly, we're going to avert a number of disability adjusted life years with treating people effectively. That's very clear. You know, the treatment over time in various countries and this treat to target sort of approach, gradual treatment, has its advantages, but we tend to treat people, titrate one medicine, and the A1C goes up, then we titrate the next. And you can see that over time, this approach to stepwise treatment and gradual treatment can lead to really treatment failure. And some people say this is a treat to fail type approach. And the argument then would be made to move on to more potent treatments right off the bat, early on, including insulin. And then the argument here to the right of the screen, kind of the same idea blown up. Every time the person has an A1C that's elevated, they certainly may sustain some tissue damage, metabolic memory, and this is a problem. And the ideal would be to treat the person more effectively. We all know that. Another issue so lots of people need insulin, big deal, it works, we know that. 33 million people have type 2 and don't have access to insulin. Well, that's a big problem. And by the year 2030, that number is going to go up, bottom line. And Dr. Sanjay Basu, in a very nice analysis in the Lancet Diabetes and Endocrinology in 2019, pointed out that current levels of insulin are not adequate for the projected need, particularly in Asia and South Asia. We know also that the price of insulin has gone up, and you can see the color that's insulin there. You know this. This is data through 2013. You know it's gone up since then. And so insulin cost has tripled between 2002 and 2013. It's going up even further. World Health Organization says that people with diabetes who depend on this life-saving treatment may really pay the price when access is lacking. Now, we could talk about access. Access is not just availability, it's cost, it's ability to pay and all that. And so what about biosimilar insulin? Does it have an advantage? And I think we all know it does. And I could just stop right now and say, yes, it does. And I can tell you that the insulin glargine that we're going to talk about is virtually identical to the glargine that we've used in the past, and that it's less expensive. We could stop at that, but we'll go into more detail. We do know that biosimilars have been used a great deal now, and cost savings are enormous in the U.S. That I know well, 40 to 250 billion over the next many years. And one of the first biosimilars was the Neupogen with the Zarcio filgrastim is what it is, and it was launched at a relatively modest discount of 15% and still save billions of dollars. And so biosimilars are expensive, biologics are expensive. really what I meant to say is biologics are expensive, biosimilars are less expensive. And so accessibility by lowering the costs can be very useful to us. The healthcare system can benefit from biosimilars, we all know that. They have to be proven to be safe and effective, but they typically are more affordable, and that's going to, we hope, increase access. And you know, this is just telling you what you kind of know. If you look at the various biosimilars over to the right-hand side of the screen and look at the projected cost, this is actually an analysis from 2015. If you look at the projected savings, depending on the discount, 40% reduction here, 30, 20, certainly this is billions of euro. So certainly billions of dollars can be saved in the healthcare system, which is important overall, but also the accessibility is improved. The guidelines have embraced biosimilars, and we're going to talk about insulin, of course, and I won't go through this in great detail, but this is from the working parties group's consensus guideline from the UK, and they say that, well, and this is very recent. They say new to insulin. If a patient is new to insulin with diabetes, you might use a biosimilar right off the bat. If they're optimized on their existing insulin, then consider switching, and it might reduce the dose a little bit just to be careful. And then the advanced level 2 would be if a person's not optimized on their existing insulin, concerns about hyperglycemia, consider switching and monitor. If there are concerns about hypoglycemia and the person's on existing insulin and you want to move to biosimilar, then consider about a 20% dose reduction, and on and on. The real bottom line here is the biosimilars have been embraced by the system. And if you look at the information from the Association of British Clinical Diabetologists, ABCD, interestingly, you find that the biosimilars might be considered as first treatment option in people who are insulin naive, and it's all about cost. And they also support that they might be used in people with type 1 who have not been exposed to long-acting, like newly diagnosed, or people with type 1 who need improved control. So biosimilars have been embraced by various groups around the globe, including here in the US. So choosing the right biosimilar is important. And with that as a backdrop, let's talk then about the phase 3 studies with the Biocon insulin glargine. I was fortunate to be able to participate and help publish these guidelines, these studies. And there's the INSTRIDE 1 study, 2, and 3. I'll tell you a little bit about all 3 of these, and we're going to talk in more detail. The INSTRIDE 1 was in type 1 diabetes, so if it has a 1, it's type 1, 2, type 2, and large numbers of patients. These are essentially sort of what I'd call abbreviated phase 3 studies, and the outcomes in the study were comparing reference glargine to the Biocon glargine at 24 and 52 weeks, hemoglobin A1C. Fasting glucoses were also looked at along the way. I'm going to show you the data. In the INSTRIDE 2 study, also this is in type 2 patients, and the numbers are substantial. And this was done. These are studies done around the world, and the U.S. also. And the hemoglobin A1C outcome, the primary outcome measure was hemoglobin A1C. These are non-inferiority studies. I'll go into that in more detail in a minute. And we also looked at the actual glargine dose over time. And then the INSTRIDE 3 study was a switch study. And this was a study to look at interchangeability, which is really interesting, I think. And essentially, so it's kind of a summary, and we'll go into more detail. We're looking at type 1 patients, we're looking at type 2 patients, we're looking at dosing, and I can tell you right now the dosing between the two, comparing the reference glargine, which was Lantus, to the Biocon's glargine, the dosing was virtually identical, and we found that the switching could be done very safely, and so that's kind of a backdrop. I am going to work on getting a little box out of the way. There it is. Okay. So the INSTRIDE 1 study. Let me tell you more detail. This is the type 1 study, and it was open label. Both of these insulins were given by pen. The pens look different. It was open label. It was multi-center around the world, comparing the efficacy and safety, both biosimilar insulin glargine, Biocon, with Lantus in type 1 patients. And this was essentially a non-inferiority study. And if there was a difference of less than 0.4 in the A1C at the end of the study, the insulin was considered non-inferior. And you'll see the results in a minute. And there were some other outcomes that were looked at, like fasting glucose and things like that. As I mentioned earlier, this is a large study, about 560 people. And the people had to get in the study, had to be on once daily insulin glargine. And they had to have an A1C under 9.5 too. Well, so the study is designed this way. And the reason for the 1-year duration was the FDA wanted to look at immunogenicity studies information, and they wanted long-term data, not just 6 months for the people with type 1 diabetes. So the people are gone through the run-in, some adjustments were made to their insulin, then they're randomized to either biosimilar insulin glargine, the Biochem product, plus Lispro, or Lantus plus Lispro. Now, there were adjustments made in the insulin throughout the study, but there was an attempt to keep the doses stable. And that was up to the investigator. So this is a 1-year study. And I'm going to tell you that some of the people after this study was complete enrolled in the study we're going to talk about in a minute. That's the switch study. So here are the efficacy results. This is really easy to present because you can barely see a difference between the two insulins. You can see the colors, the biosimilar and the Lantus. And you're seeing what you really do want to see when you look at a biosimilar insulin. You see that the A1C is the same in both groups. And these are, again, treated in parallel, and it is open label. So when you analyze the result, the upper bound of the 95% confidence interval mean difference between the groups was 0.117. Now that's very low. It's certainly less than the non-inferiority margin of 0.4. You can say then that the Biocon insulin glargine is non-inferior. And that's really the bottom line. Now that's the A1C data. And now here's the fasting glucose data. And you know, I ask everyone to see if you can see a difference here over the time period of the study. This is just another, this is the fasting plasma glucose change at week 24 and week 52. And you can kind of look here and see these are the same. And there was no difference between the two at weeks 12, 36, and 52. You just can't see a difference at all. The incidence and types of adverse events and serious adverse events reported were similar between the two insulins. No meaningful differences between the treatment groups and the incidence of overall hypoglycemia. And this is really important too, of course, when you look at comparing two insulins, nocturnal hypoglycemia, systemic reactions or local reactions. And so the conclusion is very clear. Biocon's insulin glargine is clinically equivalent to reference insulin glargine, which is Lantus in people with type 1 diabetes. And so that result was very clean. And you'll see a similar sort of outcome here in the type 2 study, I'll tell you now. This is the InStride type 2 study, and this is a large group of people. Once again, it's an open label study, again, multi-center around the world, looking at efficacy and safety of biosimilar insulin glargine compared to reference insulin glargine, which again is Lantus in type 2. And this is, again, a non-inferiority study, and we're going to look at outcomes such as A1C, and we'll talk about those in a minute. And these are people who are either insulin naive, and about 40% were insulin naive, or people who had been on a stable dose of glargine prior to the study. And so that's the study, the organization of the study. It's going to be very similar to what we looked at before. But this is a type 2 study, and so a shorter duration is considered acceptable here. So these people are randomized, and they're put on the biosimilar insulin glargine Biocon, or they're placed on the Lantus. And if this is a typical sort of start the insulin, the people who are insulin naive, 10 units or 0.2 units per kilogram, and they were titrated, or adjustments were made in the people who are already on Lantus. And so here are the results. This is really easy too. I mean, you can't see a difference. This is the actual A1C. They started a little over 8, and they came down a bit during the study. This is week 24 data, and you can see there's just no difference. And if you look at the actual numbers, the difference between groups was 0.06%. Of course, that's not significant. That's certainly, this is again a non-inferiority trial, and if they're within 0.4, it's considered non-inferior. So you could certainly say that biosimilar insulin glargine Biocon is not inferior, but really this is nearly, it's not quite identical, but it's nearly identical. If you look at another question I know you have is the insulin dose. And if you look at the actual insulin glargine dose, this is units per kilogram over time in the two groups. You also see that there's really no difference there throughout the 24 weeks between the two types of insulin. And you can look at all patients in terms of the increase in daily glargine dose units per kilo, 0.124, 0.122. No difference there at all. And what about the people who are insulin naive? Is there any difference there? And the answer is 0.236, 0.240, and units per kilo, not significant at all. Safety results, again, the frequency and nature of the treatment emergent adverse events and the serious adverse events between the two is the same, similar. And hypoglycemia profiles, again, very important, not only efficacy, but safety in between the groups. When you look at any time or nocturnal hypoglycemia, very, very similar here too. So you could say that the Biocon's insulin glargine is equivalent to reference insulin glargine in people with type 2 diabetes. Now, there were immunogenicity studies, and these are required when it comes to establishing safety. So efficacy, safety, very important. And really, you know, we could spend a lot of time on this, but we don't have that time. And if you look at changes in cross-reactive anti-drug antibodies in the INSTRIDE 1 and in the INSTRIDE 2 trials, here's what you see. Change in cross-reactive insulin antibody over the time period of the trial in type 1. You just don't see any difference here. And the references in that, I'm not good at colors, I think that's red, and then blue is the Biocon. And then if you look in the type 2 study, certainly you see similar information. There's just no difference here. This isn't a big deal. I mean, these are identical hormones, insulins, but there's still the FDA and every group anywhere in the world wants to know about immunogenicity. And then if you look at the antibody response, this is cross-reactive insulin antibody response. There are a bunch of different ways to look at that insulin antibodies, and there are many different assays. And so you look in the type 1 group, the presence of antibodies is relatively elevated to begin with because they've been on insulin for a while, typically. And what you're looking at, though, is the comparison between the two insulins, and also over time, you see there's no difference. And then in INSTRIDE 2, these are people with type 2, new to insulin. Not for the most, actually 40% were insulin naive and 60% were not. So many of them have been exposed. You just don't see a difference here between the two insulins. So the people who met the criteria for cross-reactive antibody, that is anti-drug antibody response, positive response, their total anti-drug antibody response, similar between the two groups. So finally, and in the last minute or so, let me tell you about the INSTRIDE 3 study. This is a really interesting study. These are people with type 1 who actually finished that INSTRIDE 1 study. And we're now going to look at them and do a switch study. And, you know, the way the switch studies have been designed has evolved over time. And you know, they may be done differently today than they were done a few years ago. This was an open label, randomized, multi-center parallel group trial comparing efficacy of insulin glargine Biocon to reference insulin glargine, Lantus, in type 1. And this was to look at switching, and I'll show you the design in a minute. You'll understand it better than all the words. And so let's take a look. We're going to take a look at whether A1Cs change when people are switched, and this gets to the question of interchangeability, which I think is increasingly important in the U.S. and around the world. Here's the study design. You take these people who are type 1. They finish the INSTRIDE.
Excuse me, sir. You have 2 minutes left.
Thank you.
Yeah.
And they finished the INSTRIDE 1 study, and they were on reference glargine. So only the people that were on glargine reference, the Lantus, in the INSTRIDE 1 could get into this study. So what's done is one group, and this is a smaller group, 127. One group, about 63, left on glargine plus Lispro, of course, throughout the time period of this study. The other group is going to be placed on biosimilar for 12 weeks, reference for 12 weeks, and biosimilar for 12 weeks. And we're going to take a look at a few outcome measures, and we'll jump right to the results. If you look at hemoglobin A1C change, now look at the scale. We're looking at a scale that goes, this is 0, negative 0.1. These are tiny, tiny, tiny changes. But if you look at, and the outcome here was change in A1C over the time period of the study. If you look at this is the color is the biosimilar. If you look at the people in the biosimilar group, there's a little change here, but it's tiny. And then the group in the reference here, at the end of the day, both arms had similar change in A1C over the time period. And the difference was 0.01, and that's A1C change. So that's really, and you can see the least squares mean difference here at the bottom if you want to look at that. And other data that was looked at was fasting glucose over time, and you can see that they're very similar over the time. Here's the period 1, period 2, period 3, and you can see the groups, and then also actual SMBG here over time. These people were asked to do multi-time SMBG testing, multi-point SMBG testing periodically during each period. And you can see there's really no difference here. So in both treatment groups, yeah, the visual tells you what you need to know, I think, and I won't spend much more time on that. But in the treatment groups, the FPG and SMBG remain stable throughout the 3 time periods, and there really was no change. And I can also tell you antibody responses didn't change either. So the incidence of adverse events and serious adverse events were similar between the 2 groups. So you could conclude that Biocon's insulin glargine is clinically equivalent to reference insulin glargine. Again, the dosing was nearly identical, and patients can be switched back and forth with no adverse events. So is using biosimilar insulin safe and effective? The answer is I think it is. And thank you very much for your attention. And at this point, we'll open for questions.
Thanks, Dr. Thomas. It's been a very wonderful discussion, or wonderful points that you put across. Few questions are coming in, so I can considering the time, I can ask you a few questions, not everything. One is that in India, we don't have any interchangeability guidelines. We switch as per the patient convenience, that is cost or easiness. What's your opinion on this?
I think that's fine. Interchangeability would mean, of course, that the pharmacy could just change because they had a better price. But in fact, we don't have interchangeability for this insulin here in the U.S. at this point either. So I agree. I think that if the patient wants a better cost, if this insulin is more available, and if it's more ideal for the patient, I think we have the data to back up making a change. If you want to be conservative, you could look at the UK Working Party's suggestions about maybe reducing the dose a little bit and that. But, if you look at the data, you don't really need to. A one-to-one exchange is, I think, as a clinician, I'm not establishing guidelines, of course, I think is a reasonable thing. And you look at that data, and I think that backs up what you're doing.
Thank you very much for putting that answer for that. The last question I would like to put across is that, is it a must, or should we check the ADA, that is anti-drug antibodies, while switching from biosimilar from reference insulin to a biosimilar insulin? Is that, how do you see it from the clinical practice, or do you recommend anything else like SMBG?
Yeah, I'm going to tell you, as a practicing endocrinologist, diabetologist, I almost never check anti-drug antibodies except in clinical research studies, and we do quite a few studies. And I think it's really something to be done in the research realm. Now, if I have a person who has a very, very, very unusual circumstance, like it looks like they might have sort of an antibody response, say they have the systemic allergic reaction or something like that, I might check them then. But the answer is no, and I would not. And it's not really predictive. They're going to be a little bit elevated in people with type 1 anyway. They're going to be a little bit elevated in people who have type 2, have been on insulin, and I don't follow them. They don't help me. If you look at the data here, you see there's no real change over that group of patients, that were a large group of patients who were looked at. So that even that data would argue against doing it. It doesn't tell you anything. And next is, you're making these switches to try to save people money. And I don't know what the cost of the anti-drug antibody
But
is.
how do you see the SMBG as? How do you see that SMBG? Do you ask your patients to capture the SMBG values during the course of time?
Oh yeah, I mean, certainly patients need to monitor their glucoses. I hope I'm answering your question.
Exactly.
Definitely I will tell them if I'm switching, I want you to check your blood sugar. It's a slightly different insulin, I guess. I mean, it's really the same molecule. I actually, what I really tell them, it's the same thing. But but I always have people checking their blood sugars as you do. And we use a lot of continuous glucose monitoring if we can. And I try to make conclusions based on that. But I think that is I agree completely. That is very important that people always monitor their glucose when changing insulins, when changing doses, all of that.
2 more minutes, we have to move to the next session.
Sure. So the last question, since considering a minute, and I would put last question and we'll wind up the session. Is there any dose change? I think so you're told, but still the question came up. Is there any dose change when you switch from reference insulin to a biosimilar insulin while switching? That is, I think so they're talking about the INSTIGHT-3 study precise.
Yeah. The answer is, as a clinician, I would say not. I would say no. If you look at the study, the switch study, there was there was a tiny difference in dose change at the end of that study. It was like 0.019 units per kilo, and that tells you how minimal it is. And so I suppose, and a lot of that had to do with the fact that there was a different kind of dose, basal insulin dose, slightly different between the two groups at the beginning of the study. So there was kind of an evening out toward the end. So I think if you have a person, if you go back to that working party recommendation, if you have a person who's really well controlled or who's having hypo, you might reduce the when you switch a little bit, but otherwise I would tend to go 1 for 1. I mean, the change in the switch study was so clinically not relevant. But I think being conservative, we're all conservative practitioners. I think it's reasonable if you're concerned to reduce the dose a little bit. Thank you very much for your.
Thanks, Dr. Thomas Blevins, for your time and wonderful information that you put across to us. And I also thank Dr. JYOTHYDEV and his team for this session. Thank you, sir. Over to you.
Thank you very much.
Everyone. Thank you for that. Moving on to the next session, I would like to invite Dr. Tony Joseph. He is the consultant endocrinologist at Sri Gokulam Medical College and GG Hospital, Thiruvananthapuram.
7:30. Hello, I'm audible, right?
Yes, sir. Continue.
Okay. Good evening, everyone. At the onset, I would like to thank JYOTHYDEV sir and the organizing committee for giving me this honor of chairing this session. So without wasting any time, we'll come to today's topic, which is on SGLT2 inhibitors and DPP4 inhibitors for powerful glycemic control. And we have an eminent speaker, Dr. Vijay Vishwanathan sir. Dr. Vijay Vishwanathan sir is the head and chief diabetologist at MB Hospital for Diabetes and Professor M. Vishwanathan Diabetes Research Center, Royapuram, Chennai, which is a collaborating center for research, education, and training in diabetes. He is the president-elect 2021 to 2023 of DFood International, based in Belgium. He is the national vice president, RSSDI. He has completed 29 years as a diabetologist. He has a PhD in diabetic nephropathy and has published around 50 research papers in this field. Sir has won the first Vivian Fonseca Award from the ADA for his work in diabetes and tuberculosis. And he has developed the specialty of diabetic foot care in India by training over 2,000 physicians and has set up a state-of-the-art podiatry center in Chennai since 25 years and has published over 150 original research papers in diabetic foot. He was awarded fellowship of the Royal College of Physicians, London, for his research and contributions in diabetes. His fields of interest include diabetes and foot and diabetes, diabetic kidney disease, diabetes in patients with tuberculosis, and socioeconomics of diabetes. So over to you, sir.
Thank you, Dr. Tony Joseph. And at the outset, I'd like to thank Dr. JYOTHYDEV for this wonderful meeting and also for inviting so many people and trying to get such a knowledge base for everybody. Just trying to search my slide here. So in the next 12 minutes, I'll take only about 12 minutes to talk about this new kid on the block. And that's the combination of an SGLT2 inhibitor and a DPP4 inhibitor. And this is an FDC, which is a fixed dose combination. Now, this combination, which I'm going to talk to you in the next 12 minutes, is a powerful one. It's effective and it's beneficial among all the oral drugs which we have been using. So powerful, effective, and beneficial. And I'll talk to you in the next 12 minutes trying to justify this, why I said it's powerful, beneficial, and effective. This is a very interesting slide which I always project. When we talk about prevention of diabetic complications, treatment of diabetes, we are interested only in one thing. We want to prevent complications. We don't want people to die of kidney failure or blindness or attack or a stroke. So this was a study which we did 10 years ago, which was a population-based study of cost of illness study, where we looked at the direct cost and indirect cost of people with diabetes. And we estimated the cost of diabetes care in India to be about 31.9 billion US dollars 10 years ago in 2010. Now, as I said, our primary objective is to prevent complications. So we looked at the complications of diabetes and how much does it cost and what is the impact of complications on people with diabetes. So for that, we took in the study people who had one complication, two complications, three or more complications, the various combinations, kidney and heart and so on. Now, this is a very important concept in this COVID era, and that is called the loss of man days per year or the loss of median income per year. It's very important, and this is applicable to the patient as well as the primary caregiver. And you can see that as the number of complications increase from 0 to 1 to 2 and 3 and above, you can see that the number of loss of man days per year increased 2 times, 3 times in people who were having multiple complications vis-a-vis just one complication or no complication. And so on. So the loss of median income per year also increased 28 times if you had 3 or more complications. Now, having told you about the cost and the effect of complications on people with diabetes in India, the study which I showed you was from India, was from Chennai. Now, how can we prevent complications? So the only way to prevent complications is to keep the HbA1c as close to 7%. Of course, use the latest markers of glycemic control like intraglycemic variability and so on. But the old data points to an HbA1c of 7. And I would like you to concentrate on these white columns in the microvascular complications, cardiovascular complications, and mortality, only the white columns. And you can see that after some 8 to 10 years, you can get real benefits. And the benefits of good control of diabetes was shown in the type 1 and type 2 cohort in the United States and United Kingdom respectively. Even after several years, the blue color shows you the immediate effect and the white columns show you the later on effect. And you can see that the kidney, heart, the eyes complications, the heart complications, and the death is substantially reduced if you keep your HbA1c close to 7% as possible. Therefore, prolonged hyperglycemia is occurring in most people in India and in other parts of the world also because of what is called delayed treatment intensification. We are not intensifying treatment. And you can see that if you have this prolonged hyperglycemia, and if you keep your A1C above 7, you can see it's not only MI, but stroke, heart failure, the composite cardiovascular endpoint, everything is increased if you don't keep your diabetes under control. And why we are not able to control diabetes that easily in India is because of many factors which we know: high carb diet, patients keep on taking multiple OADs and just don't have their control. And they don't come, the diabetes is not under control, they'll not see the diabetologist. Therefore, we have number of studies, both the Indian and the studies from abroad, which have shown that among the patients who are undergoing treatment, you can see that the HbA1c ranges anything between 8.5 to 9.3. So this is the average or the mean HbA1c of people who are undergoing treatment for diabetes, which we cannot allow. So where are we going wrong? Maybe we are not trying to address all the pathophysiological risk factors or factors concerned with diabetes control, which is so beautifully brought out by Ralph Alfonso. And this is where probably this last 8 minutes of my talk, where I'm going to concentrate on this combination of DAPA with SATSA. which will cover about 6 out of 8 pathophysiological mechanisms responsible for uncontrolled diabetes. And if you add metformin to that, you can get the effects on the liver and in the peripheral tissues also, skeletal muscles also. So going back to the previous slide, I think probably we are making a mistake of not addressing all these factors. And that is probably offset by using such agents like DPP-4 inhibitors or SGLT2 inhibitor combination, about which I'll talk to you. The other factor might be patients are not taking the medicine. So that could be, we are prescribing it, but how do you know? We don't go to their house and check. We don't call them every day and ask them, are you taking the tablets regularly? Therefore, if you have this loose dose combination, if you give multiple drugs, 1, 2, 3, 4, 5, patients simply think that their pill burden is more and they'll not take. Whereas if you have a fixed dose combination, if you have 2 drugs or 3 drugs for diabetes or 1 drug for diabetes, then their compliance might be better. As you can see in this study, very elegant study, which showed that if you have a fixed dose combination, your HbA1c control of 7% is better. Therefore, these are the 4 components about which I'll talk to you in the last 6 minutes. Are we going to control glycemic control properly, glycemic levels properly? Are we going to have a favorable effect on the weight? Are we going to also manage the comorbidities like hypertension, which coexist with diabetes? And are we going to avoid hypoglycemia, which is a very important point. Now, if you take this combination, as I said, it's a new kid on the block, the DPP-4 inhibitor and SGLT2 inhibitor combination, FDC, you can see that the hypoglycemia risk is lower. The weight reduction is not there, weight gain is not there, and in fact, you can get a weight reduction with this combination. CV safety is there, which I'll show you in a couple of slides later. And to some extent, there could be some reduction of blood pressure. We're not going to depend on this drug to reduce blood pressure. We're going to use ACE inhibitors and calcium blockers and so on. But from this combination also, you'll get some reduction in blood pressure. Now, hypoglycemia is maybe one factor which is avoiding patients to get to the diabetologist. So once we write a drug, the patient goes into hypoglycemia, he loses faith in the doctor and he doesn't go. So you can see that all the major studies like Advanced Accord and VADT, when they intensified treatment, when they tried to make the treatment more intensified to get the HbA1c down to 7, the hypoglycemic prevalence increased substantially compared to people who were on less intensive treatment. Now, as far as this combination DAPA-Saxa is concerned, it has been compared in this very elegant study which was published in the ADA in 2018 with glimepiride and metformin. We have been using glimepiride and metformin. It's a fantastic drug, but you can see that as far as hypoglycemia is concerned, the DAPA-Saxa metformin combination, which is shown in green, produces much lower hypoglycemia, which probably the patients want. And you can see that in terms of the hypoglycemic events, the events is 18.5% in the DAPA-Saxa metformination compared to glimepiride metformin combination, where it's higher. So it's quite expected because it's a secretagogue drug. Now, what about weight reduction? So you can get, again, glimepiride metformin is a wonderful drug. We've been using this combination FDC for a long time. But once again, if you see the DAPA-Saxa metformin combination, you can see that the weight reduction of nearly 4 kilos when you use this in this particular study, again presented in the ADA in 2018. Not only that, as I told you, you get a dual benefit. The blood pressure also comes down when you use a DAPA-Saxa metformin, which we all know why the blood pressure comes down. Now, there was one study, which was another paper presented in the ADA in 2018, which compared with insulin and metformin. And this study also said that this combination might be as good as insulin plus metformin. Well, this study showed compared people who are on insulin and metformin and DAPA-Saxa and metformin. And it is found that you can see that the change in HbA1c was not much better, but not inferior to patients who were on insulin. And also, you can see that the prevalence of hypoglycemia was much lower among the patients who took the DAPA and Saxa and metformin. And compared to patients who were taking insulin, the weight benefit of nearly 3.6 kgs, like the glimepiride, which I told you earlier, was also there. Therefore, if you take the overall, the side effects, you can see that this elegant study showed that by using this combination of DAPA and Saxa, you get lesser of these nasty side effects like vulvovaginitis and genital infection than what you could expect it if you use it, say, as a monotherapy, dapagliflozin. So maybe the benefits are better if you use a Saxa plus DAPA combination rather than using, say, the DAPA by itself. So this is a safety profile which is better if you use a combination. And also the adverse effects associated with volume depletion are also lower, 0.4 compared to 0.9 when you use this combination vis-a-vis only the DAPA. Now, DAPA also, we know that it's got favorable effects on the heart failure, and heart failure and CV death has also been shown by a number of studies, recent studies, and the government of India has also introduced this drug for heart failure management recently. So you can see that DAPA 10 milligram is definitely capable of reducing the heart failure risk in people who have heart failure and in people who do not have heart failure also. Now, saxagliptin, as far as the 3-point MACE is concerned, in the SAVOR-THIMI, there was no difference. You can see that the Saxa and placebo, the 3-point MACE was no different between Saxa and placebo. Now, what about the kidney? So I talked about complications in general, and I talked about kidney. Now, this was a very elegant study, which was also published in Lancet Diabetes Endocrinology last week. Now, where they took patients and randomized them to DAPA plus Saxa, and with placebo. And this was on top of the ACE inhibitor and ARB treatment. And they looked at albumin levels. They looked at patients who had an eGFR of between 25 and 75, and a persistent microalbuminuria between 30 and 3 grams of proteinuria. And you can see that patients who were taking the DAPA and saxagliptin compared to the placebo had much lower levels of albumin as time went by. And you can see that compared to the placebo, there was a substantial reduction in albumin excretion also. So you get benefits in the kidney as well. So if you go back to my earlier slide, does it offer good glycemic control? Is it powerful? Yes. Is it beneficial? Yes, because it has favorable effects on the weight and it has favorable effects on the hypertension, which I showed you. Is it safe? Yes, it's got a lesser hypoglycemic risk compared to sulfonylureas and with insulin. Therefore, I think to summarize, this slide is just to tell you the patient's perception of the number of pills which they take. It's called the pill burden. Now, if you put a person on one drug or two drugs like the DAPA-Saxa combination, they are much happier. You can see the green shading. Whereas if you put them on a basal bolus insulin therapy, multiple drugs, their pill burden and their liking is also less. So they are greatly overburdened. They are psychologically affected if you put them on multiple doses. So patients don't like it. And most of the people like taking oral drugs than injection. That's seen universally everywhere in the world. Therefore, to summarize my last two slides, there is a significant reduction, so it's powerful. There's weight loss and blood pressure benefits. There's a reduced pill burden, and there is also acceptable safety and tolerability. And with this combination, it seems to be a synergistic pair for CV renal and also for HbA1c reduction. It has been shown in that study which I showed you that it's as good as insulin, but there might be one subset of people who definitely need insulin because their beta cells are very weak, and it is beneficial for the kidney, and the safety is also well established. I'd like to thank JYOTHYDEV once again and congratulate him for his wonderful show. Thank you very much.
Thank you, sir, for the wonderful presentation. So, sir has nicely elaborated the fixed drug combination of dapagliflozin and saxagliptin. According to the DCCT and various trials, every 1% HbA1c reduction, it improves the microvascular complications by 30%. So, starting a patient on fixed drug combinations, it improves the patient compliance and it target the fixed drug combination of SGLT2 inhibitor and DPP4. They target various components of the ominous octet that Sir has said as per the Defonso study. And I would like to ask Sir a few questions. So, so if someone is having an atherosclerotic cardiovascular disease, will you first go for this fixed drug combination, or will you prefer metformin initially and then step up to SGLT2 inhibitor? And
So I'm still a big fan of metformin, and we would still start metformin to start with. And then if the glycemic control is not satisfactory, I'll definitely add this on, because in India, the cost factor is definitely there. So if the patient does very well with metformin, if his HbA1c is only 7.2, so I would just start him on metformin and see what happens. And control the cardiovascular risk factors with statins and with blood pressure control and all. Having said that, my definitely next choice would be the DAPA and Saxa if somebody is not getting control with metformin.
Sir, what is your experience with empagliflozin and linagliptin combination?
Yeah, so I don't think there is head-to-head trials to compare this versus that. So it's just that fixed drug combination concept which is important. So I think there's very little I can say about the difference. But today I have talked about good data which has come out from this combination of DAPA and SATSA. So I think this is a combination which has got a lot of robust data. So.
Yes, sir. Very good. So, sir, as per the SAVOR-TRIMI trial, saxagliptin is CV safe, but has reported to have a slightly higher risk of heart failure. So, have you experienced such events in your clinical practice?
So, not really. We have not seen anything. And just to add one point extra to what you said, I don't think this SAVOR study was powered enough to look at heart failure. It was an incidental finding, and subsequently many real-world studies did not show the relationship between heart failure and saxagliptin. Moreover, the NT-proBNP levels were normal in the same study. Therefore, we really don't know whether it was just a chance finding or what it was. I think around 289 out of 8,200 patients, the SAVOR-TIMI, which is about 3.5%, had hospitalization to heart failure, whereas it was 225 out of 8,000, 2.8% among people who were not taking this saxagliptin. Therefore, there is very, very close difference between the two, and I don't think it's powered enough. So it's too early, and here we are using a combination with a drug which actually favors heart failure. So I don't think there's anything to worry about it.
So up to what GFR will you start this combination of dapagliflozin and saxagliptin?
Yeah, so when we get patients who are newly registered to our hospital, we get different eGFRs. So about 80% of patients have a good eGFR, above 60. So I think we would start it above 60. Up to 45 will definitely start, but below 45 I will think twice, because simply not because it's dangerous, but because the follow-up is not there. So patients come to us after 2 years with an eGFR, it would have been 40, 45, and then they'll come to you with an eGFR of 5. And then, everybody will blame us for not following up. Our patients don't follow up very regularly. That's a problem.
Yes, sir. You rightly said that patient follow-up is an important thing. So coming to the next question, sir, about UTI, what is your experience with urinary tract infection, especially serious urinary tract infection like pyelonephritis?
I think we just have time for one question, so it's 7:55. So
sure.
I think it's a problem. You have to warn your patients, and in my experience, it's only about 2 out of 10.
So will you stop it permanently, or will you
No,
restart it?
I will just stop it, lower the drugs, and then lower the dose and see what happens. But if the second time he gets it, then he's completely off. So I think we have time up. So I think we need to ask the next speaker to take over.
Thank you, sir. Thank you, sir, for the wonderful talk.
Sir, actually, we have more time, sir. We have time till 8 o'clock for the discussion.
Okay. So I don't mind taking 1 or 2 questions more.
Yeah, you
no
can
problem.
take more questions, sir. If panelists want to ask more questions, they are welcome to ask. We have time till 8 o'clock. We have time, sir.
Dr. Tony, if there's any question in the chat box, you can ask me.
Sir, if you don't mind, I will ask one
Yeah,
question.
yeah.
Sir, we have seen that SGLT2 can produce UTI, but in some cases when SGLT2 is combined with DPP4, the UTI kind of reduces. I read about it like it reduces because of certain mechanisms. If you can explain more regarding
I
that.
showed the data just now. It was the genital infections which came down with this combination, not UTI. If you had seen my slide, the UTI was almost similar in patients on the combination versus vis-a-vis the patients who are on DAPA alone, UTI. But the genital symptoms, genital infections were lesser. I showed you that slide. I do not know the exact mechanism. Maybe there's some protective effect if you use it along with Saxa. I have not gone into the details of this, why the protective effect. So
I have read somewhere like the DPP4 kind of inhibits the bacteria. That's how this happens.
yeah,
The chances of infections are less.
maybe. I'm not very sure about it.
Thank you, sir. Any other questions from any panelist? I encourage other panelists to ask questions. Anybody can ask questions. We have time till 8 o'clock. 5 more.
There is one question from Sheetal Suresh. Your comments on heart failure indication prevention with DAPA. Yes, so supposing as Dr. Tony asked, will you use it as a preventive? Yes, after metformin, definitely the person has got a high risk of atherosclerotic cardiovascular disease. If he's already got an MI, if he's got all the markers of atherosclerotic cardiovascular disease, right? If he's got history of smoking, if he's got a strong family history of coronary artery disease, I will definitely prefer this combination as an add-on to metformin in somebody who is prone to get heart failure. So that is one question. And the Dr. Mohan Verghese percentage cardiovascular mortality reduction in patients on metformin. Oh, this is to Dr. A.K. Singh. Fine, no problem. So I think there are no more questions. Anything in the chat box? No, I don't think so. So I think you can give more time to the next speaker.
So I think it was a wonderful talk. So combination of SGLT2 inhibitors and DPP4 inhibitors definitely should be tried out, especially in those people who have high risk of atherosclerotic cardiovascular disease, especially those who have hypertensive, dyslipidemic, who have a family history of cardiovascular disease. So these people should be given the benefit of SGLT2 inhibitors.
Those who are smoking, cigarette smoking,
cigarette smoking. So it has multiple effects like SGLT2 inhibitors, as sir said, it has good weight reduction. It also has BP reduction by its natriuretic effect. Also, these molecules are cardioprotective and renoprotective. So why not give the patients the benefit of all these?
Exactly.
And when you combine it with DPP4 inhibitors, then you give an SGLT2 inhibitor, the glucosuria, which it stimulates the glucagon secretion.
Yeah.
So in order to reduce the glucagon secretion, we give a DPP4 inhibitor. So this has synergistic effects.
Yeah. As I said, 6 out of 8 of those octet are addressed. So I think it's a wonderful combination, and I use it extensively. So I think I would vouch for this combination. Thank you.
Thank you, sir, for the wonderful talk.
Any more questions from any of the panelists? Sir, Tony sir, we have still 4 minutes left. If you want, you can add on something.
As sir has talked more about dapagliflozin and saxagliptin combination, my personal preference would be empagliflozin and linagliptin because linagliptin is more CV neutral when compared to saxagliptin. I would be a little hesitant, though I have not seen any case clinically. I have never started saxagliptin in my clinical practice because I am a little skeptical based on the study. And SGLT2 inhibitors definitely form my second armamentarium after metformin because it has a powerful ASCVD risk reduction. Okay, and combination of this molecule, it has very low risk of hypoglycemia. And coming to the genital infection which was talked about, I don't think it is anywhere different. The latest meta-analysis, they show that urinary tract infections on people using SGLT2 inhibitors and those not using SGLT2 inhibitors, they are not different. So it may be the inherent immune system defect that diabetes brings along with it that is causing the UTI. And I think, as sir rightly said, that we should stop the drug when there is a urinary tract infection and restart it once the urinary tract infection settles. And also, dapagliflozin, coming to dapagliflozin, along with heart failure, most of it, dapagliflozin can also be given in patients without established diabetes. It has been proven that there is reduction in the cardiovascular mortality in patients even without diabetes. So it is a very good molecule, but saxagliptin I'm a bit skeptical. So I would go for the other combination of dapagliflozin and linagliptin.
Thank you, sir. That was a wonderful session. We will now move on to the next session. For the next session, I would like to invite the chair, Dr. Radhika Sia, Assistant Professor, Department of Pediatrics, Pediatric Nephrology, SAT Hospital, Government Medical College, Thiruvananthapuram. Welcome, Doctor.
Thank you, Dr. Yasin. Welcome to another interesting talk in Jpef 2020. It is the role of keto analogs in chronic kidney disease with diabetes. Chronic kidney disease and keto analogs have always been a sort of controversial topic in nephrology. To talk to us and enlighten us more on the topic, we have Dr. Bharat Shah from Mumbai, who's a senior nephrologist. He's associated with Global Hospital and Global Reliance Hospital, Mumbai. He's a managing trustee, Narmada Kidney Foundation. He's an honorary professor of nephrology, LTMMC Sion. He's a very experienced teacher and nephrologist. He's the president of ISN Westzone, and he has more than 100 publications in various national and international publications. Welcome, sir, to Jpef 2020, and we eagerly await your talk.
Am I audible?
Yeah, now audible, sir.
Audible, sir.
So it's a pleasure to be with this group, and I'm going to talk on a subject which is very important because we see this problem of chronic kidney disease and diabetes very often. I'm going to share my screen now. Fine. So what I plan to do in the next 20 minutes is to tell you about the extent of problem that we see today, what are the treatment options available to us, and then talk about the controversial topic that the chairperson mentioned about, is the role of keto analogs in treatment of patients with chronic kidney disease with diabetes. Let me give you an introduction to the subject of my talk. We all know that chronic kidney disease is increasing all over the world, and it's increasing even more in our country. We also know that the most common cause of chronic kidney disease is diabetes. In fact, in our practice, particularly in a private setup, diabetes accounts for almost 40 to 50% of all cases of chronic kidney disease. In most cases, chronic kidney disease, particularly that due to diabetes, progresses to end-stage kidney disease. Mind you, not all chronic kidney disease progress, but diabetes and diabetic chronic kidney disease is usually a progressive condition, and it eventually culminates in end-stage kidney disease. The treatment options are limited and include dialysis and transplant. And you all know that these options are not easily available everywhere in our country. They are available in major cities, and at the same time, they are very expensive. And therefore, not many people can afford these treatment options. The result is that barely about 10 to 20% of the patients will be able to get this treatment. Even with treatment, the quality and longevity of life of these patients is significantly compromised. And therefore, every effort should be made to prevent or retard the progression of kidney disease. Now, what are the principles of management of any chronic kidney disease? These principles will remain the same irrespective of what the etiology is, and therefore would be applicable even to patients with diabetic kidney disease. The most important thing in treating any disease for that matter is to treat the primary cause. What is the cause of chronic kidney disease? If you can treat the primary cause, you may be able to halt the progression of kidney disease. And this is what we are not able to do with diabetes. We are not able to eradicate diabetes. We are making an effort to try and control, but we can never achieve a glycemic control as in a normal person. And therefore, diabetic kidney disease is most often progressive. Another important thing in the principle of management of chronic kidney disease is a good control of blood pressure. Dietary control, which is practiced by many, is usually in the form of low protein diet. One seldom realizes the importance of prevention of malnutrition, which is a bigger problem as the kidney disease progresses. And everyone thinks that the answer lies in low protein diet, and I will be talking more about this in our talk. Of course, when the kidney disease or the kidney function becomes less, there's an impairment of calcium and phosphorus balance, there is an electrolyte and acid-base disorder, your hemoglobin drops, so you need to correct that. You are at an increased risk of infection, so you need to vaccinate these people well. One very important thing is that if you cannot treat, at least avoid acute insults. So one should avoid painkillers of the class called NSAIDs. Many people feel that if you cannot treat with allopathy medicine, let's try alternative, but that can at times prove to be detrimental. Of course, smoking increases the risk. And very often in my suggestion to patients, I say that they all should be well insured because chronic kidney disease is a very expensive condition to treat. So now with this background, I'm going to talk first about the importance of low protein diet in management of patients with chronic kidney disease. And then I'll come to the main subject for today's talk, and that's about the role of JYOTHYDEV'S. So why low protein diet for patients with kidney disease? We all know that the most important function of the kidneys is to eliminate the nitrogenous waste products which are generated from the proteins that we take in the diet. So obviously, if your kidney function is poor, you are going to accumulate these nitrogenous waste products. By lowering the protein content of the diet, you would reduce the generation of these nitrogenous waste products. Now, this was the basis of using this as a therapy for many years before the availability of dialysis and transplantation. In 1970s, it was realized that low protein diet not only helps in reducing the generation, but it can retard the progression of chronic kidney disease, which means the rate at which your kidney function is going down can be slowed by introducing low protein diet in your therapy. So how does low protein diet retard progression of chronic kidney disease? And this understanding comes from animal experimental studies. And why were these studies done? it was found that some patients with chronic kidney disease continue to have a progressive course even if the underlying etiology had been eradicated, which means that there are certain changes happening intrinsically which are responsible for the progression of kidney disease. So when the number of functioning nephrons, when your functioning renal mass is reduced, there are adaptive changes happening in the kidney. Say, for example, in your office, there are 10 people who are working and 5 people are lost. What will happen? The remaining 5 people will work hard to complete the work that has to be completed. But in the process, they are overworked. They will be able to do the work in the beginning, but over a period of time due to overwork, these people will start becoming sick, and gradually more and more people will not be able to function. So something similar happens with all the organs of our body, and that is what happens even with the kidney, that when the functioning renal mass is reduced, adaptive changes take place. And what are those adaptive changes? This is the glomerular capillary, this is the efferent arteriole, and this is the efferent arteriole. So when the functioning renal mass is reduced, there is an efferent arteriolar vasodilatation, there is an efferent arteriolar constriction, as a result of which in each nephron there is an increase in blood flow, there is an increase in glomerular capillary pressure, and each nephron overworks and there is hyperfiltration. So if you lose 60% of your renal mass, your renal function of your GFR does not become 40%. It will bring about these adaptive changes, and in the beginning, despite your functioning renal mass being now 40%, the GFR would still be 60% or 70% now. But these adaptive changes in the long run prove to be detrimental. So based on these observations, Brenner and his colleagues put forward a hypothesis that when there is a decrease in the number of functioning nephrons, if you continue to take an unrestricted protein intake, it leads to increase in glomerular blood flow, it leads to increase in glomerular capillary pressure, and these adaptive changes lead to glomerulosclerosis. This leads to further reduction in the nephron mass and sets up a vicious cycle where there is a progressive glomerulosclerosis, progressive loss of nephrons, and progression of kidney disease. So this was a landmark study published in New England Journal of Medicine, dietary protein intake, renal hemodynamic changes, and progressive glomerulosclerosis. So how much should be the protein restriction? Theoretically, proteins should be restricted proportionate to the degree of reduction in the number of functioning nephrons or reduction in functioning renal mass. So if you have lost 60% of your renal mass and now your functioning renal mass is 40%, theoretically you should reduce your protein intake to 40%. So for a person who takes about a gram per kg a day of proteins, it should be cut down to 0.4 gram per kilogram per day. But one must understand that proteins are very important for our functioning of body. A person can remain in nitrogen balance with protein restricted to 0.6 grams per kilogram per day, with 50% of protein being of high biologic value. So if we reduce our protein intake to less than this, we will get into negative nitrogen balance. We'll get undernourished and will suffer from malnutrition. The protein intake can be further reduced to 0.3 gram per kilogram per day if you supplement either with essential amino acids or keto analogs of essential amino acids. So this brings us to our today's talk on role of keto analogs. Now, what are keto analogs? Keto analogs are essentially essential amino acids which have been deaminated. So it's a deaminated essential amino acid. Because they do not contain nitrogen, they do not generate nitrogenous byproducts. At the same time, they can accept amino groups from non-essential amino acids and can be rebuilt to corresponding essential amino acid and prevent a negative nitrogen balance. So this is what can be achieved with keto analogs. You have a non-essential amino acid nitrogen, which could have been converted to urea, but this is diverted by the process of transamination, keto analog accepting the amino group, forming essential amino acid and decrease in generation of urea. So let us see the rationale of using keto analogs in chronic kidney disease due to whatever etiology, and it's applicable to diabetic chronic kidney disease also. So because keto analogs do not contain nitrogen, they do not generate nitrogenous waste products. Because they accept amino groups from urea generating non-essential amino acids, they get rebuilt to corresponding essential amino acids and at the same time reduce urea generation. This allows the patient to remain in nitrogen balance despite taking a very low protein diet. Further, calcium content of keto analog preparations and their phosphate binding capabilities allow even better correction of mineral metabolism abnormalities. So how should keto analogs be used in our clinical practice? It must be realized that keto analogs are deaminated essential amino acids. They are not a medicine. Their use is only when your protein intake is reduced. So if you do not reduce your protein intake and if you give keto analogs, it's a waste of money. And the recommended amount is 1 tablet per 5 kg body weight. So for a 60 kg person with a very low protein diet, you should be supplemented with about 12 tablets of keto analogs. So this is an example to show you how keto analogs are used in clinical practice. They are used as if it's a medicine without an advice for a very low protein diet. And this is what should not happen in practice. So keto analogs should be used very judiciously because they are expensive. It must be realized that each patient is different and dietary protein requirement will vary from case to case depending on the nature of underlying kidney disease. So there are some patients who will not need it. It depends on the appetite of the patient and nutritional status of the patient. So if someone has poor appetite or poor nutritional status, you can't put them on a very rigid diet. It would further affect their nutrition. This is an example of a patient whom I saw in 2014 with a creatinine of 2 milligrams per deciliter. He was hypertensive for 15 years. His routine urinalysis was unremarkable. He had very little insignificant proteinuria and he had borderline small kidneys. Should he be on a low protein diet? No, he doesn't need to be on a low protein diet. If you see, for last 10 years, he had a very stable creatinine until he saw me. So when I saw him, I allowed him to continue his regular diet and he continued to remain very stable. So a patient like this, who is very stable naturally, one may not need to use that. It is also not useful when you have a rapid decline in kidney function. So this was a patient who was stable for quite some time. At this point in time, he was lost to follow-up, took some alternative therapy, and had a very rapidly declining kidney function. So when you have a rapidly declining kidney function, a dietary modification is not going to be very helpful. So here is another scenario where it is not going to be helpful. So although he was started on keto analogs, he continued to have a progressive rise in creatinine. But this is an example that I would like to show. This was a neurophysician who saw me when he was 73 years old back in 2006. And at that time, he had a creatinine of about 4.5. And he was in states and he was told that he should prepare for dialysis, which is not wrong. if someone has a progressive kidney disease. And we found that he did not, he had a very slowly progressive kidney disease. We put him on keto analogs, and you can see that over the last 14 years, this man has remained completely stable. So patients who have a slowly progressive kidney disease, not much of proteinuria, are the ideal candidates who will really benefit from keto analogs. It must be remembered that when you prescribe someone a diet, it should not cause worsening of renal nutrition. In most cases, as the kidney function declines, you will see their nutritional status worsens, the body mass index worsens. As they progress from stage 3 to 4 to 5, you can see over here that as the creatinine clearance drops, there is a progressive decline in your body mass index, and this becomes precipitously worse in stage 5 of chronic kidney disease. And worse nutritional status has a worse prognostic implication, and that should be avoided at any cost. Several studies have shown that in patients with diabetic nephropathy, low protein diet significantly reduces the risk of decline in glomerular filtration rate or creatinine clearance. And a recently published study from Italy showed safety and effectiveness of a low protein diet supplemented with keto acids in diabetic patients with chronic kidney disease. And they found that in diabetic CKD patients, a low protein diet supplemented with keto acids improves uremia and diabetes. I'm not sure if it can improve diabetes. Diabetes may improve due to progression of kidney disease, causes sudden decline in body weight if you don't take care of the energy, but it does remain stable if you take care of adequate energy intake, and does not have a negative effect on the muscle mass and fitness. So in diabetic CKD patients, low protein diet with keto acids is safe if adequate nutritional status is monitored. So what is the approach that I would suggest? I would suggest that a low protein diet or a supplemented very low protein diet should be prescribed to those with proteinuria like diabetic kidney disease, which is slowly progressive from an early stage. The appetite and nutrition status is good. A low protein diet or a very low protein diet should be prescribed even at an advanced stage if the patient has a good appetite and nutrition status, because it will reduce the generation of uremic toxins. It should not be prescribed if the renal function is rapidly declining. It should not be prescribed to those with poor appetite and weight loss and poor nutritional status. And if
Excuse
someone
me,
is
sir,
likely to
you're
go for
almost about to finish. Your time is almost about to be over, sir.
So this is my summary slide.
Okay, sir. Thank you.
Keto analogs allow subjects to remain in nitrogen balance with very low protein diet. This can retard the rate of progression of chronic kidney disease in those with slowly progressive chronic kidney disease and reduce the generation of nitrogenous waste products. And this in turn can delay the need for renal replacement therapy. They should be used judiciously in right dose, 1 tablet for 5 kg body weight, only with very low protein diet. Thank you. And I would be happy to take the questions if there are.
Do we have time for questions?
Yes, ma'am. Obviously, we have time for questions. We have almost 10 minutes for questions. We can take any questions.
So one of the questions which have come up is when to give taurine cysteine combination. Can it be used along with keto analogs?
So I have really not been fond of taurine cysteine combination. I don't know of any study which has shown it to be useful in chronic kidney disease.
Exactly, more in AKI probably.
This drug is available by a name called Nephrosave, and people feel that it saves your nephrons. It's a waste of money.
Yes, sir. And does the stage of CKD, the GGFR, make any difference when you prescribe alpha keto analogs?
So I would think that if someone like diabetic chronic kidney disease, we know that they are going to progress. There is no turning back. And I would think that implementing a strict diet right from an early stage of diabetic kidney disease will significantly delay the need for renal replacement therapy. So it should be introduced at an early stage. Unfortunately, what happens is that doctors start introducing this in stage 4 and stage 5 when they start beginning to have worsening of the nutritional status. That would be a wrong thing to do. It would be right to introduce at an early stage.
Early as in stage 2 or stage 3, probably?
That's right. That's right.
And the main problem with this is the pill load is very high because you need to give one tablet for every 5 kg. So what do you think of like acceptability in terms of the number of pills?
So pill load is high, which I think is manageable. My 73-year-old neurophysician who is now 87-year-old is still managing with that pill load. But what is difficult to manage is the pocket load. It's a huge burden on the pocket.
That was my next question actually.
It's a big load on the pocket. But I don't think if it can save our kidney and if it can delay the need for renal replacement therapy, it is a big thing.
Yes, it is. And there's another question is whether I can reduce the microalbuminuria also.
Sure. We do know from the studies that in patients with proteinuria, by reduction in protein intake, you can reduce the degree of proteinuria. And any therapy which can achieve a reduction in proteinuria is going to preserve the nephrons better. And that is the reason why I say that we should start using it from an early stage of kidney disease.
Another question that has come up is there any role for pentoxifylline in delaying diabetic kidney disease?
So this was a study done by one of my fellows, and he did find, but it was a short period of follow-up, and he did find that pentoxifylline does help in reducing proteinuria. It was only a 6 months of follow-up, and then availability of pentoxifylline became a problem, and therefore I could not continue it for many of my patients to see its long-term benefit. But yes, in the short term that we looked at, it does reduce proteinuria and helps, and thereby would help in retarding the progression.
Okay. Thank you, sir, for that lucid talk. If you have any more questions from the other panelists, we can take them.
How many minutes we have?
We have 5 minutes left. We have 5 minutes left. Any more questions from the other panelists? Yeah.
I would be happy if there are any questions from the panel. Low protein diet is very widely practiced, but it is indiscriminately practiced. And it is very important that it is practiced in early stages rather than in late stages. Because
before you prescribe a low protein diet,
yes,
do you actually look at the diet of the patients and see how much protein they are taking regularly and then prescribe it, or you just prescribe it for everyone?
absolutely. So we did mention about this in our article in Jpef back in 2000, that we should not be indiscriminately advising a low protein diet. We should do a baseline estimation of the protein intake, and we do it with an objective method. We make the patients do 24-hour urinary urea nitrogen, and based on that, we estimate what their protein intake, and depending on that, we advise them on a diet. So every patient of ours who goes on a low protein diet or on keto analog supplemented very low protein diet does periodically do, periodically means every 3 monthly we do 24-hour urinary urea nitrogen to see whether the patients are compliant or not.
And sir, what do you think is the role for alpha keto analogs in children with chronic kidney disease? Because usually in children, we don't restrict proteins even if they are in advanced chronic kidney disease because you have to account for their growth. So do you think alpha keto analogs will play a role in management of pediatric chronic kidney diseases?
So Radhika, actually you would be an expert in this as a pediatric nephrologist. I am not the right person to opine on this, but logically I would think that children have to grow and one should not try to restrict. In fact, eventually when they progress to end stage, the best treatment for them is going to be transplant. So if a child were to be with me, I would just allow them to eat their regular diet, let them grow. And when they progress to end stage, I would do a preemptive kidney transplant for them. We stress a lot on preemptive kidney transplant.
Actually, that's what we do in practice also. We ask them to take a normal diet. And actually, we even need to supplement protein in children when they are progressing in their chronic disease because their appetite is very low. So they actually don't meet their normal protein requirements. So we actually do the other way around. We don't restrict. We actually supplement proteins for children.
Absolutely. That's right. That's right. So one of my colleagues, Dr. Kamini Mehta, who is a pediatric nephrologist, you may know her. She had a very small child, maybe 1 or 2 years old, who was severely malnourished. She prayed through Riles tube, improved the nutritional status, and then took that patient for transplantation.
Yes.
That child is doing extremely well.
Okay, that's a very common scenario because the most important limiting factor for transplantation in small children is actually their weight.
Right.
So we need to sometimes resort to tube feedings and all.
Absolutely.
I think we have come to the end of questions. I can't find any more questions from the audience.
Thank you, Radhika madam. Thank you, Parasha.
Thank you so much, sir, for that excellent talk. It's very comprehensive and very clinically oriented.
Thank you. Thank you for the opportunity.
Okay, we'll be moving on to the next session. To chair the next session, I would like to invite Dr. Riaz I. He is the Associate Professor of Department of Pediatrics at Government Medical College, Thiruvananthapuram. He is also the Medical Officer of Pediatric and Adolescent Diabetes Clinic and also the MITAI program. Welcome, sir.
Thank you for the opportunity. Now we are moving on to the arena of pediatric diabetes, and almost always we think pediatric diabetes is only type 1 diabetes, but it may not be so at many times in our practice. So we have Dr. Parvati, consultant pediatric and adolescent endocrinologist at Aster Hospital, Kochi. She graduated from Trivandrum Medical College, did her MBBS, MD, and DCH from Trivandrum Medical College, and did a fellowship postdoctoral fellowship in pediatric and adolescent endocrinology with Dr. Raghupati at the prestigious Institute of Indira Gandhi Institute of Child Health at Bangalore. And I think she is a consultant who is having a large number of diabetic children on follow-up. And we would listen to Parvati on having surprises when we see children with diabetes. Over to you, Dr. Parvati.
Thank you, Riya sir. Shall I share my screen?
Yes, please.
Thank you, Riya sir, and I thank JYOTHYDEV sir and the whole team for this opportunity. So this is I suppose this is the last talk of today, and I have 15 minutes. I'll quickly take you all through an interesting story of a diabetic child who was referred for evaluation. So the topic is how to spot the zebras among the horses. So the background of this talk is that, as we all know, type 1 diabetes definitely is the most common type of diabetes in childhood. We have increasing number of type 1 diabetes being detected, especially in India. As per the last IDF Diabetes Atlas 2019, we see that there is around 15,000 cases of new type 1 diabetes coming up in India. And we also know that there is an increasing rate of type 2 diabetes. because of the obesity epidemic that is happening even in adolescents. And also we need to know about the recent surge of monogenic diabetes. Monogenic diabetes, most commonly it's a neonatal diabetes and also the MODY. So it's very important. The simple message of my presentation would be how to differentiate between the types of diabetes and how it is important in planning the therapeutic strategy and prognostication. So I'll take you through the case. So this is a 11-year, 4-month-old girl who had complaints of not gaining weight and height as her peers. So there's a common complaint with which children come to the pediatric OPD. Taking a quick look through her history, there is no history of any recurrent infections, any history of diarrhea or recurrent fever or polyuria or polydipsia. She's the first child of a non-consanguineous parentage, and she was born term with a birth weight of 1.75. So she was a term SGA IUGR baby. There was no postnatal complications. There was no history of any significant illness in the past. She had attained all her developmental milestones for her age as per the criteria, and she was immunized for age. There's a family history of diabetes in her paternal grandmother, which as per history was more suggestive of a type 2 diabetes. So this was the these were the reports with which she came. So she was found to have glycosuria. While she was being evaluated for her failure to thrive, a simple urine routine showed her urine glycosuria, and from there, further evaluation was done. Her serial blood sugar monitoring was done, which was found to be in the range of 200 to 300 milligram per deciliter, and her HbA1c was found to be elevated, and she was diagnosed as type 1 diabetes, and she was advised to start on insulin as early as possible. So the parents were definitely, we all know type 1 diabetes diagnosis comes as a shock to the parents or the family. So they went for a second opinion, and from there also they were advised to start off insulin. They did some further investigations also, like so the HbA1c was 8.2. They also did a GAS65 antibody. This is a common antibody that we do in a type 1 diabetes that was negative. And the other preliminary investigations, including a liver function, renal function, thyroid function, blood count, all were normal. She also underwent a karyotyping test because, as you know, in all short children, we do a karyotyping to rule out a Turner syndrome, which came to be normal. And echocardiograph was also done. So these were the investigations which were done from outside. And she got advice to start insulin as early as possible. So when she came to our hospital on examination, she had a characteristic dysmorphism. She had a triangular facies with deep set eyes, hypoplastic alanaceae, overhanging columella of the nose, and a small chin with a dimple. And this is a picture of the child. I've not put the face. So she had a characteristic finding, which was the acanthosis nigricans, which was severe in all the flexures. And she also had lipoatrophy of arms and face. She had a pointed chin with triangular facies and a characteristic dimple, which you can even make out from the lateral view. So coming to the growth, it was a complaint which the parents took to the hospital, to the multiple hospitals. So this child, the weight, this is a growth chart. This is the IAP 2015 growth chart, the girl's growth chart. And this is the third centile. You can see the weight is below the third centile. Her height is also well below the third centile. Her pubertal status, she had started her puberty with a breast age of 3 and pubic head 2. Her bone age was also done in view of the short stature. Bone age was 10 to 11 years. So her systemic examination was otherwise normal. So finding these atypical features of acanthosis nigricans in a child who was failing to thrive, or in a non-obese child, we plan to do a blood sugar, fasting blood sugar with the corresponding insulin levels and C-peptide. We found that the C-peptide level was normal and the fasting insulin was definitely higher. So these features were definitely suggestive of an insulin resistance in this 11-year-old child who was evaluated for failure to thrive and found to have a elevated blood sugar and elevated HbA1c, which is not a characteristic feature in type 1 diabetes. So from there, we went ahead with the further investigation. So these were the atypical features which suggested that this is not a type 1 diabetes. The absence of classical symptoms. We all know that a type 1 diabetic kid usually presents with a an abrupt onset of symptoms, polyuria, polydipsia for probably 2 to 3 weeks, weight loss, and the child is highly prone for ketosis, most of them present with a diabetic ketoacidosis. So this child, there was no polyuria, polydipsia. The classical symptoms were definitely absent, and there was no significant weight loss. The only complaint was that the child was not gaining weight. And features of insulin resistance without obesity. So we know that the features of insulin resistance, the clinical features that we look for are acanthosis nigricans, maybe polycystic ovarian syndrome. All these are usually common in an obese adolescent. So this child was not obese, but the features of insulin resistance were present. This child had severe acanthosis nigricans and a characteristic dysmorphic facies with a failure to thrive and stunting. All these prompted us to think against type 1 diabetes. And so at this point, we were thinking of any insulin resistance syndrome. Typical of insulin resistance syndrome, child regular blood on diet modification, started on an insulin sensitizing drug metformin, and meanwhile, family counseled for a genetic analysis. And so, am I audible, Riya sir?
Now you are audible. You are audible. Please.
Okay. And she was started on metformin, and we counseled the family for a genetic analysis. And in 4 weeks, the genetic reports came to our surprise. That is, she was positive for heterozygous mutation in PIK3R1 gene, which was suggestive of a insulin resistance syndrome and a very rare syndrome called SHORT syndrome, which is usually autosomal dominant in inheritance. So what is SHORT syndrome? SHORT syndrome, it is called SHORT syndrome. It is an acronym. I'll come to that. So it's basically because of the mutation in PIK3R1 gene. PIK3R1, it stands for the phosphatidyl inositol 3 kinase activity. And that gene is required for transmission of blood which is required for the insulin-mediated glucose uptake. So this pathway is abnormal, and that leads to insulin resistance and SHORT syndrome. So it is autosomal dominant in inheritance. So the acronym SHORT stands for short stature, H for hyperextensibility of joints or inguinal hernia, O for ocular depression or deep set eyes, which this child had, R for an anterior chamber anomaly, Rieger anomaly, and subsequent glaucoma, T delay. So this is a classical acronym SHORT syndrome, but always children with SHORT syndrome need not have all these findings. I've just highlighted the finding which our kid had, short stature and ocular depression. Rieger anomaly, teething delay, hyperextensibility was not present. The other features, the other characteristic features, even though the acronym mentions the short features, these are the other classical features which have been found to be associated with the case cohort of SHORT syndrome when you search the literature. So other features include a triangular face, a small chin with a dimple, lipodystrophy, abnormal position of the ears, hearing loss and delayed speech, IUGR. As you might remember, our child was 1.5 kg, and classical insulin resistance and diabetes mellitus. So these highlighted features were present in our case. And these are the classical, this is the classical phenotype. These are multiple case reports of SHORT syndrome. And our child also had a classical facial disorder, the facies, the pointed chin, the hypoplastic area, and a mild mid-facial hypoplasia with a deep set eyes. So you can see the different cases of SHORT syndrome published so far. I'm just taking you through what are the positive findings we had. This child, our case had short stature, low body weight, a triangular face, a prominent forehead, a small chin, hypoplastic LNSA, large mouth with thin downturned lips, and these were absent, as I mentioned. And a child also had lipoatrophy, a normal intelligence, diabetes mellitus with an insulin resistance. So how did we manage our case? So basically, as I mentioned, this child was asked for a lifestyle modification, dietary modification with proper sugar monitoring. And we had already started her on metformin, initially started on 500 OD, and now the child is on a BD dose of 500. And as to start with, as you remember, the HbA1c was 8.2%, and now it has come down to 6.1% with medication as well as the dietary modifications, and her sugars are all well controlled. Most of her postprandial sugars are in the range of 120 to 140, and fasting sugars are also okay. Occasional rise up to 200, especially when she has a cheat in her diet. So this is basically the point I would like to raise in this presentation. So when do you suspect other forms of diabetes in children, especially when there is an autosomal dominant family history of diabetes? So we all know Modi presents with a early onset diabetes, and usually the adolescent or the child would be non-obese with a characteristic early onset of diabetes in the family. Presence of syndromic features as in our child with a characteristic facial gestalt, insulin resistance features without obesity. If there is associated deafness, optic atrophy. We all know the classical Didmore syndrome, which presents with a diabetes mellitus, diabetes insipidus, optic atrophy and deafness. So all these should make us think about a alternate clinical diagnosis of a diabetes. And the features of insulin resistance, it could be acanthosis nigricans or polycystic ovarian syndrome. And requirement of a very little insulin, or there is no requirement of insulin even after the usual duration of the honeymoon phase. And exposure to certain drugs. For example, if you get a child from a pediatric oncology ward, definitely with the high sugars, you would be thinking more in favor of a drug-induced diabetes, because L-asparagine, steroids, all these can induce diabetes. And when the onset of diabetes is below the age of 6 months, you would definitely think about a neonatal diabetes, which is a characteristic example for a monogenic diabetes. And we know genetic study is very important in a neonatal diabetes. So the take-home messages from my presentation and the case which I see is type 1 diabetes is not always type 1, but still we know that type 1 diabetes is the most common form of diabetes in children. But especially when you have clinical clues against type 1, you should always work up the child in detail and plan genetic evaluation if needed. You have to consider insulin resistance if clinically suggested features like acanthosis nigricans or polycystic ovarian syndrome are present. It's very important in identifying the type of diabetes, whether it's type 1, type 2, monogenic diabetes or insulin resistance. And the importance lies in the fact that it helps in appropriate management of the case and also prognostication. And if possible, if financially feasible, a specific molecular diagnosis is important for proper management, genetic counseling for the family, and testing of other family members. Thank you.
Thank you, Parvati.
Yes, sir.
It was an excellent case, and the presentation was very crisp and clear. When you see a child with diabetes, we have to think about other causes of diabetes other than type 1 also. That was the point which was highlighted. And as you clearly told that it is important because management can also differ in some cases. So I think we have a little more time. Can you tell us something about neonatal diabetes? Because that will be something people may not be very.
Yeah, neonatal diabetes, as I mentioned, it is a monogenic diabetes. We all know type 1 diabetes, type 2 diabetes, it's polygenic. Neonatal diabetes usually occurs due to certain genetic mutations in the beta cell. For example, you have the potassium ATP channel, and the commonest mutations are a KCNJ11 or ABCC8 mutation. Another important thing is that genetic analysis becomes or is of prime importance when you get a child or an infant with diabetes, especially less than 6 months, because that determines the mode of management. Giving insulin to a young baby less than 6 months, we know that there is a definite risk of hypoglycemia, and also administering insulin is difficult for a young baby who's on breastfeeds, controlling the blood sugar. So the importance of neonatal diabetes is that if you identify mutations which are responsive to medical therapy, especially sulfonylureas, the treatment can be switched over from insulin to sulfonylureas. So it's very important to consider genetic tests, especially in neonatal diabetes, in infants who are presenting with diabetes less than 6 months of age. And also there are a lot of conditions or mutations based on the clinical features which will help you to prognosticate the condition. For example, if child who's coming with a recurrent diarrhea, who's presenting with diabetes, diabetic ketoacidosis, developing an enteropathy, there is a high chance for IPEX syndrome, which is associated with neonatal diabetes. Condition associated pancreatic agenesis associated with another genetic mutation. So it's very important to do the genetic mutations so that you can prognosticate and give appropriate management and avoid insulin therapy and control sugars with a sulfonylurea in positive mutation cases, especially ABCC8 and KCNJ11 mutation. Anything to add on, Riya sir?
Thank you. Like I know that you had a case like that also. Okay. And
Yeah, we had a case of like this.
one important thing which is very important is like in the initial management of diabetes, most of the time we may be starting with insulin in children, be it type 1, type 2, or other MODY or anything, because when the child comes with a glucotoxicity, when there is hyperglycemia, the first treatment is always insulin. But as Dr. Parvati explained very well, we have to look for the cause, because in a significant proportion of cases, we may be able to shift the treatment from insulin to oral hypoglycemic drugs, which will be a very, what you call, very welcome move for the parents, because it's very difficult to manage young children with insulin. So I don't find any questions, Dr. Yasin.
Okay, sir. I think so. That would
Is
be.
there any questions? Otherwise, okay. So
No, sir.
I think most of the queries may have been answered by your talk itself. So I thank again, once again, to Dr. Parvati for enlightening us on this topic, and also JYOTHYDEV sir and his vibrant team for making us a part of this wonderful experience which he religiously conducts every year. And I thank in a very different platform, even when the pandemic is having its rage. Now we are spreading knowledge regarding diabetes. Hats off to you, sir. Thank you. Thank you.
Thank you very much, Riyas. Jyoti.
Thank you, Parvati madam. Thank you, Riyaz sir. That was a wonderful presentation, ma'am. So with this, I would like to conclude today's programs. So it was another successful day of JFF. On behalf of the JFF team, I would like to thank all the participants, all the speakers, all the chairs who had participated today, and it was a very wonderful day.